जूम लिंक है?
ना ना वो अपने मुझे तो आपका सेशन रिकॉर्ड करा के लीव कर दो यार, स्टॉप शेयर करके लीव कर दो। हाँ
नहीं तो
अरे अभी जब लॉगिन करेंगे तब
अरे हम उनको बता देंगे ना उनको
अरे
वो कर देते हैं ना।
नहीं होस्ट नहीं है ना अभी,
पोस्ट करवा लेते हैं।
हाँ 24 कह दिए
तो वही करूँगी।
हेलो सीजीआर वाले को होस्ट बनाओ देना। नहीं वो वाला सेशन है ना, तो उसमें रिकॉर्डिंग पॉज कर देंगे ना अभी।
देखो पेन ड्राइव दिखा तो मेरे को खुद करने देंगे क्योंकि
हाँ सीजीआर वाले को
हाँ आ गई। अभी आती हूँ। कहाँ है? पीपीटीज, हाँ ये नहीं है। बहुत टाइम लग रहा है। कोई खाली पेन ड्राइव चाहिए, भरी हुई है ना मेरी पूरी। नहीं ऐसे अजीब लगेगा, ये आता रहेगा। नहीं ये नहीं, अच्छा ये आपका ही है। हाँ 10th Feb ना, हाँ यही है। किसी को बोल दूं खाली पेन ड्राइव, किसी हमारे यही है ना।
क्या देखो
ये तो आ गया सर। बस पेन ड्राइव में इतनी जगह है नहीं ना कि इतने सारे दिख रहे, कॉपी नहीं हो रहा, तब से सर्च ही कर रहा है। कॉपी कर लेती हूँ।
अच्छा
एक बार रन करके देख लूं आपका। कौन आ गया? ये कौन आ गया?
नहीं प्रेजेंटेशन
वही तो है, यही तो यही जो डिसाइड किया था, मैं बताने में स्टार्ट करना है।
मैंने इसलिए क्या किया है
कर लिया। नहीं भी haven't. बोल सकती हूँ कि this brings us to the end of the ceremony of the event. Now I would like to request. ये मैंने सोचा था कि एब्रप्ट लग रहा है पढ़ने, Good morning, everyone. We welcome you once again to the 14th Foundation Day and the first alumni meet of the Department of Pulmonary Medicine, SGPGI. Today marks a significant occasion as we gather for the first alumni meet of the Department of Pulmonary Medicine, which was established way back in the year 2006. Over the years, our department has grown remarkably, evolving into a renowned center of expertise in the field of pulmonary medicine, receiving referrals for common as well as rare respiratory disorders from the entire UP and adjoining Bihar, Madhya Pradesh, Orissa, and Nepal.
To commemorate this milestone, we have an exciting lineup of academic sessions planned for our audience. Given that the burden of airway diseases has increased manifold over the last few years and forms a chunk of our OPD services, our scientific sessions will delve into various aspects of airway diseases and the management. Now, I would like to invite Dr. Prashant, sir. Dr. Prashant AP. And it's a matter of great pride for us that he's actually the first DM fellow from our institute to deliver his talk on the first session.
The first session will be chaired by Professor Rajiv Garg sir, Professor, Department of Respiratory Medicine, KGMU, Lucknow. Professor Ved Prakash sir, Professor and Head Pulmonary Medicine Department, KGMU, Lucknow. Dr. Abhinav Chaudhary sir, Consultant Pulmonologist, Lung Heal Clinic, Ayodhya. And Dr. Rakesh Chaudhary sir, Consultant Pulmonologist, Sahaj Hospital, Lucknow. I request all the chairpersons to kindly please occupy their seat of prestige on the dais. The first session will be taken by our very own alumni, Prashant sir, who has recently passed his DM, and we are very proud that this is the first session that he'll be taking. And the first session will be on the topic of differentiating asthma from COPD phenotypes, and it will be a case-based discussion.
Good morning, everyone. And at the outset, I must congratulate all of the Department of PCCM, SGPGI for conducting its first alumni meet. And to begin with, there's a slight change in the program, which I understand, and we straight away going to start the case-based discussion. And to start this, we have Prashant, their role assistant professor, who is the DM fellow here. Prashant, go ahead.
A very good morning to all my respected teachers, colleagues, and my dear friends. At the outset, I'm really thankful for this opportunity, and I really feel honored and blessed for this opportunity. So, without wasting much time, the topic for the first discussion is differentiating the asthma and COPD phenotypes. So, I will start with a case scenario. We had a 66-year-old male who is a carpenter who presented with complaints of breathlessness for the past 10 years and cough with expectation for 10 years. The breathlessness was insidious in onset with multiple exacerbations and ER visits requiring oral corticosteroids. And he was not having any comorbidities, or there is no any relevant family history. He was a chronic smoker with a significant smoking history of a pack years of about 25. And the general examination and vitals were fairly normal, except for in the respiratory system, he was having bilateral polyphonic bronchi. So I would like to ask our respected panelist, Ved Prakash sir, in the routine clinical practice, how will you differentiate between asthma and COPD, and how will you go ahead investigating those cases?
As the asthma usually present in childhood or adolescent age group, having episodes, attacks of dyspnea, coughing, wheeze, chest tightness with aerosol variation, history, seasonal variations, history of atopy, and significant diurnal and day-to-day variation. Nighttime waking with breathlessness and coughing. So on the other hand, COPD is usually occurs beyond fourth or fifth decade. However, now we are having the cases beyond 30 also. Mostly due to significant exposure to cigarette smoking, biomass fuel exposure, symptoms of chronic productive cough, dyspnea, which is insidious in onset and gradually progressive. So, how we diagnose? The diagnostic workup include chest X-ray, spirometry, and routine blood investigations, at least CBC, to rule out anemia as a cause of breathlessness. And in X-ray of COPD patients, we may have features of hyperinflation of lungs, flattened diaphragm, and wherein asthma, a fairly normal chest X-ray can be seen. So X-ray also necessary to exclude the occasional alternative diagnosis that may mimic asthma, like mediastinal mass with tracheal compressions, heart failure, especially in middle age group. So these are the how we can differentiate between the two diseases.
Thank you so much, sir, for that elaborate answer. So basically, I mean, there are various clues for the differentiation of asthma and COPD, as sir has already elaborated most of the points. So we went ahead with the routine blood investigations. It was fairly normal. And the chest X-ray showed bilateral hyperinflation, and the PFT showed a moderate obstruction without any bronchodilator reversibility. So, Rajiv Gaur, sir, so what diagnosis will you consider in this case?
This patient, you said patient is 60 years and above,
66-year-old, yeah.
60 years and above, and symptomatic for more than 10 years.
Yes.
Just I would like to know whether in interval period between these, say supposedly patient is symptomatic throughout the year or patient has the seasonal variation.
He was symptomatic throughout.
If the patient is say symptomatic throughout, then I would first keep the diagnosis of a COPD with the current scenario which you are giving. But just in a say, if you see an X-ray only, then there is hyperlucency is there in the upper zone. So further, we would like to investigate this patient, since patient is having repeated exacerbation. That's how I would like to go ahead with further evaluation in this patient.
So, for this patient, the initial diagnosis we made was that of obstructive airway disease, probably COPD and we prescribed him on LABA and LAMA, and also advised smoking cessation. Now, Rakesh sir, in your practice, what is your opinion regarding spirometry as a tool to differentiate between asthma and COPD?
Actually, the spirometry is the very specific tool to differentiate, to diagnose the obstructive airway disease. Because although the diagnosis of the COPD and asthma is the clinical scenario and history is very important to diagnose or to differentiate either it is in the favor of asthma or COPD. But finally, the diagnosis which help us is the spirometry. If we are getting the reversibility test, bronchodilator reversibility is 200 ml and 12%, then definitely is favor more in the asthma. If you're not getting, although there is the patient of COPD which we are getting the reversibility, but the most of time in asthma reversibility is the part there, and in COPD case there is the less reversibility. So definitely tool help us, spirometry help us with the clinical history, either this patient is in favor of asthma or COPD.
Thanks, sir. So yeah, the bronchodilator reversibility, I mean, it can be present in COPD as well, as the ECLIPSE study I've showed. About 24% in their cohort were having bronchodilator reversibility, and it only bronchodilator reversibility only suggests that they better response to the inhaled corticosteroids. And coming back to our case, so the patient who went with the prescription of LABA and LAMA came back to us after 4 months with worsening of symptoms. He was having 2 ER visits in between, though he was having good compliance with the treatment and a proper inhaler technique. And there was no ongoing history of any exposures or substance abuse. So, Dr. Abhinav, at this scenario, how will you proceed?
So like patient is already on LAVA, LAMA, and symptom, if the symptom is not improving, then we have to confirm the diagnosis by taking the history again. And then we have to rule out the other things, like there is some infection or is there any comorbidity that we have to take care of that things. And then we have to investigate the few other things, like there's blood eosinophilia, or if possible, then sputum eosinophils and other things also.
Yes. So revisited the history and now to reconfirm the diagnosis, and we try to rule out the infection, comorbidities, and other complications, and the basic investigations of blood eosinophils, sputum eosinophils, and HRCT thorax was planned. So this was the HRCT thorax with showing the upper lobe showing significant emphysematous changes. The can very well appreciate the paraseptal and central lobar emphysema in these cuts. And to our surprise, the absolute eosinophil count of this patient came more than 1,000, though in the initial investigation, it was in the normal range. And on revisiting the history, he gave history of recurrent episodes of rhinosinusitis from the age of 20. So we went ahead with FeNO, which showed 38 and the IG value of 876. So, where, sir, at this scenario, would you like to, how will you, modify the diagnosis with this light of these investigations?
Yeah, so this patient with recurrent rhinosinusitis is having high absolute eosinophil counts, suggestive of eosinophilic inflammation. And FeNO greater than 50 ppb in adults or greater than 35 in children, suggestive of eosinophilic airway inflammation. So value of FeNO between 25 to 50 ppb in adults, 20 to 35, 20 to 35 ppb in children should be interpreted cautiously with reference to the clinical situation, like symptomatic or on off therapy, current smoking status. So given the history of rhinosinusitis, high eosinophilia and total serum IgE, FeNO value of 38 can be due to atopy, eosinophilic airway inflammation. So collectively, these investigations are suggestive of atopy or allergic rhinosinusitis having raised biomarkers of type 2 inflammation. So this is my take.
Sir, Raju, sir, any other comments from your side?
Basically, this patient is of COPD with having a modest history of smoking, along with, say, eosinophil count. The other thing is, whenever we see such type, when we come across with such type of patient, we have certain things in mind when we are practicing here in, say, our country, whether it is because of really some hypereosinophilic lung disease or not hypereosinophilic, whether this eosinophilia is because of some other tropical disease or not. So these things crop up in our mind, and we should be aware of those things in our mind when we, because patient is having, say, emphysematous changes. There's no doubt about that. Patient is more than 60 years of age. Patients even say, but at the same time, FeNO is, yes, one good tool, which is showing the raised value as far as eosinophilic lung disease. So what I would say keep this patient, definitely patient is having, say, COPD component along with some eosinophilic inflammation also. For further investigating this patient, definitely it's not on a routine basis, sputum eosinophilic count, it should have been done. And you should have gone, we can go ahead with, say, serum IgE level or other thing to rule out, say, inflammatory, rule in rather, say, eosinophilic inflammatory disease in patient, in background history of, say, COPD.
Okay. So moving ahead, so as we know, asthma and COPD, it is no longer considered as a single disease. It is highly heterogeneous, and there comes the importance of phenotyping. Phenotype, as we know, is the observable properties of an organism that are produced by the interactions of genotype and environment, and mainly classified based on the triggers, patient characteristics, and clinical presentation. And endotype is the biological pathway which is identified and explains the observable properties of phenotype. So, in the routine clinical practice, what is the importance of phenotyping? Raju, sir?
Phenotyping, as you all understand, it's in the observable characteristic. Observable characteristic, when I say it is a mix of, say, genomics, that is the genetic makeup of that patient, with, say, its interaction with the environment and their clinical manifestations. Say, that makes what the phenotypic characters are. Then, but characterizing phenotypically many a times is not, say, sufficient, because where various pathobiological mechanism. There are various other things which you call the endotypes. So this is the era when we are talking today, when he's standing in 2024, it's the era of say, precision medicine. So yes, definitely we need to characterize these subset of the patient, say different, say subset, whether which phenotype of this patient is. So definitely there is importance of phenotyping in obstructive airway disease.
Yes. So as sir has already elaborated, it is no more a single umbrella of disease. Now the one size fits all or therapy, that concept is no longer valid. So based on the various features, the patient can be stratified to various phenotypes, and then we try to identify the endotype, and based on that, we will go ahead with the target therapy for the patient. So in the phenotypes of asthma, it is mainly based on the T2 inflammation, the T2 high phenotypes and the T2 low phenotypes. The T2 high phenotypes include the early onset allergic asthma, late onset eosinophilic asthma, and the aspirin exacerbated respiratory disease. And the less studied or the T2 low asthma, which includes the obesity associated, smoking associated, and the very late onset asthma. So in order to identify the endotypes, we have the T2 high biomarkers, the biomarkers which are basically the indicator of a normal biologic process, pathogenic process, or pharmacologic response to the therapeutic intervention. So the widely used ones are the sputum eosinophils, peripheral blood eosinophils, serum total Ig, and FeNO. And the various others are in the pipeline like periostin, dipeptidyl peptidase, and urinary LT4. So, Rakesh sir, according to you, what are the challenges do you think you face in diagnosing eosinophilic inflammation in Indian scenario?
In Indian scenario, when you are taking the history, almost this is that like this patient is the more than 60-year of age, and by characteristic, by his history, is the smoker. But sometime we will get the same time we will get the exacerbation, like the change with the season and all this. So there is the mixed picture with the like allergic asthma is overlapping with the COPD. So definitely, if you are not getting the eosinophilia in the DLC, and we are not getting IG level high, that there is the difficulty to there is challenge to either we should keep in mind to either is the overlap or not. So sometimes it's very difficult to diagnose either there is the overlap or not.
So as Raju sir was also explaining, there is high incidence of parasitic infections, and the eosinophil count should always be taken carefully. And very often there is a very poor correlation between sputum eosinophils and the absolute eosinophil count. There are contradictory studies regarding this, and the non-availability of trained staff and facility for sputum examination, and the cutoffs, the lack of standardization of these cutoffs is also an issue in the current practice. And the T2 low phenotypes, which basically include the obesity associated, smoking associated, and the very late onset asthma. And the T2 low biomarkers, as far as the T2 low biomarkers go, there is high unmet need, though the blood or sputum neutrophils, metalloproteinase, they are all in their initial stages. So coming to COPD, COPD is again a complex heterogeneous disease. As per the latest goal 2024, the principles of getomics, the genetic makeup, the environmental exposures, and over time, when the susceptible host, when exposed to allergens, pollution, smoking, or pathogens, and due to the various interactions, there can be a spectrum of COPD features. And the most widely used classification include the chronic bronchitis, the emphysematous, the asthma COPD overlap, and based on the exacerbation, the frequent and rare exacerbators. And of course, we have various emerging phenotypes based on the eosinophilic inflammation, the amount of emphysema and the areas affected, and based on the smoking history and the age. So regarding the asthma COPD overlap, this is again not a very well explained or defined term. The definitions are changing over time. And the airflow obstruction that is not completely reversible and accompanied by symptoms or signs of increased obstruction or reversibility. The diagnosis is, there are various diagnostic criteria, basically it is made on one major or two minor criteria. The major criteria is usually considered are the persistent airflow obstruction, tobacco smoking, previous asthma or reversibility of more than 400 ml, and minor criteria like elevated total Ig, high eosinophil level, personal history of atopy, and post-PDR. So, I mean, Abhinav, sir, what is your opinion? Whether these phenotypes, they are all airtight compartments or whether they can overlap?
As you mentioned, Prashant, in your PPT, that asthma and COPD is a complex heterogeneous disorder whose pattern rearrange from the time to time with response to host and environment interaction. So in the same way, like the phenotype can overlap and can change over time. These are multifactorial things that can affect phenotyping. So it may be the environmental factor or recurrent exposure of infection or other things like smoking, aging, obesity, and even the hormonal changes body can affect the phenotyping.
Okay. So yes, the phenotypes, they are not airtight compartments. They can overlap and change over time. The environmental factors, exposure to recurrent infections can change from a T2 high to a T2 low phenotype. And of course, the smoking, aging, obesity, menopause all have a role in the phenotypes. So if you come back to our case, sir, what will you consider? Whether you will consider it as a asthma COPD overlap, a T2 high eosinophilic asthma, or a eosinophilic COPD? Rajiv, sir?
Better would be, we can consider it as, though it is an overlap, but eosinophilic COPD will be the more appropriate to think in this patient.
Any difference of opinion, sir? Ved Prakash, sir?
Yes, sir is rightly said about eosinophilic COPD, but asthma COPD overlap is also a very common entity, and in this particular case, I will consider this overlap, asthma or COPD overlap.
In view of the previous history of rhinosinusitis, we definitely can keep that thing also in mind of, say, asthma COPD overlap in this patient.
So, as per the treatment options we have, mainly we have the bronchodilators and the anti-inflammatory drugs. So, as per the latest upcoming research, the better way of doing things will be classifying patients based upon the airway limitation and the eosinophilic airway inflammation. Of course, if it is a predominant airway limitation with a decreased eosinophilic inflammation, the combination of LABA and LAMA will be a better option. And as the evidence of eosinophilic inflammation, as we find out the evidence, then we may go adding inhaled corticosteroids and other biologicals. So any other closing remarks from the panel? Rajiv, sir?
Actually, these overlap things are definitely a complex disorder. And the scientific community as well, they are not on the same platform, whether to call it as distinct clinical entity or whether to call it as an entity which has got the overlap. Because if you see the Dutch hypothesis says that asthma and COPD are on a similar
Same
platform. But the British hypothesis says
They are
that
totally different.
yes, the asthma has got a distinct origin, COPD has got a distinct origin. So yes, scientific community is not on a same platform. What to call about the phenotyping of asthma and the COPD? The people have not even tried to phenotype this entity as well. The ACO can also have different phenotypes. But yes, phenotyping in certain disease disorder itself is not sufficient. We need to understand different, say, biochemical reaction or cytokine reaction, immunopathological things. But the limitation with these type of patient is we don't have the individual biomarkers where we can pick them up and we can label that patient that yes, it is a patient of ACO definitely. So there will be an overlap and say some gray areas. definitely in these patients. And what the literature says, supposedly a patient has got a partial reversibility, that most of the time when we encounter such type of patient, even in my practice, I treat this patient as an asthmatic or a severe asthma type of patient, where patient has got a, say, partial reversibility.
Rakesh sir, would you like to add something?
As Rajiv sir said that when we got this type of patient, definitely MR has this some reversibility. So we treat like that some part of with the asthma, uh, uh, like add-on therapy, steroid therapy, and all these things.
Abhinav boss, any comments? Okay.
As Rajiv sir said, actually phenotyping regarding phenotypes of all I mean airway diseases, asthma and COPD, the scientific community still is not in resonance. So there's much work to be done in the field of this getomics and presentations and various risk factors and varied presentation of both the entities. But definitely, I think individualizing treatment based on phenotypes, uh, uh, recognizing phenotypes in clinical practice ourselves, and then guiding the therapy according to the patient to patient, rather than sticking very or adhering very strictly to the guidelines, is not a better approach. That is why these phenotypes and these things are being talked about so much nowadays. So phenotyping has got a more of a clinical management related implications rather than academic based. The research platforms are open. The research platforms are open for phenotypes, both in asthma and COPD, and they will have very important implications on individualized therapy, which is becoming the talk of the town for every clinical entity which we, as pulmonologists, are going to encounter. So, phenotyping has got a very important role in individualizing the therapy, and individualized therapy will be the future for all clinical entities which we come across.
Studies which we say see whether it's a GINA references or a gold. These have said deliberately omitted out the ACUs. Right? If you take patients of asthma, so definitely we have to look the cohort of ACUs, and we have to say follow those patients, because the limitation is this only. कोई भी जो भी स्टडी आप देखेंगे वो एजमा पे है, तो उन्होंने डेलिबरेटली उन्होंने उसको एक्सक्लूड किया हुआ है. So you people are say upcoming say pulmonologists, and a lot of say research areas is wide open to see whether it's a distinct entity altogether. But yes, they would be say overlapping.
In fact, there are question marks in literature that whether ACO or ACOS, whether it exists or not, or it's all mental jargon of a person sitting in a laboratory just thinking around what to do more to stimulate the scientific community. I'll ask Professor Nilda to enlighten us with his views on this.
I entirely agree with you. Phenotyping is not a distinct kind of parameter, you see. It is only resemblance of some characteristic of some diseases, you see. And it's like clustering. Like people, we say tall and short, you see. But there would always be several people who would be in between, you see. So it is morphological characteristics. We already have now the genotyping, you see, to make it more precise. And in future, perhaps even genotype, there again would be a lot of overlap between the gene kind of things you see between asthma, COPD, one or the other phenotype. So I think one should not be kind of led away by the concept of phenotyping to a very clear cut concept, you see. It's only a guideline to give some kind of help in deciding therapy. Otherwise, I think it remains a subject of investigation further, you see.
Professor Rajendra Prasad, sir, please.
What Dr. Jindal said, I agree with him that, phenotype is basically to decide about what sort of a treatment. And ultimately, as you said, Alok, also that the genotype is probably going to be very important because for every disease, the personalized medicine we are moving towards, and probably those things will come up. But as a clinician, I believe that simply you have to be very clear that what type of patients you are seeing and what maximum benefit we can provide to the patient by tailoring our prescription. Thank you.
And last, as we all know, practical mantras are given by Professor Surikant. So let's hear him also.
Thank you, Alok. I think I must congratulate this young boy. He's, I think, assistant professor by virtue of the bond. So, so he has shown his good ability as a teacher, as a communicator. And you see, the phenotyping, and we are moving ahead toward the precision medicine. That is important, but we need a lot of facility to establish the phenotyping. How many centers we have the sputum for eosinophil facility? How many centers will have the genotyping, of course, facility? So that is, we have to think of that's why you see Dr. Jindal is here and he's always to make the guideline and consensus statement for the primary care physicians. So I think for learning all these things are very good things, but parallelly we should also come out that how simplified clinical phenotypes we can develop. So that is I mean, that would serve the people at large, community at large. That is my always concern.
Thank you, sir. Thank you so much. Over to Prashant.
So thank you, sir, for the comments. Thank you, all the panelists.
Just wrap this up now. If you ask me in my clinical practice, how I see if I come across with this type of a patient, say it's a patient with a dual curse. Patient is having a mix of two things, asthma as well as COPD. It's a sort of a dual curse of जैसे sir बोलते रहते हैं, it's a Karela and neem chada. So because these are the patient whom you are going to say recurrent exacerbations are there. Patient will respond to the triple therapy or OB. There is not suboptimal, results are there. Yes, people are now talking about the biologicals as well in these type of a patient, but you have to take a pinch of salt because the experience will be less because of prohibiting cost and whatnot about this. But I must congratulate Prashant for to roll on this airway conclave with this type of a common condition which we come across in our day-to-day practice. And that's all from my side.
Thank you, respected chairpersons and speaker, sir, for this very enlightening discussion. So may I request now Dr. Rajiv Garg, sir, to present a memento to Dr. Prashant, sir. May I request now Dr. Aloknath sir to please present a memento to Dr. Rajiv Garg sir. May I request now Dr. Zia Hashim sir to please present a memento to Dr. Ved Prakash sir. Dr. Zia Hashim sir, please. Could you please come to the dais to present a memento to Dr. Ved Prakash sir? May I request Dr. Ajmal sir to please present a memento to Dr. Abhinav Chaudhary sir? And may I request Dr. Rajendra Prasad sir to please come on the dais and present a memento to Dr. Rakesh Chaudhary sir. हम उनको एक बार दे दें। Now, I would like to invite Dr. Mansi Gupta, Associate Professor in the Department of Pulmonary Medicine at SGPGI, to kindly start the next session.
Yes. Yeah. A very hearty morning to everyone joining us here today. It is my pleasure to welcome you all to our 14th Foundation Day and first alumni meet. We are very proud to celebrate this occasion with you all today. And on this occasion, to celebrate it, we have organized this interactive and thematic CME on the most talked about and a very major public health problem, that is airway diseases. And I'm very happy to have, I'm grateful to all of you, all the speakers, the dignitaries, and the delegates here who have joined us here today. They will be sharing their knowledge and experiences with us, and we hope to have a very grand session today. With the first session having a very interactive discussion. I'm very happy to have that. To begin our next session, it is my extreme delight and I'm honored to invite on stage our esteemed guest of honor, Professor S.K. Jindal sir, who has taken out time from his busy schedule to be with us here today and inspire all the budding and practicing pulmonologists through his words of wisdom. For his session, may I have on stage the panelists? For the panelists for this session are Professor Rajendra Prasad sir. Sir, please. Now I invite on stage Professor Suryakant sir. And we also have our Professor Aloknath sir, departmental head, to be in this session for us. We all are very proud to have Professor Jindal with us today. He is our distinguished medical teacher and a scientist. He's fellow of National Academy of Medical Sciences, American College of Chest Physicians, and several other scientific and professional organizations. He has undertaken several investigational and multicentric projects and published over 300 scientific papers and reviews. He has been honored with the Outstanding Educator Award for scientific contributions by the American Thoracic Society and Lifetime Achievement Award from the Indian Chest Society. He has also received honors and awards for many other national and international bodies, including American College of Chest Physicians, International Union Against TB and Lung Diseases, National Academy of Medical Sciences, and Indian Council of Medical Research, and others. In his past, he has been president of the Indian Chest Society, Indian Medical Association, and many other national associations. He's also been a member and chair for various expert and scientific committees, including National DOTS Plus Committee and Zonal Operational Research Committee for TB. Sir is also the associate editor of two important and widely read journals, Chest and International Journal of TB and Lung Diseases, and member of editorial boards of several other journals. Besides his books, Oxygen Therapy and Quit Smoking, he has edited a comprehensive 2-volume textbook and a handbook in pulmonary critical care medicine. And more than that, he has been teacher to all our teachers. He's been truly the mentor that all of us have looked up to. So it's an honor again to call him on stage and deliver his deliberation, sir. Thank you so much.
Good morning. One more, as Mansi said very rightly, that he's a teachers, I must say. So at least I have been very privileged to interact with him for last so many years. And he has mentored most of the chest physician of this country. So with this little words, I just asked Dr. Jindal, and he will be talking on a very interesting subject, development of respiratory medicine in India from antiquity to future. Professor Jindal, sir.
Thank you, Professor Rajendra Prasad and Dr. Mansi Gupta. Thank you, Dr. Suryakant, Dr. Aloknath, for inviting me here. I'm very honored to be associated with this function of the department. You see, the foundation day of the department, as well as the kind of first alumni meet of this department, you see. I feel privileged in being associated with the development of this department for over 3 decades and have been coming here off and on for various activities, not only for the department, sometimes for the institute as well, when I was at PGI Chandigarh. So I think I can see many faces whom I recognize as past students, and I'm proud that most of the members of the faculty of this department, Pulmonary Medicine Department, have been our students in one or the other capacity in the past. And of course, of my association with the both the kind of stalwart sitting here on the dais, as well as now Dr. K.V. Gupta has come, with whom I again have very kind of old association and friendship. So thank you very much for giving me this opportunity. I have chosen this subject because I have nothing real academic to talk. I know most of you know the subject and have read about the subjects of diseases related to the lung and respiratory system. So I thought rather than kind of being specific, it is better to be general, because in general talk, you can speak anything and it gets accepted. While when you talk on a specific subject, you have to be really master of it, you see. Well, I have chosen this subject also because it has been, because I have seen personally and actually involved in the development of respiratory medicine in this country for the last 40 years, you see. Since when we first joined the Department of Chest Diseases at that time at PGI Chandigarh, you see. It is not my intention to go in the history of respiratory medicine all over, but I think you need to be proud in being the most ancient people about medical kind of history, you see. If you really go into antiquity, 1500 BC or perhaps even before that, when it was myth, most of the ideas at that time were myth rather than the actual science which we know today. Breathing was the most noticeable vital physiological sign of life recognized by ancient man. In fact, whenever anybody used to say whether the person is living or dead, it was the breathing, you see, because no other sign was as visible. And many old cultures and Vedic Aryans in India, you see, identify life with number of breaths. Even till date, we always say कि सांस सब पूरे हो चुके हैं, you see. So जितने सांस भगवान देता है, उतनी ही लाइफ इंसान की होती है. So it is always counted the number of breaths. And in ancient Indian Sanskrit, Om is the symbol of breath. Pranayam, you have heard in different contexts and ancient breathing techniques based on yogic practices. And Vayu was always considered the Hindu god of air in the past, you see. And of course, resuscitation was a known kind of phenomena or procedure. And medicinal resuscitation, you know the history of Lakshman Murcha or whatever they call, you see, and his resuscitation by the Sanjeevani booty or herb. So factually, the breathing has been very important and most ancient, more than pulse, more than any other organ function, you see. And then, of course, we have different diseases mentioned in the ancient text, asthma and tuberculosis. These are the two most ancient diseases in the world, you see. In different cultures, not only, I'm talking mostly about the Indian systems or Vedic cultures, but even in, for example, Egyptian, Chinese, and Greek, you see, these are the most ancient cultures. The same has been mentioned by different names. In Charak Samhita, which is the kind of Ayurvedic medical kind of collection, you see, there asthma is mentioned as Tamka Swasa, Shudra Swasa, Pratmaka Swasa, Chinna Swasa, etc., and Mahaswasa, you see. Dyspnea associated with wheezing, paroxysm, cough, and painting, etc. So the point is to say that this is the asthma has been known for more than 5,000 years or perhaps 10,000 years. And same is true about tuberculosis. Tuberculosis has been described in ancient India as Rajakshma. Rigveda describes as the physician who wants great fame cures a man attacked with consumption. Consumption, you know, is tuberculosis. Same is mentioned in Atharva Veda with the words of Indra, Mitra, and of Varuna, who were the gods. With the voice of all the gods, do we ward of Yakshama. Yakshama is tuberculosis. Same is mentioned in Ayurveda, that anybody who can cure a consumptive is the is the best physician, you see. Laws of Manu again mention the infectious nature of tuberculosis. Sufferers from tuberculosis are unclean, you see. So there are various research papers and works on these findings, you see. Both Rig Veda and Atharva Veda were spiritual and philosophical texts. So reference to Yakshma or tuberculosis was indirect and contextual. But Sushruta Samhita, which is the Ayurvedic materia medica of that period, gives details of the origin and symptomatology of Yakshma. Of course, we will not go into those details at this stage. The actual modern medicine perhaps started with Hippocrates during the biblical period, and he was the first to introduce several concepts as well as the procedures related to respiratory system. he first wrote about his the Hippocratic corpus is a collection of over 60 works of kind of different texts, as well as the other aphorisms and so on. See. He described intubation in his book Treatise on Air. One should introduce a cannula into the trachea along the jawbone so that air can be drawn into the lungs. He described air as an instrument of the body. He described pneuma, which he said is a kind of organ. He said phlegm, for one of the four humors, you see, Hippocratic fingers, and perhaps he was the first to drain pus from the pleural cavity. So Hippocratic was the real father of modern medicine. I think one must admit that. There is no doubt. He wrote extensively about different things, mostly focusing on respiration. It was Galen who changed several concepts of Hippocrates in the 2nd century after Christ. You see, when he said respiration served a triple purpose: cool and regulate innate heat, pump the chest to introduce air into the blood, and to get rid of the friligiminous products of the sputum, you see, etc., etc. And during the same time, of course, there are references to the Indian physicians who laid great stress on respiration. And there is a record that a person breathes 22,636 times a day, which is 16 per minute, you see. And that again, I have given the reference below. You see. Subsequently, of course, very little is known. We know the dark ages of 5th to 15th century, and the modern pulmonology, of course, the foundations were laid during 7th century. Then subsequently in 13th century, we have some reference to respiration, pranvayu, etc., coursing through the interior of lotus-like heart, and so on. You see. So I think the details are not available for everything, but some or the other reference here and there one finds. You see. So then there, of course, you all know that the modern history, there was a period of Renaissance. You see. That was the 14th to 17th century in Europe most of the time. And when a lot of developments had taken place in physics, chemistry, other sciences, as well as in politics, in humanistic, and all the modern kind of word which we know today, actually, of course, came after the European Renaissance, which was a very bloody period, you see, because there were a lot of wars, lot of kind of persecutions had happened at that time. And many kind of scientists or medical people, especially respirologists, you have listed on one of the column, including Priestley, Lavoisier, Vesalius, and Servetus, who were known, who had described very innovative concepts, you see, were actually either executed or guillotined, you see, for their concepts. I won't go into those details, but the fact is that this was the period which was difficult period, but it was a period during which the whole concept about science, about disease had changed. You see. And even during this period, it was the lungs which were given preeminence as far as medical world is concerned. And you can see here the quote from William Harvey, who gave lectures on whole of anatomy, who said that nothing is specially so necessary, neither sensation nor ailment. Life and respiration are complementary. There is nothing living which does not breathe, nor anything which breathes which does not live. I think that's again during these were the concepts which were there in the antiquity, and same were kind of re-emphasized during the modern times. And you also know that the clinical evaluation, whether it is percussion or auscultation, starting with Evan Brugger for percussion and Lennox for auscultation, it actually started with the with the methods to find diagnosis for tuberculosis, because tuberculosis was the major problem faced even during these times. See, um, and in India, of course, we have text during Mughal period. You see, when they say respiration, more than respiration, the pulse was given stress. You see. Post-Renaissance, of course, most of you have seen these developments, rapid changes in concepts, research and development. Professional, industrial, and commercial interests had now come in. And now medical science or respiration was no more an incident. It is now a profession, you see. It is a kind of lot of people are involved in these lot of microbiological and mycobacterial discoveries which had happened during the Renaissance period, immunological, biochemical, radiological developments. I think all this is a current things you have seen, most of them. In India also, there is a paradigm shift in respiratory medicine during this period. And this can be attributed to many factors: the increased disease burden, the shift in disease distribution and clinical spectrum of different diseases, and advances in understanding of disease causation and pathogenesis. And now we have newer vistas of diagnosis, management, and we also finally have academic curricula and education technology which have come and have affected all these things, you see. So naturally, the needs have changed, you see, in the modern times. And the WHO stress that there are colliding epidemics now, you see. On the one hand, there is infectious disease like tuberculosis, which is a global emergency, and kind of as important a person as Director General WHO described it as a global emergency in 1993. And then, of course, the global lung health lays stress on colliding epidemics of tuberculosis, tobacco smoking, HIV, and COPD, etc., etc. And lastly, of course, you all know that the non-communicable diseases or NCDs have come, you see. And even the UN, for the second time, the United Nations Assembly, for the second time adopted a medical resolution, you see. They have never done anything about medical kind of problems in the past, except for HIV once. And then for non-communicable diseases, when the General Assembly said that the 4 main non-communicable diseases, cardiovascular, cancers, chronic lung disease, and diabetes, kill 3 in 5 people worldwide. So now, of course, the stress has changed from respiration to cardiology a little more, you see. Most of you would be familiar with this figure that which is the kind of the assessment about the leading causes of death and other things, the burden of disease study, which is very famous. They estimated in 90s which are the common diseases which are important. And you can see here that a COPD or chronic lung disease has come to occupy the 3rd spot from the predicted 6th spot in 1990. So within a period of 30 years, I think it has moved up, because most other diseases are either have a plateau of curve or decreasing in incidence. Chronic lung disease somehow has an uprising trend, you see. That is the problem with it, because there is no cure. You have seen in the past session about COPD. So that continues to rise in spite of all the developments. And in India, COPD is already the 2nd leading cause of mortality and disability adjusted life year. The modern medicine has also kind of necessitated the changes in concepts. Most of people will be familiar with the left-hand column. When Robert Koch first described the mycobacteria and the concept about the microbiological diseases, that the organism must always be present in a disease state. The organism must be isolated from a host containing the disease. Samples of the, so many, I think all these are infectious kind of, sorry, all these are the postulates for an infection, although many were subsequently kind of not necessary, considered not necessary because of different issues. But now again, the modern medicine has kind of changed these also, that rather than organism, they have started saying nucleic sequence of a putative antigen or a putative pathogen should be present, no copy numbers in hosts or tissues. So these concepts are changing about even diseases such as tuberculosis, which have otherwise laid the foundations for disease pathogenesis, we say. The contemporary pulmonary medicine, of course, by late 19th century has established as a specialty, you see, with which we are familiar now. And most of you are the product of this this kind of pulmonary medicine, you see. Now there is a significant component of pulmonology, as we know, in other several specialties and subspecialties of medicine, including sleep, sports, medicine, aviation, space medicine, rehabilitation, occupational medicine, industrial medicine, etc., etc. Even in cardiology, I think it would be a very poor cardiologist who does not know about the respiration, which somehow is being more and more kind of compartmentalized. India have already talked about some of the changes in concept, but post 1970s, we have even seen that there is a winds of change. You see, new concepts and technology has come into this country because after the initial kind of first steps, you see, in the ancient periods, India has gone into the relatively darker phase of development. You see. But now there are winds of change, and in the post 70s, of course, new concepts and technology. And I have listed some of them here. We have new imaging, scanning techniques. We have new interventional pulmonologies, microbiological and genomic studies are there. And we also have mathematical modeling, computing. And now, of course, we also have many other issues which have come, including the artificial intelligence now, you see. That is all over the world, of course. We cannot remain isolated from the rest of the world nowadays, you see, including the integration of assisted respiratory supports, interventions, and surgery. That is one important issue which we are now going through, domiciliary care. Different strategic advances are also important. The one with tuberculosis, you are all familiar with the DOTS program. We also have other domiciliary care, which is becoming more and more important, you see. I think this is what I will say, that is the dramatic change which has occurred, and the speed of change has also been significant. I have this is from my own laboratory, which we used to do this spirometry with a double barrel spirometer. I don't know how many have seen such a kind of big kind machine, you see. And we used to calculate the different graphs with our own hands. You can see here, this was done by me many years ago, 35 years ago, perhaps, you see, by making the graph on the spirometer black, to do the black smoked paper, you see, and then draw our graph on the graph paper, you see. This is a case of tracheal stenosis. You can see the inside flow volume curve of a tracheal stenosis, the square kind of, and then of course, after dilatation, first dilatation, second dilatation, you can see the flow volume curve. Now, of course, we have computerized machine. I published a paper in 1990s. We did a small survey of 60 Indian medical colleges or large hospitals where there were 500 beds. And we asked them how many of you have spirometry, blood gas analysis, diffusion test, or exercise testing. You can see here that only 48 had a spirometer of one or the other kind. And the tests per week were on average 22. The blood gas analysis was again even lesser machine. Diffusion, of course, was only in big institutes, and exercise test, of course, the rare. You see, this is published in a nice NIH volume. You see the pulmonary function laboratory in the tropics, and now you can see. You see the change. I have not kind of documented here, but you all know that it is something which is out of the box. This was the time when we first started DM pulmonary medicine, 1989. I've just given here some of the, we had taken opinion from many of the experts at that time, like Dr. Guleria, J.S. Gloria, the Guleria's father, you see, Professor Bahadur, Professor Thiruvengadam, Professor Jain. Some of them are just listed here, you see. And all had agreed that there is a need to change the concepts about pulmonary medicine, because you have to go to the equal level, you see, of other specialists. And I think that was after, I won't go into that history, of course. Now we have, we started in 89 at that time, you see. There was also opposition kind of thing, but slowly and slowly people started realizing that the spectrum is changing, you see. So there is a need to change the curriculum as well, you see. There is a need to change the, change many other things. So that's how now, of course, we are lucky that there are many departments and institutes who are kind of also doing this thing, you see. Of course, we can talk about the respiratory medicine also in the light of futuristic developments like distant opinions, decisions. Some of them are already there, of course, to small or larger extents. We also have, these are, of course, true for any specialty of medicine, I will say. So I will just like to say that we need to adopt all these things in respiratory medicine as well, because you cannot stay behind, you see. There is a kind of need to define local problems and issues. We cannot go on depending upon the Western developments, you see, or someone else, you see. Somehow we are lacking behind in our research and development even now, especially research, you see. So we have to improvise very feasible and practical solutions, more meaningful and original research, because for the time being, many of you, the alumni, are not perhaps going into research field. That is a kind of lacuna which I think is felt by many of the people like me, you see. We can adopt, of course, evidence-based management practices and guidelines elsewhere, but we have to develop all these things ourselves. So I won't go into these things. Then finally, I will just say that this is a very famous quote from the Lewis Carroll's book, well, where the Alice in Wonderland, you know, that he says, she, in fact, well, in our country, said Alice, still panting a little, you would generally get to somewhere else if you run very fast for a long time. And the Queen, who is the character, the main character in Alice and the Queen, you see that it's a slow sort of country. Here you see, it takes all the running you can do to keep in the same place. I think that is what is important for pulmonologists to appreciate and to understand, that it takes all the running you can do to keep in the same place. If you want to get somewhere else, you must run at least twice as fast as that. Well, thank you very much for your patient listening.
Thank you, Professor Jindal, for really telling about everything starting from very beginning and what should be the future of pulmonary medicine. And particularly, I'm also of his opinion and of his is with little difference. Some of you are sitting, but two things I would like to add. I started my career and that time it was known as tuberculosis and chest disease, way back in 1976. So when sir, I was asked to which department you want to join, because in those days, there's nothing like PGME or NEET. There was on merit of various admissions were made. So I was on the view that I can get any department, medicine and surgery, pediatrics, but I chosen this particular specialty. That time it was very unpopular. Nobody wanted to go on that side because my boss, my mentor was very strict. There were 5 MD seats in that department. And I think in 5 years, one used to get MD. So those were the eras. We were very afraid when I joined. Many of my batchmates said, "Are you gone mad? कहाँ जा रहे हो? कुएं में डाल रहे हो अपने को?" Then anyhow, I decided to join, and probably thinking that if I'll do hard work in this particular specialty, probably I may click. And that has actually happened. Professor Jindal has seen my journey from very beginning. So what I'm trying to say to the youngster, you have to be work, all has been achieved by the hard work and sincerity and honesty to your professor. So I would just say to the youngster that please make these efforts. We have brought to this level, and it is in your hands now. You have to take it further to a very higher level. One thing. The second thing, since I have got opportunity, and I'll also probably leave early because I have a flight to Delhi. Since I am a chairman of National Academy of Medical Sciences, state of Uttar Pradesh. And so what I would request, many of you are DMs. For DMs, there is a special package to become an associate fellow. Fellow is a little difficult of National Academy of Medicine. It is not like any other organization. And luckily, we are in this audience. I see there are 3 fellows sitting. First is Professor Jindal, and Professor Jindal nominated me as a fellow way back in 2000. And then I am also a fellow, and Dr. Surikant is also a fellow. So what I would request you to become a fellow, but you can apply for fellowship, but the DM people can apply for fellowship that is known as associate fellow. And that if you are less than 45 years age, please go onto the website and you can download that form and fill. Otherwise, membership is open for everyone who is MD. And luckily I'm in a council nowadays. Last council meeting we discussed, if somebody did DNB, if he can be made member of say National Academy, because to become a member or fellow of any academy is a prestige. So why not our MD and MS, our MDS student, why they cannot become an associate member? So I think the provision has been made very soon. It will be out. So every PG now and every faculty who has got 5 years of experience had minimum of 3 publication, they can. So you can visit the website of National Academy of Medical Science. Nowadays, everything is online, nothing that initially days, I know that the fellows has to provide some form to become even a member. But now everything has been made available. So I would request, being in charge of state of Uttar Pradesh, I would request some of you who are eligible for that, please go and visit that website and see how you can fill. And if there's any help is required, you please contact me. With this, I think Dr. I think with this, as we are, hello.
Thank you so much, sir. I really thank Professor Jindal for taking out time from his busy schedule for giving his words of wisdom. And I would really like to reiterate this last slide that if you want to, if you keep on running at your own pace, probably you will remain at the same place. And if you want to reach far ahead, you will have to run at the twice as pace as you are running at. This is, I think, all of us should be assimilating this in your mind, because way back in 1989, if sir wouldn't have thought that pulmonary medicine should be developed as a subspecialty and a super specialty, this day wouldn't have come, when DM pulmonary medicine is now recognized as a subspecialty, and several number of institutes and institution across the country are offering it. So thank you again, sir. Thank you very much for giving these words of wisdom and coming here, and really we are all very, very, very thankful to you. Thank you, sir.
Thank you.
And at this juncture, I will ask the whole audience to give a standing ovation for this.
Thank you, thank you, thank you very much. You see, I'm very grateful. Thank you very much. I'm very grateful for this honor. You see.
Thank you, respected chairpersons and esteemed speakers, sir, for the wonderful deliberation. May I request Dr. Rajendra Prasad, sir, to please present a memento to Dr. S.K. Jindal, sir. Dr. Rajendra Prasad, sir, to present a memento to Dr. S.K. Jindal, sir. May I request Dr. Alok Nath, sir, to please present a memento to Dr. Rajendra Prasad, sir, please. हाँ सर, इसके बाद inauguration. Sir, to Dr. Beth. May I request Dr. Ajmal Khan, sir, to please present a memento to Dr. K.B. Gupta, sir. Alok Nath, sir. May I request Dr. Ved Prakash, sir, to please present a memento to Dr. Alok Nath, sir. Okay. ठीक है. हाँ, we are happy to know their achievements. हाँ, ठीक है. We We welcome our chief guest for the day, Professor Dr. R.K. Dhiman sir, Director SGPGIMS, and we now proceed for the inauguration ceremony.
ये हटाना ना, ये हटा के दी।
हाँ जी,
ये सीनियर तो नहीं जाएगा। हाँ, बैठाने का सीक्वेंस और स्पीच का सीक्वेंस उल्टा रहेगा।
एक नंबर।
कॉन्फ्रेंस का वो लगा दो। Good morning, everyone. I welcome you once again to our 14th Foundation Day and first alumni meet of the Department of Pulmonary Medicine, SGPGI. The Department of Pulmonary Medicine at SGPGI was established in 2006 under the Pradhan Mantri Swasthya Suraksha Yojana, with a vision to deliver high-quality services, promote professional excellence, and contribute to sustainable development in the realm of pulmonary diseases. Over the years, the department has grown steadily and has emerged as a leading specialty in the region, excelling in clinical, interventional, academic, and research activities. We express our gratitude to all those who have taken time out to join us for our inaugural alumni meet. We are honored to have distinguished faculty members who are stalwarts in their fields and have served as mentors to many in our midst. On behalf of the entire department, we extend a heartfelt welcome to each one of you. Now, we would like to humbly request our dignitaries to take their seats of honor on the dais. I would request our very honored guest of honor, a doyen in the field of pulmonary medicine, a mentor of mentors, Professor S.K. Jindal, sir, to please occupy his seat of prominence on the dais. Sir is a professor. Sir has been honored with the Outstanding Educator Award in the year 2011 for the scientific contributions by the American Thoracic Society and Lifetime Achievement Award of the Indian Chest Society. Dr. Jindal in the past has been the president of the Indian Chest Society, Indian Medical Association, and national associations. He has been also a member of chair for various expert and scientific committees, including the National DOTS Plus Committee and Zonal Operational Research Committee for TB. Dr. Jindal has been the associate editor of the two important and widely read journals, Chest USA and International Journal of TB and Lung Diseases, and a member of editorial board of several other journals. Beside his books, Oxygen Therapy and Quit Smoking, Why and How, he has edited a comprehensive 2-volume textbook and a handbook in pulmonary and critical care medicine. We are extremely privileged to have him as a guest of honor. A huge round of applause for him. Next, I invite our chief guest, Dr. Radhakrishna Dhiman, sir, Professor of Hepatology and Director, SGPGI, Lucknow. Sir did his medical graduation and post-graduation from the prestigious KGMU, Lucknow, followed by DM Gastroenterology training from SGPGI. His academic and teaching career started in the year 1993 at Postgraduate Institute of Education and Research, Chandigarh. Dr. Dhiman was instrumental in starting the Liver Intensive Care Unit liver transplantation program and in starting a new super specialty course, DM in hepatology, for the first time in the country at PGI Chandigarh. Dr. Dhiman has been the forerunner in promoting organ donation. Through his persistent efforts, the concept of pledging for organ donation on driving license in Chandigarh Union Territory became a reality in the year 2013. He has received numerous awards, and to name a few, he has been awarded with the prestigious Dr. B.C. Roy National Award by the President of India in the year 2008, Harold O'Conn Award by American Association of the Study of Liver for presentation of a research paper at the annual meeting, Basanti Devi Amir Chand by the Indian Council of Medical Research. We would like to congratulate him for his latest achievement as well. He has been awarded with the prestigious Padma Shri for his distinguished work in the field of hepatology. Now we invite our Dean, Dr. Shaleen Kumar Sir, Professor, Department of Radiotherapy, SGPGI, to please occupy his seat of prominence on the dais. We would also like to request our head of the department, on whose stable foundation our department has flourished and reached such height, Professor Alok Nath Sir, to please occupy his seat on dais. In a green initiative, we would love to offer saplings to greet all our esteemed dignitaries, and we are very thankful for their presence. I would request Ms. Poonam to please offer the saplings to all our dignitaries. Mrs. Shivani, please offer sapling to our chief guest, Professor R.K. Dhiman, sir. Ms. Vinita, to please offer a sapling to Professor Shaleen Kumar, sir. Ms. Madhubala, please offer a sapling to Professor Alok Nath, sir. To make this morning a To make this morning a blessed one, we would like to seek the blessings of Goddess Saraswati by kindling the lamp of knowledge and wisdom. I would like to invite all the dignitaries on the dais to please come forward to kindle. And Zia, sir, please to come for the photo. Thank you, respected dignitaries. Now we would like to request our head, Dr. Alok Nath sir, who laid the foundation of the department as a single faculty in the year 2009, under whose guidance over the year the department has steadily grown and emerged as one of the finest centers for catering common and rare respiratory disorders in the country. I welcomed our head, Dr. Alok Nath sir, to please address the gathering.
A very good morning to all of you. Our honorable guest of honor, Professor S.K. Jindal, our chief guest, Professor R.K. Dhiman, our honorable Dean, Professor Shaleen Kumar, Professor Suryakant, Professor Rajendra Prasad, all the dignitaries of the dais, ladies and gentlemen, my dear students, friends, ladies and gentlemen, I welcome you all to this 14th Foundation Day of our department and the first alumni meet. It gives me immense pleasure to welcome you all on this auspicious occasion of the 14th year of foundation of our department and the first alumni meet. I remember when I joined this institute on 17th of July 2009 as the first faculty member. And when we didn't have a department of pulmonary medicine at SGPGI, and I was appointed as the first faculty member to start this department. And I also remember my first working hands, Dr. Rajni and Dr. Subodh Pandey. Both are, Subodh is working at AIMS Gorakhpur and Rajni is in her own private practice. They were my first working hands, and I was, I always remember them because at that time nobody was there to start assist me in all the work of the department, right from the paperwork to the clinical work and running as errand boy also. So on this occasion, we have organized a CME on airway diseases, which is a unique CME in itself because the topic will be deliberated by none other than our own alumni and our own students under the able guidance of the stalwarts in the field of pulmonary medicine. A day like today is actually very important to us because it gives us an opportunity to interact with all of us, meet with each other, meet with the earlier staff, meet with their former teachers, and gather at the alma mater. It has its own feeling and go down the memory lane and look forward for new interactions and new hopes. It also enables the alumni to notice the changes and developments which have the department has gone through in the due course of time. So I sincerely express my gratitude to all of you for taking out time from their busy schedules to be present in here and sparing some time to spend with us. 14 years ago, department started even without a basic infrastructure. And it gives me immense pride and pleasure to see that our graduates have widely spread throughout the country and they are showcasing their excellence and outstanding performance everywhere. Working and graduating from institute like SGPGIMS is actually a dream come true for every aspiring medical professional, all because of its sheer repute and stature, which has been achieved by the hard work put by its esteemed faculty and staff members and students. Our institutions has made its place in the top 5 institutions in India and first in the state. And all thanks to the dedicated staff, dedicated student, dedicated faculty of this institution. So I welcome you all again for this CME on airway diseases and our first alumni meet on the occasion of our Foundation Day. So fasten your seat belts for a good academic ride, and I'm sure all of you will relish it. Thank you so much.
Thank you, Dr. Aloknath, sir, for the wonderful words. Next, I would like to invite our Dean, sir, Professor Dr. Shalin Kumar, sir, to address the gathering, please.
Professor Jindal Sahab, Professor Theeman sir, Director, Professor Rajendra Prasad Sahab, my teacher in KGMC, Alok, Dr. Suryakant, invited faculty members, guests, delegates, ladies and gentlemen. While at SGPGI, for those of you who've been here in the past, and for those of you who are coming here again this time, for the first time, it would be worth taking a stroll down the campus to savor its landscape, its natural habitat, something that is quite rare. I might say in the context of pulmonary diseases and the growing pollution in the country, which is ubiquitous now, this place is literally an oasis. It's perceptible that the temperatures in summer are down by 4 degrees, and conversely, they're colder by 4 degrees in winter, but also that the suspended quantity of particles is quite a fraction. And we are actually living in a, in an oxygen tent, so to speak, or a cocoon of oxygen tent. Well, I'm no expert in, I just know peripherally the kind of the studies that the deliberations that you're going to do. And, but I think it's very pertinent that given the sheer magnitude of the problem of respiratory diseases now compounded by what we call progressive or economic growth. As economic growth grows, as it inevitably will, so will the impact on earth, water, and air. And it's going to impact back on human beings. So I hope you have fruitful deliberations and have a chance also to relax in this in this pristine atmosphere that is now a rarity in the country. Thank you all for coming here, and I hope you have a good time.
Thank you, sir, for your wonderful words. Now, I would like to invite our chief guest for the day, Professor Dr. R.K. Dhiman, sir, to bless and enlighten us.
Respected Professor Jindal and respected Professor Rajendra Prasad ji, Dr. Shalin Kumar, the Dean of the Institute, and Dr. Alok, Head of the Department, my dear colleagues, students, ladies and gentlemen. आज पल्मोनरी मेडिसिन का 14वां फाउंडेशन डे है और शायद ये पहला एलुमनाई मीट कर रहे हैं। जहाँ तक फाउंडेशन डे की बात है, लगभग 3 साल पहले मैंने कहा था, रिक्वेस्ट किया था जितने भी एचओडीज हैं सारे डिपार्टमेंट के कि हमें फाउंडेशन डे मनाना चाहिए। हमारी क्या ग्लोरी है, हमने क्या प्रोग्रेस करी है, हमने कैसी इसमें एडवांसमेंट की है, उसको याद करने का एक ही दिन होता है, वो होता है फाउंडेशन डे। इट्स जस्ट लाइक ए बर्थडे। आप देखते हैं कि पिछले क्या किया है और आप ये भी उस समय डिसाइड करते हैं व्हाट वी हैव टू डू इन द नेक्स्ट 1 or 2 years or 5 years or so। पल्मोनरी मेडिसिन इस मामले में थोड़ा पीछे रहा है, लेकिन अच्छा है आज मना रहे हैं ये लोग, और मैं आशा करता हूँ कि इसी तरह से जो है आप इसको सेलिब्रेट करते रहेंगे। हमारे तीनों जो फर्स्ट फैकल्टी है, डॉक्टर आलोक, अजमल और जिया, ये तीनों जो हैं पीजीआई चंडीगढ़ से हैं और आप तीनों के गुरु आपके साथ में ही हैं सामने, प्रोफेसर जिंदल। तो व्हाट ए डे, गुरु शिष्य आपस में मिल रहे हैं और आज ये भी डिसाइड करेंगे कि आगे हमने क्या करना है। जहाँ तक मैं पल्मोनरी मेडिसिन की बात करूँ, जब मैंने ज्वाइन किया तो शायद उसी साल में या उससे अगले साल में यहाँ पे डीएम पल्मोनरी मेडिसिन आई। बहुत ही वाइब्रेंट डिपार्टमेंट है और हर तरीके की जितनी भी थेरेपी पॉसिबल्स हो सकती है वो सारी यहाँ पर अवेलेबल है। And I would say this department is a national pride for us. उसमें आप लोगों ने एडवांस ब्रोंकोस्कोपी लैब खोली है, मेरे ख्याल में इंडिया में कहीं ऐसी नहीं है, and they have full support of the anesthesia. They have the anesthesia workstation and everything. और इस मामले में जहाँ तक मेरे को ध्यान है और मैं देखता हूँ सभी लोग वैसे तो इंटरवेंशन कर रहे हैं, डॉक्टर अजमल का इसमें काफी विशेष जो है बढ़ाने का प्रयास हमेशा रहा है। तो यही सारी चीजें जो हैं हम लोग देखते हैं अपने फाउंडेशन डे पे और ये भी देखते हैं कि आगे क्या करना चाहिए। जहाँ तक मेरे को ध्यान है, इफ आई एम नॉट रॉन्ग, देयर आर 24 बेड्स इंक्लूडिंग 10 बेड्स ऑफ द आईसीयू। अगर ये देखा जाए कि आज के दिन में जितना लोड है, जितना इनके पास कार्य है, अब मतलब वर्क है करने के लिए, इंटरवेंशंस हैं, सब है, pulmonary medicine should expand further also. That is my feeling also. How we have to do it, we can sit together and we see that these 24 beds should increase at least to the 40 beds also with the total units of the two in the department. आप ये देखिए इस चीजों में। और इससे ज़्यादा तो मैं कुछ नहीं कहूँगा जहाँ तक डिपार्टमेंट की बात है, और ये हमारे लिए शान की बात है कि वी हैव सच ए डिपार्टमेंट इन अवर SGPGI and imparting the training also, best of the best training in the pulmonary medicine also, including interventions. और इन्हीं शब्दों के साथ मैं यहाँ पे अपने को विराम देता हूँ। थैंक यू सो मच फॉर द इनविटेशन टू दिस आपका जो फाउंडेशन डे है और एलुमनाई डे है। थैंक्स अ लॉट।
Thank you, Director Sir, for the wonderful encouraging words. Next, I would like to call upon our guest of honor for the day, Professor Dr. S.K. Jindal Sir, to share his pulse of wisdom with us.
Thank you. And Professor R.K. Dhiman, the director of the institute, Professor Shaleen Kamar, the dean, Dr. Aloknath, the head of the department, the Professor Rajendra Prasad, Dr. Suryakant, and Dr. Ved Prakash, Professor K.V. Gupta. In fact, all of they have been very senior colleagues and friends. Dr. Ajmal Khan, Zia, alumni of the department, and other participants. You see, I've already talked about my pleasure and privilege, you see, in being associated with this department and the institute for over 3 decades, you see. And that's how, in fact, I have seen the development of the specialty in the country in general, as well as in this institute in the past. And I'm glad that now they're already crossed 14 years, you see. In fact, I was one who was also involved in the beginning in setting up the department and giving some suggestions here and there, and sometimes in official positions as well. So I'm very glad, you see, and I must congratulate Dr. Aloknath and both and all the members of his team. Of course, 2 of them have been our own students, Dr. Ajmal and Dr. Zia, and Mansi also has been associated with me and my department in one or the other fashion. So, and I'm glad the director has already said that this is one of the best bronchoscopy laboratory, and the department has achieved great heights in every field. So I wish that all the achievements should continue in the future. And in fact, more and more progress should be made. And I am sure that with all of you, your cooperation, and of course the lead given by the faculty here, that dream can be really achieved. Thank you very much.
This brings us to the end of the inauguration ceremony. We now take this opportunity to felicitate our esteemed dignitaries. And may I request our director, sir, to kindly felicitate Dr. S.K. Jindal, sir. लगा दिया 1 मिनट फोटो वन May I request Aloknath sir to kindly felicitate our director, Professor Dr. R.K. Dhiman sir. May I also request Alok sir to kindly present a memento. May I also request Alok sir to kindly present a memento to Shaleen sir. Finally, I would like to invite Dr. Mansi Gupta, Associate Professor in the Department of Pulmonary Medicine, who has in fact been the driving force behind this conference, to give the vote of thanks.
On behalf of the organizing team, I'm glad to be standing here today to express my vote of thanks. It is indeed a matter of pride and immense joy for each one of us from the Department of Pulmonary Medicine to be celebrating our 14th Foundation Day as well as first alumni meet. And it is an honor for us to have such distinguished guests to be part of this wonderful event and making it even more special to us. I'm grateful to the SGPGI Alumni Association for providing us the necessary platform and support to conduct this event. I would express my heartfelt gratitude to our guest of honor, Professor S.K. Jindal, for being so generous and accepting our invitation. Thank you, sir, for being here with us today. Your presence at the event means a lot to us, and your words have truly enlightened us today. I express my heartfelt thanks to our esteemed chief guest and our director, Professor R.K. Dhiman, who has always been there to support our department. Thank you, sir, for being there and motivating us and supporting us in all our endeavors. You continue to inspire us every single day. I want to sincerely thank Professor Alok Nath for guiding and standing behind me throughout the planning and execution of this event. I also thank my senior mentors and colleagues, Professor Ajmal Khan and Professor Zia Hashim, for their constant motivation and invaluable suggestions. I would like to thank our renowned faculty, Professor Rajendra Prasad sir, Professor Suryakant sir, Professor K.B. Gupta sir, Professor Ved Prakash sir, Professor Rajiv Garg sir, and the list is endless. You have come all the way, taking out time from your busy schedules, and also many of our alumni who have grown into renowned faculty and who have come all across the country. Thank you for being here today and making this event truly special for us. I would be failing in my duty if I did not thank my junior colleagues and my students, Dr. Atul Tiwari and Dr. Prashant, and all our fellows from the department who have made this day possible with their meticulous efforts. Also, a huge thanks to all our sponsors and support staff from various departments at SGPGI who have helped us organize this memorable event with full perfection. Finally, a round of applause to all the delegates to be present here and making time to be with us here today and making this event a grand success. Thank you all. I would invite all our dignitaries and all our guests for a high tea, which has been arranged outside, and we'll resume for the sessions in next 15-20 minutes.
या गए सेशन पे रीना मैम है, राजिन सर है, राजिन सर नहीं है, मैं बुला लूंगी, आ जाएंगे वो और रजनीश श्रीवास्तव सर और ममता मैम। सबसे पहले राजिन राजिन सर ही है। I welcome everybody and we'll be beginning with our academic sessions now. The next session will be taken up by Dr. Suryakant sir, Professor and Head Department of Respiratory Medicine. And the session will be a critical appraisal on GINA 2023 guidelines. The session will be chaired by Dr. Professor Rajendra Prasad sir, who is a BC Roy National Awardee, Senior Consultant in the field of Pulmonary Medicine, presently Emeritus Professor, Era Medical College, Lucknow. It will be also chaired by Dr. Prerna Kapoor ma'am, Senior Physician, SGPGI, Lucknow. Dr. Rajneesh Srivastav sir, Consultant Pulmonologist, Sahara Hospital, Lucknow. And Dr. Mamta ma'am, Associate Professor, VIMS RC, Bengaluru. I request the chairs to please occupy their positions on the dais. I would like to reintroduce you to the next session that will be taken by Dr. Professor Surikant Sir, who is Professor and Head, Department of Respiratory Medicine, KGMU. The session will be a critical appraisal on GINA 2023 guidelines. The chairs for the session are Professor Rajendra Prasad Sir, BC Roy Awardee, Senior Consultant in the field of Pulmonary Medicine, presently Emeritus Professor, ERA Medical College, Lucknow. Dr. Prerna Kapoor Ma'am, Senior Physician, SGPGI, Lucknow. Dr. Rajneesh Srivastav Sir, Consultant Pulmonologist, Sahara Hospital, Lucknow. Dr. Mamta Ma'am, Associate Professor, BIMSRC, Bengaluru. May I please request the chairpersons to please introduce the speaker.
So it is still not good afternoon. Yes. What? Yes, it is good afternoon. So after, I must say, a very heavy breakfast. That's, I think, the quality of PGI, SGPGI. They provide a very good breakfast whenever I have come to this place. And before I could invite Dr. Surikant, because I have to leave little early, I must say, I must inform you, initially I'm talking a long 14-year back, rather 15-year back, when SGPGI had no department of pulmonary medicine. So I vividly remember that time the Kartar Singh was director of this institute. He was again from PGI, Chandigarh. So he wished that whether the department should be established in, because KGMC has a very rather big department, what they have said. So they made a committee. And in that committee, apart from, I think, PGI, Chandigarh, and then Dr. Khilnani from AIMS, and I was invited from KGMC. And Kartar Singh was very humble to start the proceeding of that. I must like to share with you. He first asked me, Professor Prasad, what is your opinion? Because, you know, I must tell you, during those days, the cardiology of the KGMC and many more departments were there. And when they are trying to establish here, so there's little bit of hue and cry. Why, when I have a good department, why another department should be established? So in that way, probably Kartar Singh asked me first to give your reaction. You know, those days, PGI was a big institute. Anybody used to have cough. There's no department. So usually they are calling us from KGMC. I was the culprit actually. You know, every time I have to move, you know, from come to KGMC, see a patient, go back, it takes about 2.5 hours. So a lot of disturbances. So I said, what was the word I said in that meeting? I would like to reproduce that word. And I know that why Kartar Singh asked me first to react because of those reasons. I said, I will be the happiest person if you establish Department of Pulmonary Medicine in PGI. So that was the beginning that I set the tone, and I'm happy that after some time they got a grant and this department was established. And today, what I've been told, this is the 14th year of the foundation of this department. So from my side, I wish you best of luck, and faculty, I know, all the faculty I know, because of one word I can say that faculty, what they have is trained for one of the best institute, I must say. Professor Jindal is sitting, not that he is sitting so that I'm saying these words. I have been very regular visitor of PGI Chandigarh for many reasons. Sometimes JTF, sometimes lung cancer meeting and whatnot. And when some resident used to come to pick me at the airport, now they have become all faculty. I just trying to interact how PGI Chandigarh runs. That is what I'm speaking from my core of heart. Then what I realized, One day I realized one resident said there is no attendance in PGI. I don't know what is the current status. Well, sir, there is no attendance in the PGI. So how the things goes on? Well, nobody can afford to miss any day or any class in PGI. So that was the reputation. I'd like to say one more line, and what I have seen in my life, I have seen many institutes, India, outside India. I've yet to see an institute like PGI Chandigarh. So, and Professor Jindal has been one of the founder of this department. And he was also one of the person who thought about super specialization in the field of pulmonary medicine. And I'm happy that all the 3-4 faculty what they have in PGI, mostly they are trained from that big institute. I hope the department I'm seeing here in Lucknow for last so many years, the department is flourishing, will flourish, and my best wishes to this department, that foundation of which I feel I was the instrumental. I was one of the person who is instrumental to establish the Department of Pulmonary Medicine in. So with these little information that I wanted to share, the next talk, because I'll leave in between. Next talk is going to be by none other than I must say, one of my very pet student and very, stalwarts. Most of the students might have become stalwart now. That is the happiness for a teacher. If a student becomes very high, goes high, that gives a good feeling to a teacher. So one of the good students what I have today is Dr. Surikant, who is heading the Department of Pulmonary. You know that probably he needs no introduction. I used to say him, you are following me. He always used to say, sir, I am following your footsteps. Rather, I must say that he is going ahead than me. And that teacher wants that a student should go more than a teacher. So I am happy that he is one of them who is going ahead. With these few words, I invite Dr. Surikant for his lecture.
Am I audible? Okay. So a very good afternoon to everyone. And I really want to congratulate the Department of Pulmonary Medicine at Sanjay Gandhi PGI. Director has already appreciated in the inaugural ceremony, like anything. And this is the 14th foundation day of the department and first alumni meet. I must congratulate to Dr. Alok and Dr. A to Z. Anybody who can understand what is A to Z? A for Azmal, Z for Zia. So, and of course, Dr. Mansi, who is the vibrant organizing secretary of this event, and a lot of residents. I think so many DM students here, and out of the so many, 3 are here from King George Medical University. And so many stalwarts. You see, in this hall, although appears to be a mini conference, but to have these stalwarts all over the country, like Dr. S.K. Jindal, Dr. Rajendra Prasad, Dr. K.B. Gupta, it's a very rare commodity, I would say. So to begin with congratulations and best wishes for this one-day event. And can I have the changer? Slide changer? Keyboard se karna hai? Achha, oh, sorry. Okay. So actually, whenever a topic comes to you, I add something like this is called, जैसे आप सादा दाल खाएं और तड़का दाल खाएं, दोनों में अंतर हो जाता है. So this is my habit of presenting the topic and preparing the slides. So when Dr. Mansi called me and Dr. Alok called me, sir, you have to present the GINA critical appraisal. So I found that only 6-7 new things they have been added in GINA 2023. So I said, time allotted me is 30 minutes. And if I present in 30 minutes, the 6-7 changes, then of course it will be not justice for the topic. So I must utilize this forum just to refresh your memory. So what I will do, my segment in 3 parts. That first, foundation stone, sensitization. And second part is the GINA critical appraisal. And third, what is new thing to be added in future that can be the part of the GINA. So this will have the 3 components. And as a medical fraternity, as a medical teacher, I want to share with you that as a professional duty, yours is that you update your students and fraternity. But as a citizen of this country, your present duty is that you also update and make aware the public. So from fraternity to community, that is my concept. So don't limit yourself to the fraternity only, go up to the community also. So, okay. And this one slide is showing the power of the pulmonology, power of the lungs, power of the breath, which everybody has realized during the COVID times. That you can live without food for 3 weeks, you can live without water for 3 days, but you cannot live without breath, air, or oxygen for more than 3 minutes. And that you have to realize, everyone. And noteworthy is that we breathe 25,000 times a day. And this is the one pair of lungs. God has gifted so many organs in the body. And one of the most important organ is the one pair of lungs with having 100 square meter of anatomical area and 10,000 liters of air and blood passing through it, resulting into the net result of 500 liters of oxygen, which is required for our daily survival. So I will not go into the history because this has already been told by in detail Dr. Jindal sir. And this is the basically evolving concept of asthma. So I'll just utilize this first part of talk just to resensitize you regarding the asthma. Starting from the 1970s, when the asthma is supposed to be a bronchospasmic disease. That's all. That was the only pathology and pathogenesis known to our fraternity. And then in 80s, the concept comes that it is not only bronchospastic disease, it's a bronchospasm plus inflammation. And then in 1990s, when I became the MD student, I joined in the Department of TB and chest disease at that time it is called under Dr. Raimshad and so many other stalwarts. Then a new thing was added, that is, it is bronchospasm, inflammation, and airway remodeling. And then, of course, presently we are having newer and things. That is the biomarkers, personalized treatment, phenotypes, genotypes, endotypes, so many things. And similarly, the treatment history also going to change, starting from the pure bronchodilator, then of course inhaled bronchodilator, and then now a lot of things, including the biologicals. So this is the simple definition, is still in 2023, that it's a heterogeneous disease characterized by variable respiratory symptoms such as wheeze, shortness of breath, chest tightness and cough, and variable expiratory airflow limitation, and usually associated with airway inflammation. And we know that 13% of the global burden of asthma is done country. So burden is 13%. What is alarming that if you see asthma mortality, that it is 43%. So burden is 13%, but why mortality is 43%? Just because of not delivering the adequate, prompt, and early diagnosis and treatment to the asthmatics. So this is one of the favorite slide, the concept of asthma. Why allergens are there, pollution is there, why everybody is not having bronchospasm, why everybody is not having airway inflammation. Only certain subset of people they are having because of the genetically determined hypersensitivity. And that's why there is an interaction between the genotype and environment, and that interaction resulting into the asthma. It is not only genotype which is sufficient, but also you require environmental triggers, and that interaction resulting into the symptoms of asthma or presentation of asthma. And that's why roughly 50% of the cases you are also getting the family history. And this is my public domain, very popular slide. That when I talk to the public domain, I show this slide. You touch the leaves of every plant, nothing will happen. But you touch the leaves of touch me not plant, what will happen? Chui mui ka pauda, what will happen? They will shrink. And that is the difference between the bronchi of an asthmatic person and a non-asthmatic person. With the exposure of any trigger or allergen factor, the airways of the asthmatics will have inflammation and then spasm, but the general population, the non-asthmatic population, will not have any problem. So, and this is my MBBS final year slide. What is the pathogenesis of asthma? I used to say ABC. What is ABC? A stands for airway hyperresponsiveness, B for bronchoconstriction, and C for chronic inflammation. And you can see in the cut section that hardly there is any space in the bronchial tubes to pass the air. And major risk factor, as you know, the family history, depending upon your genotype. That's why early symptom of atopy are there. Tobacco smoke may be active, passive, or tertiary smoking, outdoor and indoor pollution, biomass exposure. Thanks to Prime Minister, that now problem of biomass exposure is going down because of Ujjwala Yojana. 10 crore poor family have been given the this LPG cylinder in this scheme. Respiratory essential and para-influenza virus infection, usually in the early childhood, and so many occupations. In this country, you see, you cannot imagine how many occupations are there which are releasing a lot of gases, triggers, smoke, dust, and so many things. And some associated comorbid conditions. They are also either precipitating or aggravating the asthma. So what are the challenges in this country? I'm not talking the GINA, global challenge, but these are the three important challenges for the asthma management in this country. Number one, majority of the Indian patients remain undiagnosed or wrongly diagnosed. Those who get diagnosed remain poorly or inadequately treated. The second challenge, and third is the most of the Indian patients continue to be on oral medication rather than inhalation therapy. So these are the three challenges, and we have to, of course, tackle with this as a pulmonologist. Now, when I say about the public domain, then I think Dr. Jindal sir is there. Yes, sir is there. So we have published two articles in association with Indian Medical Association under the able leadership of Dr. Jindal. So what should be the management in asthma in primary care? If you are a MD, whether you are MD or DM, whether you are professor or emeritus professor, the responsibility as a sincere citizen of this country is to update, aware the public also. And your colleague working in a very remote area, that is in PSC, CSC. So this document is basically for those doctors, the primary healthcare workers, the primary healthcare doctors working in the periphery, either in the government setup or in the private setup. And this, again, we have revised. This was in 20, and this was also published in Journal of Indian Medical Association, which is the most largely circulated journal. This journal is circulated to 4 lakh doctors of this country. And again, this is same published in December 2022 in the same journal. So anybody who want to disseminate this knowledge to the periphery, they can go these 2 articles. But this is my way of teaching asthma, how to go ahead for asthma. This is called 7D approach. So this is my personalized way of teaching. That is 7D approach. Nothing, this is not evidence-based. This is not present in any book, guidelines, or Google. But just, you see, if you symbolize the things, you can remember more. शोले पिक्चर के डायलॉग आज तक आपको याद हैं, और बीच में हजारों पिक्चर आई जो बकवास थी, वो नहीं याद हैं, because you are symbolizing, you are correlating with the Sholay. That's the reason. So what is 7D? First is you have to become the asthma doctor. And second is you have to be expert of diagnosis as well as the differential diagnosis. You should not miss it. You should not start inhalation therapy, interstitial lung disease, and tropical pulmonary eosinophilia, and so many other diseases. So, and then you have to choose drugs, what drugs and their doses. Then most important is the selection of device. It is rather more important than choosing the drugs. And deliberation, that is the communication, patient education, and adherence to your therapy. Your prescription may be wonderful, but if it is not being compliant, it is not being adhered, then it's useless. So these are the 7 factors related with asthma management. Now, how you can become asthma doctor? Yes, by attending such type of gatherings, such type of academic events, you can update yourself, you can train yourself, and you can become asthma doctor. But don't take the things from wrong side, because Google and all this is full of so many good things, so many garbage also. So please go judiciously. So this person is not Aman not suitable to read this book, but he's reading. So that is my message, that go for the only good things, learning by good things. Everybody knows that diagnosis of asthma basically in 2024 also, it's a clinical diagnosis, and GINA 2023 also has given the same table, that history of variable respiratory symptom. The term variable is very important here. And this variable terminology has been, if you just review the GINA guidelines, for last 20 years, the term variable is there. Breathlessness, wheeze, cough, and chestness, whatever we have discussed in definition. And you, if confirm variable expiratory limitation, if you have the facility by either spirometry or by peak expiratory flow meter. And then important differential diagnosis also. जैसे हम लोग कहते हैं ना कि जैसे हर चमकती चीज सोना नहीं होती, ऐसे हर फूलती हुई सांस अस्थमा नहीं होती. So you have to remember that we have already have a wonderful lecture by Assistant Professor Prashant regarding the asthma COPD differentiation. So you must differentiate whether I'm dealing with COPD or asthma, or it is ACO. Then of course, GERD, pulmonary tuberculosis, bronchiectasis, and cardiac failure. These are the important differentials of the bronchial asthma. You must remember them. Then I used to say, if you are examining with the help of a stethoscope any patient, and if you are listening so many sounds, मैं दो चीजों से अस्थमा और COPD का ऑस्कल्टेशन कंपेयर करता हूं. आप सुन लीजिए, शायद याद रहे आगे. आप किसी शादी में जाते हैं तो म्यूजिक सुनने को मिलता है, शहनाई सुनने को मिलती है. अस्थमा शादी है, आला लगाइए, बहुत सारी शहनाई जैसी आवाज, म्यूजिक की आवाज सुनेगी. तो जैसे ही आपने स्टेथो चेस्ट पे लगाया एंड यू आर हियरिंग ए लॉट ऑफ म्यूजिकल साउंड, शादी वाली बारात, सोचिए शादी में हम एंटर कर गए, दिस इज अस्थमा. अगर दूसरा पेशेंट है COPD का, आपने उस पर स्टेथो लगाया और ऐसे समझिए जैसे हम मातम में गए हैं. मातम में कोई हंस रहा होता है, कोई रो रहा होता है, गा रहा होता है, कुछ नहीं, सब साइलेंट. सो चेस्ट इज ऑल्सो साइलेंट. तो याद रखिए, अस्थमा के पेशेंट पे ऑस्कल्टेशन लगाएगा तो क्या याद आएगी? शादी. और COPD के पेशेंट में हम ऑस्कल्टेशन कार्डियक स्टेथो लगाएंगे तो क्या याद आएगा? बस हो गए. नाउ यू आर अस्थमा COPD एक्सपर्ट. There is no need for genotyping, endotyping, phenotyping. You are the expert of asthma and COPD. So bilateral diffuse bronchi, and then of course you can go with the evidence, because this is the era of evidence-based medicine. So of course you can do spirometry, and you can do PFR, and you can make the diagnosis. You can confirm the diagnosis rather. Doses and drugs. How many type of drugs you require? Asthma medication are of three types: controller medication or reliever medication, and then add-on therapy for severe asthma. So only three groups you have to choose. That's all, finish. Asthma is a disease of two important pathologies. One is, that is the spasm which needs reliever, that is bronchodilator. Swelling needs a preventer or controller, that is anti-inflammatory. Most of the time it is inhaled corticosteroid. Now, how many controllers you have? We have controllers or preventers, inhaled corticosteroids, and inhaled corticosteroids plus LABA, and leukotriene modifier montelukast. So either in combination or alone, you can use the such type of controllers. Then we have relievers, the SABA, salbutamol and terbutaline. Short-acting anticholinergic can also used, like ipratropium bromides. And low-dose ICS-formoterol. This is new in the GINA 2023 and 2024. That is, the combination of beclomethasone or formoterol or butyrylus reformer can also be used as a reliever. And this is one of the important changes which the panel will, I would also take inputs from the panel. That is the second important thing which is included in the GINA 2023. So add-on therapy, the third component of the asthma therapy is add-on therapy. So you have, where you have to prescribe, they are ideally considered for persistent symptoms and or exacerbations despite optimized treatment with high-dose controller medications. Now, so you have so many add-on therapies: tiotropium, omalizumab, mepolizumab, benralizumab. Dupilumab is not available till now in India, and then of course systemic corticosteroids. And accordingly, in certain age groups, usually less than 6 years, they are not indicated, but otherwise they are indicated for as add-on therapy. Now, what doses you have to see? So ideally, the most common prescribed, you see, at least from tertiary care hospitals, is the budesonide. So budesonide 200 to 400 microgram per day is the low dose, 400 to 800 is the medium dose, and more than 800 microgram per day is the higher dose. And corresponding equivalent doses you can calculate and you can use as and when required as per the severity of the disease. Device, which device you have to use? So for last so many years in the Department of Respiratory Medicine, we are using this format. This is devised by me. GINA guidelines were silent a few years back. Now they have coming back how to select the device. But usually around so many years back, the GINA guidelines were saying about the device that select the device according to the days, according to patient choice, according to the years, but there were no clear-cut guidelines. But we in the Department of Respiratory Medicine for so many years, we are using, and this you can say as evidence. You see, evidence grading is maybe 1, 2, 3, A, B, C. But this is called last grading. It is called UPP, Universal Point of Practice. So that is also evidence for last so many years we are using, and this is called UPP, Universal Point of Practice. That for asthma, this guideline is for asthma, not for COPD. From 0 to 3 years, you can use PMDI with a spacer, with face mask or baby mask or nebulizer. 3 to 6 year, you can use PMDI with a spacer. 6 to 6 year DPI or breath actuated inhaler. And more than 60 years, PMDI with a spacer or breath actuated inhaler or nebulizer. So this is very popular. 3 days back, I was in Patna and one of the faculty in Patna was saying, sir, still I remember your formula 6 to 60, use DPI. So such kind of, you see, this is not 100% correct because during acute severe asthma, DPI does not work. So you have to use either nebulizer or inhaler with spacer. Now, how many of you are prescribing the inhalers with spacer? Raise your hands. MDI with spacer. Raise your hands. Okay, only 30%. My dear friends, this is also UPP, Universal Point of Practice, that never prescribe MDI without spacer. Never. जीवन में कुछ चीजें जोड़े में ही अच्छी लगती हैं. आपने सुना नहीं? शंकर पार्वती, सीताराम, ताला चाबी, पति पत्नी. आपको अलीगढ़ का ताला हम दे दें और चाबी ना दें, कैसा लगेगा आपको? If I gift you बहुत बढ़िया अलीगढ़ का ताला और आपको चाबी ना दूं, तो आपका पर्पस सॉल्व होगा? नहीं होगा. Similarly, don't waste your time for the demonstration of inhaler technique to the patient. Inhaler with a spacer is easy to understand. Compliance is good, adherence is good, drug delivery is good. And even if the patient knows the correct technique of inhalation, it has been studied that drug delivery becomes double if you are using inhaler with a spacer. So make it one message from my talk that never prescribe MDI without a spacer. But you must demonstrate the technique of cleaning of the spacer, and a spacer must be changed annually. Although recommended 6 monthly, but ideally, practically, feasibility point of view, बोल दीजिए उसको साल में एक बार इसको बदल दीजिए. Deliberation, interaction with the patient is very important. आप अस्पताल जाते हैं तो कहते हैं अस्पताल में सफाई बहुत थी, अस्पताल में दवाई बहुत अच्छी थी, और फिर पब्लिक गांव देहात का आदमी पता कहता है, लेकिन सुनवाई बिल्कुल नहीं थी. What is this सुनवाई? कोविड के दौरान when I was the in charge of 1100 bedded COVID hospital during second wave, एक मेरा 3 मिनट का वीडियो है, कभी आप देख लिए हमारे YouTube चैनल पे जाके. एक 3 मिनट का वीडियो है जिसमें मैंने सुनवाई पे बात की और किसी पे बात नहीं की. सुनवाई मीन्स कम्युनिकेशन. सुनता कौन है? डॉक्टर साहब आते हैं, चले जाते हैं, उनसे कुछ कहो तो डांट देते हैं, फिर कहते हैं हम इलाज करेंगे तुम इलाज करोगे, डॉक्टर हम आएंगे तुम आए. ये सब डायलॉग है ना, ये आप ही के द्वारा बोले जाते हैं, हमें छन छन के सुनने को मिलते हैं. वो सब द रेजिडेंट टॉक, डॉक्टर हम आएंगे तुम, इलाज हम करेंगे तुम, ये हमें सब सुन छन छन के सुनने को मिलता रहता है. SGPGIMS पता नहीं मुझे, हमारे यहाँ तो हमें सुनने को मिलता रहता है. So patient education should be part and parcel of your program. Adherence. Somebody said that drugs don't work in patients who don't take them. It is true. The problem, if you see compliance and adherence in this country, that 67% of asthma patients in India reported exacerbation in the previous. This is the old data, but still the same kind of situation is there. 78% of asthma patients in India reported missing work or school in last 1 year. In only 36% and 50% of Indian asthmatics use controller and rescue inhalers. Rest, they do not. Another question when asked, this is the very interesting data that in India, the uncontrolled asthmatics are 40% and partially controlled only 60%, no percent, rather 0% well controlled. And just ask the 4 questions. This is again GINA 2023. Just ask these 4 questions and you can evaluate that this patient is well controlled, partially controlled, or uncontrolled. That's 4 questions. But still only 9% takes inhalers and 9% around same kind of patient with doctor consultation, or most of the around 90% they are off and on. So now I'm coming to the 6-7 questions, and I would have the attention of my panelists also. This is GINA 2022 and GINA 2023. Nothing had changed. A few things only had changed. Number 1, recommendation ICS containing therapy. You see, when I started attending the European Respiratory Society since 2005, I used to ask, if asthma is an inflammatory disease, why don't you advise in the guidelines that inhaled corticosteroids should be used to begin with? And there was no answer from anyone. So this question I was asking since 2005. And now the answer is there. GINA is also saying, so the query which I have in so many years, more than 15 years, rather 20 years. Now the answer is there. Yes, we can use inhaled corticosteroid to begin with. So that is the new thing in 2024. So GINA no longer recommends treatment with SABA alone. That my objection. That was my objection. And this, and I was the correct in 2005 also. And now GINA has proven that Dr. Surikant was correct at that time also, 20 years back also. So now there is no recommendation. All adults, adolescents, and children more than 5 years, because of the risk of severe exacerbations during emergency department visits or hospitalization and asthma-related deaths. So these risks are marked reduced by ICS containing therapy. So now ICS is indicated to begin with. And if somebody want to see my prescription, even 20 years back, you will find that I have never prescribed beta-2 agonist alone in asthma patient. So I was against the guideline at that time, but now guidelines are correct, which I was practicing in last 20 years. The second thing is that fixed dose combination inhaler containing both a steroid and a fast-acting beta-2 agonist, FABA, in the same device, simplified therapy, which is called MART or SMART therapy, that single inhaler maintenance and reliever therapy. Means formoterol, which is the beta-2 agonist having short action as well as long action, this can be used as a controller also and reliever also. So ICS formoterol meets these requirements and can be used for both. I would like to have a short 15-second each from each. What is your view on this, my panelist?
So it can be used as a reliever along with so we are adding single and reliever now.
Yeah, madam.
Same, including, I totally agree with Dr. Rajneesh. ICS formoterol as a single device would be actually more useful because the patients who come to us will have financial constraints. So to maintain a single...
Yes, Dr. Prerna, final comments.
The one challenge is to convince the patient to first take an inhalation device. So this is of course an ideal combination.
Yes.
We get this kind
डायबिटीज ब्लड प्रेशर के भी मरीज को आप 2 दवा लिखो ना तो वो कहेगा अरे डॉक्टर साहब ने ज्यादा लिख दी, एक ही लो, क्या दिक्कत है? तो आप 2 इनहेलर जब भी लिखेंगे ना वो एक ही लेगा. सो दिस इज बेटर टू हैव दिस स्मार्ट थेरेपी और स्मार्ट थेरेपी. And that's why in track 2 as a relevant therapy, this has been indicated. So addition of environmental consideration. For the first time, GINA 2024 has advised that you must think of the safety of the patient as well as the planet. That you should be environment friendly as far as that. So now most of the companies, they are having some studies, some R&D that we should have the now environmentally friendly devices. Asthma phenotypes. So this has already been discussed. And how to select the various biological. So this is a very simple chart which I have prepared for you, that you just have serum Ig level, eosinophil level, and neutrophil level. And you don't need some extra high advanced test. If serum Ig is raised, patient is having severe allergic, declared as severe allergic asthma, means patient is not responding to usual treatment, even at the step 4. So you can use anti-IgE or omalizumab. If the eosinophils are raised, then you can use either anti-interleukin 5 or anti-interleukin 5 receptors, mepolizumab or benralizumab, and anti-interleukin 4 or dupilumab is not available in this country till now. Now, problem is this, that is called the neutrophilic asthma or obesity-induced asthma or the low type 2 asthma. That is the problem, and where these biological does not work. So that subset requires two things. Only two options are there. Either the macrolides, usually azithromycin, long-term can be used, or bronchial thermoplasty. And bronchial thermoplasty, as you know, that is a simple procedure in asthma treatment that targets the smooth muscle in the lungs. The treatment uses the heat to shrink the smooth muscle so it can tighten and relieve the asthma symptoms. And this benralizumab use, mepolizumab use has been now indicated in children also up to 6 to 11 years old. That is also new change in GINA 2023. Now, what is another thing which now being propagated, especially for the developing country, that don't rely upon only inhalers. You need some add-on therapy. And so there is a scope for non-pharmacological therapy. They are not the alternate, my dear friend, they are not alternatives of the inhalers. Nothing is alternative of inhaler till GINA 2023 is concerned. But there are certain things which have been recommended in GINA, and most important is that cessation of smoking, physical activity, healthy diet, weight reduction, avoidance of occupational exposure. But the most important, which I will talk in just 1 minute, is the breathing exercise. And in India, the breathing exercise named as yoga and pranayama. So just I'll take you 5 minutes. Otherwise, I have completed my talk. So I have the time. 2-3 minutes are there. It's given me 30 minutes time. So I will talk what are this yoga and pranayama. What is the role of this as an add-on therapy? I'm again repeating, they are not the alternative of inhalation therapy. So yoga and asthma beyond the drugs. And who is the Adi Yoga propagator? Yeah, Lord Shiva. And second is the Swami Vivekananda, who propagated this Indian spirituality all over the world in a speech delivered in the Chicago on 11th September 1893. And another Naren, you know, Swami Vivekananda के नाम का भी बचपन का नाम नरेंद्र था और नरेंद्र तो ही नरेंद्र. So he is the person who gave the idea of International Day of Yoga, and he proposed to the United Nations General Assembly on 27-24, and first time International Day of Yoga was celebrated on 21st June 2015, and this 21st June 2024 will be celebrated as 10th International Day of Yoga. And this is the probably world's first PhD, which was done by a student, Shruti, who is having background of yoga and naturopathy. And she was registered in 2009 as a PhD candidate for this purpose and awarded PhD in 2014. Still, I am searching. I couldn't found before that. So probably world's first PhD on yoga and asthma. And she also did a lot of, she has developed this module, 30 minutes module for various asthma, asana, pranayam, meditation. And certain asanas like Gomukha Asana, Asana, Bhujangasana, Paschimottasana, Dhanurasana, Parvatasana, Naukasana, Talasana, and Savasana. These asanas are important. And then, of course, she continued work on that, and she did the postdoctoral fellowship that completed in 2022. And still she is with us. That is our yoga room. And a lot of benefits of yoga, because today this is not the talk, so I will not. And we have 21 publications till date from 2013 to this up to this date. So 21 publications. I'm not aware of from single institute on this topic, 21 publications, maybe in this. And I'm happy to share that on third education policy, new education policy on third anniversary on 29 July, Prime Minister Modi released 100 books in Hindi, not only in the medical science, in English, history, geography, mathematics, physics, chemistry, everything. And University Grant Commission did appeal that whosoever is having the manuscript, please submit. And I submit 2 books in this, and fortunately, the both 2 books are selected, and they have been released by Prime Minister, none other than Prime Minister of India. And one of them is Asthma Mein Yog Ki Bhumika. And comorbid condition, that is allergic rhinitis, is very important. Most common thing is the allergic rhinitis. And as you know, the 3 types of treatment of allergic rhinitis. And one of them is nasal irrigation, that is Jal Neti. And you will be surprised to know कि जल नीति पे प्रोजेक्ट हमने आयुष मिनिस्ट्री में 7-8 बार भेजा और हर बार रिजेक्ट हो गया। आप तो मॉडर्न मेडिसिन के हो, आपको जल नीति पे हम क्यों प्रोजेक्ट दें? इस बार हमने भेज दिया आईसीएमआर में, and you will be surprised that it has been sanctioned. So we will create the evidence for this also. This practice, Jal Neti practice for the allergic associated allergic rhinitis in patient of bronchial asthma is already going on in the department, and we will have results. So I will not read the message. Thank you very much for your attention.
Thank you, Dr. Suryakant. Dr. Suryakant की तो एक inimitable इनका way है. तो not only did he summarize DINA 2023, what is new in the guidelines, but also added a lot of his own experience and wisdom to it, especially the interface between yoga and asthma. All this is really, really interesting and upcoming. As a physician, what really interests me is that now we are talking about comorbidities. Asthma is as much a lifestyle disease as are the other NCDs. So weight reduction, looking after comorbidities, this is so important and now being recognized. I think उसके बारे में इतना शायद बात और emphasis हम लोग पहले नहीं दे रहे थे, पर अब guidelines में है तो सबको सोचना है और इसके बारे में बात करना है. Thank you so much.
Thank you.
Thank you, sir, for your enlightening deliberation. May I request Dr. Prerna Kapoor, Madam, to please present a memento to Professor Dr. Suryakant, sir. May I request Dr. Kushwaha, sir, to please come on the dais and present a memento to Dr. Mamta. May I request Kushwaha, sir, to present a memento to Dr. Prerna Kapoor, Madam, as well. And may I request Kushwaha, sir, to again present a memento to Dr. Rajni Srivastav, please. Thank you, everyone. So for the next session on Goal Guidelines 2024, what's new? We have, may I request the panelists to come on the stage, please? Dr. Darshan Bajaj, Dr. Rahul Rathore, Dr. Vinod Kumar, and Dr. Mohammad Amir, sir. And may I request you to please introduce the speaker, Dr. Anshul Jain.
प्रेजेंटर मोड में ही रहेगा क्या? जो आप करते हैं ना स्लाइड में उसको
So I would like to take this opportunity to congratulate SGPGI fellows for this Foundation Day celebration and this academic get together. And I welcome Dr. Anshul Jain for the next talk. And he has done his MD from Kanpur, and then he has done his DM from ESI Basai Darapur, and then now he's practicing as a senior consultant at Sagar Super Specialty Hospital at Bhopal. So he would be talking on gold guidelines, what is new, 2024.
No problem.
So Anshul, over to you.
Am I audible? Thank you, sir, for your kind introduction. Good afternoon, everyone. Before starting my presentation, I would like to extend my gracious invitation, gracious congratulations to Dr. Ajmal Khan, sir, Dr. Mansi Gupta, ma'am, Dr. Alok Nath, sir, and the entire department for this invitation. I congratulate them. And I'm really fortunate to have a talk in this prestigious conference. So starting with the presentation, we are going to discuss the changes in latest gold guideline 2024, along with the evidence on which these changes have been made. There are a few minor changes and there are a few major changes are there. There are a few minor changes were there. They have merged some tables like chapter 3 and 4 has also been merged and then converted into a single chapter. The total 6 chapter in this guideline, along with the references which are initially at the end of the chapter are not shifted to the end of the guideline. And there are few major changes, that is practice modifying changes in the guideline, where they have included the PRISM. They have defined the PRISM in the detail, that is preserve ratio, impaired spirometric parameters. They have included a new chapter on hyperinflation. They have detailed about the pre-bronchodilator spirometric measures, along with screening for the COPD in the target population. There are some interstitial lung abnormality changes that has been included in the COPD patients. They have changed some vaccination recommendation in the COPD patients, along with more detail about the managing inhaled therapy. And last, they have some changes in the pharmacotherapy of the smoking cessation. So starting with the definition is still the same. It has not been changed. Same as in the old guideline, that COPD is a chronic heterogeneous disease having chronic respiratory symptoms due to the abnormality of either airway or the alveoli that lead to the persistent progressive airflow limitation or obstruction and associated with the history of risk factor like smoking or the biomass fuel exposure or some host factor could also be there. They have mentioned or maintained the same trajectory graph of the FEV1 starting with the patient in the normal patient where they mature the full peak capacity at the time of puberty around 20 to 25 years of age, along with the patient who's having initial insult or they're not catch up the growth due to the childhood insult in the past. So starting with the first change, that is PRISM. What is PRISM? It is preserve ratio impaired spirometry. Means the patient would have FE1 FE3 ratio more than 0.7 in the post bronchodilator state, although the FEV1 is less than 80% in that state. And what they have found that the prevalence of the PRISM in the COPD gene cohort was quite high compared to the normal population, which was around 12% compared to the normal population, which was 3 to 6%. And these PRISM patients had high chances of obstructive airway disease, cardiopulmonary disease, and hospitalization with the mortality in the future. They have found that around 20 to 30% patients of the PRISM will behave as a OAD in the future. And it depends on few factors which make them more prone for the obstructive airway disease. There's a paper published in the International Journal of Chronic Obstructive Pulmonary Disease, where they have traced the trajectory of the PRISM patients. And what they have found, there are few factors which make them more prone for obstructive airway disease, like closeness of the FE1 FVC to 0.7, which was having highest odd ratio of around 18. There's the age, current smoking status, longer FVT in the second evolution than in first, along with FEV1 and the age is the predictor of having obstructive airway disease in the future. And till now, but unfortunately, we are not having any evidence which favors that which kind of treatment we should provide to the PRISM patient. But yes, close follow-up is needed in this patient, and which patient behave as a OAD should be treated for that. Moving to the second change, they have included a new detail about the hyperinflation, where they have mentioned that hyperinflation is basically the trapping or the gas volume, which is more than the normal lung volume at the end of expiration. And it depends on the pathology, whether it's a static one or the dynamic one. That hyperinflation generally lead to the increase in the symptoms as well as hospitalization and having more mortality in the COPD patients. The best way to measure the hyperinflation is body plethysmography, but indirect measures are also available, like inspiratory capacity at the rest and after exercise, which fall after exercise generally in the patients. Although in the patient of COPD with the hyperinflation, the changes which we could found is emphysema, maybe the bronchiectasis, maybe airway wall thickening, but chest imaging is till now is not standardized in the patients of, especially when the hyperinflation is there. And the best treatment is bronchodilation along with supplemental oxygen if it fits in the criteria. Sometimes heliox mixture, pulmonary rehabilitation, like pursue lip breathing or inspiratory muscle training could be there, and lung volume reduction surgeries if the patient fits in the criteria, like bilateral upper lobe emphysema is there with the low lung capacity, then it is the ideal patient to have a LVRS. They have maintained the same taxonomy for the COPD patients, that if the patient having genetically determined COPD, they have labeled as a COPD-G. If patient having abnormal lung development, then it's COPD-D. The patient having cigarette smoking history, they label it as COPD-C. Having biomass fuel exposure or any pollution or the occupation related exposure is there, they have labeled it COPD-P. Due to the infection, post-infection like post-TB sequelae, they have labeled it COPD-I. Associated with the asthma, they have labeled it COPD-A, not echo. They have not used the term echo throughout the guideline. Along with, when you're not able to find out the cause, but the patient behaves with asthma, or symptoms or spirometry, then they will label it COPD-U. Now the next change is what they was like, that's pre-bronchodilator spirometry. So the first question came in the mind, why till now we are following the post-bronchodilator spirometry, which was ideal in the guideline of the gold from the very beginning. Why it was not pre-bronchodilator? So the belief or the evidence was there initially that post-bronchodilator spirometry is more acceptable and reversible compared to the pre-bronchodilator status. Along with in post-bronchodilator spirometry, they are help to differentiate the asthma from the COPD, because if the changes are there in the lung volume, then it could help in differentiating. But the evidence which now came in the picture, that one paper is published in American Journal of Respiratory Critical Care, where they have changed the repeatability of the spirometry in around 18,000 adult patients. And what they have found, that 90% of the patients were able to produce FEV1 even in the bronchodilator state, irrespective of the sex, age, height, or smoking status, has very little effect on the repeatability. Explaining only 2 to 4% of the variation was there in the repeatability. Means, yes, pre-bronchodilator spirometry is also acceptable as per the gold guideline. And especially when to do the pre-bronchodilator values, it should be as an initial test in the symptomatic patient. If obstruction is not there, then it's optional to go with the post-bronchodilator spirometry. Depend if you have very high clinical suspicion of the COPD and the curve, the flow volume loop is suggestive of having obstruction. But yes, if the obstruction is there in the pre-bronchodilator values, then very high chances of having post-bronchodilator values are having obstruction, and it is mandatory to repeat the post-bronchodilator spirometry. The gold standard till now, irrespective of the LLN and the new guideline of ATS came in the market with the GLI equation and then Z score, still gold guideline favors the post-bronchodilator fixed FEV1 by ABC ratio less than 0.7 as a diagnostic criteria for COPD patients. The reason behind that, they believe that pre and post-bronchodilator variables are same in the same individual, so better to go with that. Along with pre and post bronchodilator FEV1, initially we thought, read in the guideline and even the literature, that if the post bronchodilator FEV1 increased by 12% or 200 ml, then it is suggestive of, it is one of the criteria for diagnosing echoes. But the latest evidence says that even in the COPD patients, the lung volume changes could be there. And even in the asthma patient, sometimes you will not find the proper reversibility. So time to time variation is there. and it should not be the criteria for the therapeutic decision. Moving to the next change, it's a screening for the COPD patients. So whether we should go with spirometry or screening for COPD in each and every patient or asymptomatic adult, a big no is there. There's a proper study. They have compiled a meta-analysis is there where they have compiled almost like 33 studies, and where they have recruited the asymptomatic patients and the mild COPD patient, and they have undergone pharmacological as well as non-pharmacological intervention, and they have not found any difference in those patients. That's why they have advised strongly against the screening of COPD in the asymptomatic adult. Yes, what would be the target population? The patient who are symptomatic or having risk factor that more than 20 pack year smoking are there, or recurrent chest infections or early life events are there, they should be ideal patient and they should be considered to have a screen for COPD. Along with the patient who fits in the criteria of LDCT screening, that is low dose CT screening for the lung cancer, that is the patient having age more than 50 to 80 years, along with more than 20 pack year history of smoking is there, or some additional risk factors are there with the abstinence of less than 15 years of smoking. Then along with the LDCT, you should look for the changes of the COPD. That is called leveraging lung cancer screening for the COPD screening. And the changes what they have found are, it could be emphysema, it could be bronchiectasis, or the airway wall thickening. So there's a study published in American Thoracic Society Journal where they have find out the prevalence of COPD during the lung cancer screening. And what they have found, that the patient who's almost 983 patients were undergone lung cancer screening by the LDCT, around 57% patients had pre-bronchodilator spirometry consistent with the COPD. Now, talk about the AB assessment tool in the COPD. They have maintained the same tool, that is in the patient who's having less symptoms are categorized as group A, having more symptoms having called group B, and the patient having exacerbations more than 2 exacerbator are considered under group D. That has not been changed. Move to the next change that is very important is interstitial lung abnormality that has not been discussed in the previous guidelines. The changes that had found in the COPD patients sometimes are parenchymal lung fibrosis or the inflammation, and especially in the COPD old age patient, it's an incidental finding when you don't have any suspicion of ILD. The prevalence was around 4 to 9%, especially in the old age patient having age more than 50 years. What does it having any clinical relevance? Yes, it do have. There's a study published in the American Journal of Respiratory Critical Care where they have suggested suspected interstitial lung disease in the COPD gene study. The study was COPD gene study where they've recruited almost like 6,756 patients, and out of these patients, around 443 patients having interstitial lung abnormality, that is around 7 to 8%. And out of these patients, they have a suspicion of ILD in those patients. Based on the criteria, they have suggested that fibrosis present on the CT, along with FVC less than 80 and DSU less than 70%. And they have found 46% patient was not fitting in the criteria, having only interstitial lung abnormality without suspected ILD. And the 54% patients having suspected ILD during screening in the COPD patient. And what are their clinical correlates? The patient who were having suspected ILD in this cohort was having more SGRQ, less 6-minute walk distance, having more exacerbation frequency. They had more supplemental oxygen requirement, more severe exacerbation, and the mortality. So move to the next change, the vaccination recommendation. They have maintained the same vaccination recommendation along with the addition of a single vaccination, that is RSV, respiratory syncytial virus vaccination, based on the CDC recommendation. How this recommendation came into the picture? US vaccination securing authority has evaluated almost 20-year data. And what they have found that mortality due to respiratory syncytial virus is a U-shaped curve. It means the patient who's having age less than 5 years or the more than 60 years having high chances of mortality compared to the normal population due to respiratory syncytial virus. And they have advised to add the respiratory syncytial virus in the vaccination schedule of the COPD having age more than 60 years. They have continued with the influenza vaccination along with the SARS-CoV vaccination, and pneumococcal vaccination. If it's available, 20 valent, 20 PCV20 should be administered as a single dose, or if not, 15 followed by 23. But unfortunately, both 15 as well as 20 is not available in our country. So we are following the old regimen, that is 23 less than 65 year age and 13 in more than 65 year of age. CDC has also recommended Tdap vaccination and measles, herpes zoster vaccination, shingles vaccination in the patient who has not been vaccinated and having age more than 50 years. So initial pharmacological treatment, it is the same as previously. If a patient having group A disease, a bronchodilator must be there. If a group B patient, you can add 2 bronchodilator, depend on the symptoms, and it must be the single inhaler therapy for better compliance, as Dr. Suryakant has said. The group E patient can consider for including the ICS based on the eosinophil count as the initial pharmacological treatment. This is one of the best table that is in the available in the COPD guideline based on the eosinophil count. If the eosinophil count is more than 300 and patient having recurrent exacerbation, only eosinophil count is not there, then they should consider the patient to adding ICS, and less than 100 eosinophil count along with repeated pneumonia or history of mycobacterial infection is the contraindication or against use the recommendation of the. This is one of the best chart for the follow-up of the patients, that if the patient having more symptoms compared to exacerbation, then you should start with either LABA or LAMA, and depending on the symptoms, if they are not controlled, you can switch to either molecule or the inhaler device, or you can add up both the molecules. If still the patient is not improving, then it's better to try the non-pharmacological treatment and should investigate for other differential diagnosis or the comorbidities like GERD or OSA. Exacerbation phase are there, then you could add ICS as per the eosinophil count. And still, if it's not there, then you could consider to add roflumilast or azithromycin. I will take just 3 minutes more. Inhaled therapy, they have more emphasized around 33 types of inhaler available in the market, and each and every one have the different technique. So they have emphasized more on the education and training in inhaler device technique. The choice of device has to be individualized to the each and every patient, depend on the patient's preference, cost, that has already been told. Every time when you prescribing inhaler to any patient, just instruct it with proper demonstration and then recheck at each visit. Check adherence and technique before stepping up or labeling as the treatment as a failure. So few years back, we generally heard that if the patient is having low flow rate, if the patient is old, having more than 60 years of age, we should go with the MDI with the spacer. But if the patient having age, young patient are there having very good flow rate, then you should go with the DPI. But is the only flow rate is the only driving factor? No. There's a study published in the Journal of Aerosol Medicine and Pulmonary Drug Delivery. And what they have found, it's the pressure drop, negative pressure drop of almost 1 kilopascal or 10 centimeter of water that is suffice the delivery of the medication in the lungs compared to the flow. And what they have studied is almost most of the rotahellar or DPI devices, and they have compared at the 60 liter per minute of the flow. And what they have found, the rotahellar, which is very common in India, has led to the drop of almost 1.25 kilopascal in the patients. That is almost suffice the medication delivery. And the best devices, the other devices which are came in the market, the advanced devices, they're having different techniques and maybe different mechanism, could lead to fall in the pressure of up to the 5. Means the flow rate 60 is not required. Even the 1/5 flow rate, it would be helpful in delivering the exact medication by the DPI. So even in the low flow patient, we can prescribe the DPI. Till now, evidence-based, we have only pharmacotherapeutically based, only LABA-LAMA ICS based on impact and ethos trial, having mortality benefit, and the non-pharmacotherapy, smoking cessation, pulmonary rehabilitation, long-term oxygen therapy when we given for more than 15 to 18 hours, non-invasive mechanical ventilation in the stable COPD patient with the hypercapnia, and the lung volume reduction surgery in the right patients having mortality benefit. Pharmacotherapy of the smoking cessation, they have not changed much. Only they have added, like for acute withdrawal symptoms, you should add the nicotine gum having short acting action. And the long term, we should use the drug having long action. And ideally, we should use the combination of the drugs for better smoking cessation practice. Supplemental oxygen recommendation is same. Then if the patient having less than 55 PO2 or 55 to 60 with the heart failure, then you should prescribe this oxygen, and the target should be more than 90, along with the recheck in every 60 to 90 days to assess for the oxygen requirement. And this is the last slide where they have given the COPD follow-up chart in the guideline. It is also given in the at the last in the guideline. And it is one very beautiful chart for the follow-up of the patient of COPD, where they have mentioned how the COPD patient should be followed up. The patient should mention the diagnosis along with the symptoms, recent changes in the symptoms, along with COVID-19 symptoms or the vaccination status, written action plan, whether it's following or not, recent admission history or the emergency visit, COPD self-assessment measure, along with the main issue and why he came into the to the clinic or hospital, and the summary intervention in the plan of the management of the patient. Thank you so much for your patience. Now, house is open for.
Thank you very much, Dr. Anshul, for your very detailed presentation on newer updates in Gold 2024. Any question from the audience? Actually, we are running late, so if any question, we can take it. So my question is there any difference between PRISM and pre-COPD? Both are same or different?
Actually, pre-COPD patients are those patients having symptoms of COPD, but their spirometry are not fitting in this criteria. They are labeled as a pre-COPD patient, means FEV1 FVC ratio more than 0.7 with the FEV1 is also more than 80. These are the pre-COPD patients. And this pre-COPD patients, till now, no study proven that what kind of medication or treatment we have to give in the pre-COPD patients. But one study recently published in ERJ, that is a novelty study, which shows that pre-COPD patient, when they follow up for a longer duration, for a 1 year period or for the 3 year period, they have sudden fall in the FEV1. It's almost same as the COPD, moderate COPD kind of patients. So these should be followed up closely for the better management of the patients. And PRISM has already told you they should be follow up as per the predisposing factor. If the patient fits in these predisposing factor, then there are very high likely chances of that it converted into the COPD in the future.
Now, Dr. Anshul, if patient is symptomatic, a patient in following criteria PRISM, then what treatment you will start?
Sir, generally what they have suggested, ideally you should start with if the patient is symptomatic, definitely he must be group B. Then ideally better to start with the LABA-LAMA combination. And if it fits, if the symptom after that is not relieving, then you should change the medication or maybe the device or other non-pharmacological treatment you could add up in such kind of patients. Yes, if more than 300 eosinophil are there and patient having previous history of exacerbation, then you can give the trial of ICS. Otherwise, the best therapy is dual bronchodilator.
Thank
you. Is there any need to further work up PRISM positive patient?
Yes, sir. The PRISM patient should be closely followed up. Means it is recommended that these patients, they are having high chances of having converted into the COPD in the future. Especially 30% is a big chunk. If the patient basically fits in the criteria of having a high probability, like patient ratio FE1 FVC is almost close to the 0.7, or maybe having current smoking history, then they should be closely follow up and they should be dealt as per them.
Would you like to do CT in selected patient?
In PRISM patients, sir?
PRISM, yeah.
Yes, you can have documentation for that, because sometimes the PRISM patient would have radiological changes, and that first of all, radiological changes, if the patient having radiological changes, they're having more chances of progressing to the frank COPD, along with if the emphysema changes are there, that make him prone for the malignancy even. So they should be closely follow up and they should be dealt accordingly. Thank you.
Thank you, respected speaker and chairs. This was really a good session and it was a learning opportunity for everybody. Now I would request Dr. Darshan Bajaj sir to please present a memento to our speaker. May I please request Professor Zia Hashim, sir, to please present a memento to Dr. Darshan Bajaj, sir. May I again request Zia Hashim, sir, to please present a memento to Dr. Rahul Rathod, sir. Sir, I request you to please present a memento to Dr. Vinod Kumar, sir. So please present a memento to Dr. Mohammed Amir, sir. Since we have residents gathered in the hall at this moment, I would also take the opportunity to announce that in the lunch time, we'll be hosting a quiz for all the residents over here. So we move on to our next session, which will be on acute exacerbation of COPD in elderly patients, which will be a case-based discussion. The session will be chaired by Professor S.K. Agarwal, sir, who is Senior Consultant, Cardiothoracic Surgery, SGPGI. Professor Zia Hashim, sir, Professor Department of Pulmonary Medicine, SGPGI, and Kumar Abhishek, sir, who is Consultant Pulmonologist in Paras, HMRI, Patna. I request the chairs to please occupy the position on the dais and please introduce the speaker for the next session.
Next slide. Hello. So at the very outset, I would like to thank and congratulate Dr. Aloknath sir, Ajmal Khan sir, Zia Hashim sir, Dr. Mansi for organizing such a nice conference as well as alumni meet for all of us, and also for inviting me to present a case on acute exacerbation of COPD. So I've come all the way from Ranchi. Ranchi is a small city. It's capital of Jharkhand. It's also sometimes called City of Waterfall. But recently, this place has been made famous by none other than this particular guy, Mahendra Singh Dhoni. He was incidentally 3 years senior to me in my school. So I played not cricket, but table tennis with him. So starting with COPD, we all know that it's a very common disease entity, which we all encounter in our day-to-day clinical practice. So here's a little trivia for all of you. What's common between these three celebs? So anyone? Loveleen? So what's common between these three celebs, or maybe Arjun? Asthma. No. So this was a trick question. Actually, all these three people suffered from MI. They were quite young. So recently they suffered from myocardial infarction. So this was just a trick question. So first one is Amy Winhouse. She died quite a young age. Second one is Buddhadev Bhattacharya, and third one is JF Kennedy's wife. So all these three people suffered from COPD, and Amy Winehouse actually died because of it. So how do we define acute exacerbation of COPD? So as far as Goal 2024 is concerned, it defines acute exacerbation of COPD as an event characterized by increased dyspnea or cough and sputum that worsen in less than 2 weeks, which may be accompanied by tachypnea or tachycardia, and is often associated with increased local and systemic inflammation caused by infection, pollution, or other insult to the airways. So why exacerbation is so important? Why actually I am presenting this? Why it's very important to learn about exacerbation? Now, we all know that acute exacerbation of COPD not only leads to increased morbidity, but it also leads to increased mortality rate. So if you go by data, the risk of death is around 21% at the end of 1 year and 55% at 5 years.
the risk of rehospitalization for COPD is around 25% at 1 year and 44% at 5 years, and was gradually increased by risk factors like pollution and infection. And in-hospital mortality rate for acute exacerbation of COPD varies between 2.5 to 24.5% in different setups. So what is the disease trajectory of a patient with COPD? We all know that exacerbation leads to sharp decline in lung function. So during a COPD exacerbation, symptom usually last between a week to 10 days, but some event may last longer, up to 8 weeks. So at 8 weeks, up to 20% patients have not recovered to their pre-exacerbation state. So if you look at this particular graph, each exacerbation leads to rapid decline in lung function. So this brings us to our case. This is a fairly simple and common case. An elderly male patient was brought to emergency department with complaint of breathlessness. As far as his vital signs are concerned, he was afebrile. He was having slight tachycardia. His BP was on slightly higher side. It was 169 to 80 mmHg. He was also tachypneic. He was having moderate respiratory distress. He was using all his accessory muscle. And on auscultation, bilateral bronchi were present. So we took his history. He was having underlying diseases like hypertension, depression, diabetes, hyperlipidemia. For all these things, he was taking medication. He gave significant smoking history, but he quit almost 10 years back. COPD was diagnosed 5 years back before, when spirometry showed an FEV1 of 63% of predicted. He was on and off inhaled medication since then, plus oral bronchodilator. So patient respiratory status was gradually deteriorating since last 10 years, and it was manifested by inability to walk beyond few hundred meters. So this was his current medication. He was using 2 inhalers, salbutamol, 1 to 2 puff every 6 hours as needed, and ICS plus LABA combination. He was not on any LABA. 5 oral medication in form of metformin for controlling his sugar, doxycycline, clonazepam, escitalopram combination for his depressive symptoms, and telmisartan for controlling his BP. So this was his chest X-ray. Dr. Abhishek, would you like to make a comment on this particular X-ray? This is a classical X-ray of a COPD patient.
This is the typical chest X-ray of the bilateral hyperinfiltration. There, the flattening of the diaphragm of the both sides, typical of the COPD patient.
Yeah, excellent. There is also tubular heart shadow, and there is slight blunting of CP angle. So it's difficult to comment whether he's having pleural effusion or not. So luckily, we had his previous CT scan, which was done in 2020. It was brought along with his son. So this was his baseline CT thorax. As you can see, there is centrilobular emphysematous changes in this particular CT, which was done almost 4 years back. And this was his present CT scan. I would request panelists to comment upon this CT scan.
Yes, so the CT definitely shows some emphysematous changes, and then we can also see the there is some ground glassing on the right lower side. So, but appears like a consolidation also. Now we can. There is also, yes, effusion is there, and the bilateral effusion is also there. So,
excellent, sir. So there is minimal bilateral pleural effusion leading to basal atelectasis, and there is ground glassing and consolidatory changes in right lung, as well as ground glassing in left lung. So following investigations were done. His hemoglobin was fairly normal. WBC was slightly raised. He was having leukocytosis. NT-proBNP was 1120. This brings us to another question. Since one of the important differential of acute exacerbation of COPD is heart failure. So how important is NT-proBNP? Jia, sir, or maybe Abhishek?
Actually, NT-proBNP is only not the cardinal feature of the rule out the heart failure. You have to rule out with the other ancillary tests like the ECG, echo, and the symptom of the bilateral pedal edema, because there is a lot of variation with the NT-proBNP. If age is less than 50, your marker is 400 or 1000, and if greater than 75, is pro-BNP is the anti-pro-BNP is the elevated. So only this not is the anti-pro-BNP high, you have to exclude the CHF. You have to both the clinical and the other ancillary test. And then if is the anti-pro-BNP high, then you can suspect that this is the patient of the heart failure.
Okay, nicely said. So his serum electrolyte, kidney function was normal. ABG was done. It showed respiratory acidosis. His pH was hovering around 7.19. PCO2 was 66.1. PO2 was also quite less. Serum procalcitonin was normal. D-dimer was also normal. Blood and sputum culture were sent, but it was awaited. This was his ECG. Would you like to make a comment on this ECG?
ECG is typical of I think P waves are slightly prominent in this case, and yeah, there are MAT is there.
Yeah,
Yeah,
there's multiple atrial tachycardia
Yes,
is there,
multiple
pulmonary
atrial
is
tachycardia is there.
sir.
So this is ECG which is quite typical of COPD, because we have prominence of RSR, like R wave is prominent in the lead one, and so this is quite like with MAT, this is quite diagnostic of COPD, and the patient who's presenting with such symptoms in acute like acute worsening of the symptoms. So this can be diagnosed as a case of acute exacerbation of COPD.
Yes, sir. But his D-dimer was negative. I mean, yeah, pulmonary embolism is one of the most important differential diagnosis of COPD, acute exacerbation of COPD. But the point is that gold standard test for diagnosing pulmonary embolism is, of course, CTPA. But D-dimer is a useful test to rule out pulmonary embolism.
Actually, for diagnosis of acute exacerbation of COPD, my first seminar in DM was on this. So I presented like we used to have a criteria, Anthonysen's criteria. So if, we have got 3 major criteria and 5 minor criteria. That is a very I still use that criteria for diagnosing of COPD exacerbation, in which there is an increased production of sputum, change in the prevalence of color of the sputum, and absence of any other explainable cause. And there are minor signs like fever, leukocytosis, and worsening of dyspnea and all. So that is a very good criteria for diagnosis of acute exacerbation of COPD, and can be applied for if you have a doubt regarding this.
Nicely
So
put,
this
sir.
is ECG is quite typical of
Acute
patient with
exacerbation of
chronic
COPD.
COPD.
Yeah. So again, we did a 2D echo, no RWMA. His ejection fraction were fairly normal. He was having co-pulmonale. PASP was raised. It was 42 mmHg. So what's the diagnosis? The diagnosis is pretty straightforward. It's a case of acute exacerbation of COPD. But what can be its differential diagnosis? Abhishek?
Actually, this acute exacerbation of COPD may be the mimic like the acute heart failure, the pulmonary embolism, pneumothorax, or maybe any consolidation.
Yeah.
So you have to rule out these things and then do it to stamp at the acute exacerbation. Sir had already said if there is the cardinal symptom, 3 cardinal symptom less than 14 days, if there increase in the dyspnea, increase in the cough, increase in the sputum purulence, increase in the excessive cough production, you have to stamp it the exacerbation of the COPD. Besides, you have to rule out the acute causes of the dyspnea, like the pneumothorax, which is more common in the COPD, pulmonary embolism, because most of the patients are bedridden on the supplemental oxygen, and that this is the pneumonia. So these are the differential, and the acute heart failure, because the COPD patient has multiple comorbidity of the patient. There may be some patient have the AF with the present with the dyspnea. So have to rule out these changes, differential diagnosis before stamping the acute exacerbation of the COPD.
Rightly said, very nicely said. That's why we need to get a HRCT or maybe chest X-ray at the earliest. We also need to get a D-dimer and anti-pro-BNP or 2D echo values. So what are the causes of acute exacerbation of COPD? So broadly, we can divide it into 2 parts, infective as well as non-infective. Under infective, we have got bacterial infection, viral infection. Then under non-infective, you can have exposure to pollution. Then again, pulmonary embolism, heart failure, myocardial infarction, or pneumonia, all these things can mimic a case of acute exacerbation of COPD. So we need to rule out these things. So just to summarize, we need to get a chest X-ray to rule out pneumonia. We need to rule out pulmonary embolism, heart failure, pneumothorax, myocardial infarction, etc. So how to classify an exacerbation? Now, it's very important to classify an exacerbation from treatment perspective. So you need to decide whether it's a mild exacerbation which can be treated at home, whether it's a moderate severe exacerbation, or whether it's a life-threatening exacerbation which needs urgent ICU care, urgent NIV support. So if someone is having a confused state, is having tachypnea, his saturation is on lower side, if he's having hypercapnia, if his pH is less than 7.35, then of course he needs urgent ICU care. He needs to be put on NIV support. So again, a diagnosis of life-threatening COPD exacerbation was made in this particular case. Patient was duly shifted to ICU. He was put on NIV support. He was put on nebulized medication. He was put on systemic corticosteroid. Now, this brings us to another question. Now, there are so many different classes of corticosteroid. We have got dexamethasone, we have got methylprednisolone, we have got hydrocortisone. So which one is the preferred corticosteroid for treating acute exacerbation of COPD? So, Jia, sir, what's your take on this?
Actually, we have recently done a meta-analysis on various types of steroid we used in COVID cases. But we found out that methylprednisolone is slightly better in terms of preventing fungal infections, better than dexamethasone. But in the recent guidelines, they are all having equal efficacy as compared to each other, and we can choose either of them. But our experience is that we usually prefer methylprednisolone or prednisolone or simple hydrocortisone over dexamethasone. But there is no difference according to the latest evidence.
Okay. So what about choice of
dexamethasone? If you use the dexamethasone, this is the long acting, because the patient of the COPD, we have to rule out the needs the steroid which have the short acting. And one bad thing for the dexamethasone, the glycemic control is very high. So if the COPD patient are a multiple of comorbidity, if you give the dexamethasone, please buy for the glycemic control, because the bad glycemic control for the if you use the dexamethasone.
Okay, what about choice of empirical choice of IV antibiotic in COPD patient? Your take, sir.
Antibiotic, if the patient is from community, then we will choose IV augmentin, or we can add for if you are suspecting atypical, then we can add clarithromycin also. But usually simple antibiotics like amoxiclav and all that will suffice for this. But if the patient has got a structural lung disease and patient is giving history of hospitalization, and patient is coming from another hospital like respector for MDR pathogens, then the choice will depend. So for community acquired infections, there we don't need more than anything like augmentin and therapy.
Okay, so now phosphodiesterase inhibiting bronchodilators are very commonly used in OPD setup. We prescribe them all the time, like doxycycline, acebrophylline, and all. Should we be using this molecule in ICU setup, especially if someone is having multifocal atrial tachycardia and all?
We don't use, and I strongly discuss, like for this patient, the patient was already having MAT. So these methylxanthines are an important precipitating factor for this multifocal atrial tachycardia. So these we don't use in our ICU, then they should not be used in acute exacerbation in a case like this.
Very nicely said, sir. Even guidelines mentions not to use these molecules. So few words about antibiotics. Now, antibiotics should be started for patients who are giving history of producing purulent sputum. So any change in sputum characteristic like color, consistency, and volume should also prompt the initiation. And antibiotic choice should always be based on local bacteria resistance pattern if available. So you should always talk to your microbiology colleague. And if Pseudomonas species or other Enterobacteriaceae species are suspected, then consider combination therapy like piperacin tazobactam or maybe carbapenem along with aminoglycoside or fluoroquinolone.
So fluoroquinolone use we usually discourage because there is a possibility of resistance and.
Okay. Okay. So this particular study was published in India. This was a recent study. So what they did, they took 197 cases of acute exacerbation of COPD. Majority of them were elderly males, smokers, and belong to urban areas. Out of 197 cases, 102 patients, that is 51.8%, they were able to isolate microbes. And the etiological agent of infective exacerbation, 19.79% were virus, 23.35% were bacteria, while co-infection was found in 8.62% of the cases. We also sent nasopharyngeal swab for viral panel by PCR for influenza A, B, RSV, parainfluenza, human rhinovirus, adenovirus, and all. And luckily, influenza A came positive. So this brings us to another important question. Should we be sending nasopharyngeal swab for viral panel by PCR in each and every patient? We are having a background knowledge that up to 28 to 30% of the patient may be having exacerbation because of viral infection. Now, we know that viral panel by PCR is quite a costly test. It may not be available easily everywhere, but it may prevent overjudicious use of higher antibiotics. What's your take on this, Abhishek?
A lot of PCR based tests are there, like the viral and then bacterial, a lot of tests. But we have to just conscious about that. If the patient is if here in the local setup, there is the influenza cases are going on and the patient come with the acute disorder, then you can send for the influenza. But if the routinely patient come on that and there is no any local recurrence of the influenza in your setting, so that much is not importance for every patient should be screened with the influenza.
So especially when there is outbreak or maybe in flu season, we should be super cautious. Otherwise, maybe we should treat as it is. So we all know that viral infection exacerbation are often more severe, last longer, and precipitate more hospitalization, as seen especially during flu months. So just to summarize the management, you need to make a precise diagnosis of COPD exacerbation. You need to assess its severity to decide whether it can be treated in home or maybe in hospital setup. You need to decide regarding the etiology, and then you have to decide regarding the treatment. Now, as far as
Nishit, one thing, that the classical teaching is that bacterial COPD exacerbations are usually infectious, bacterial, they need antibiotic. And
request the audience to please respect the speaker and this ongoing discussion. Please don't chat amongst yourselves. It's really disrespectful. Thank you so much.
like COPD exacerbation usually require antibiotics, and asthma, it is asthma which are mostly viral and don't require antibiotic.
Okay. So just indication for non-invasive mechanical ventilation is like if someone is having increased work of breathing or maybe he's having acidosis on ABG, then you need to put him on NIV. So discharge criteria is pretty straightforward. So several risk factors and triggers are involved in exacerbation of COPD. In an acute setting, adequate treatment is necessary. Then appropriate measures for prevention of a subsequent exacerbation should be initiated. So you need to decide whether the patient requires long-term oxygen therapy or maybe nocturnal BiPAP, whether he needs to be put on inhaled medication or nebulized medication during discharge and all. Again, one thing is very important. That is the role of long-term macrolide and vaccines. So what's your take on the role of macrolide? Do you routinely use azithromycin, maybe in 250 mg thrice weekly dosing in your patient, in COPD patient?
No. In each and every patient, you cannot use because the macrolide, because there are bacteria registered there. If few selected patient, if he's not responding with the ICS, LAVA, LAMA, and all the therapy of the pulmonary rehab, then you can try it, but in few selected patient, because the risk of the bacterial resistance is much more. And that is the azithromycin macrolide group had more of the cardio-arrhythmic drugs.
Yeah, right. So vaccine, we all know that influenza and pneumococcal vaccine are very important to prevent acute exacerbation. But what about recently released Boostrix or Tdap vaccine? Are you routinely using? See, I have never seen a case of pertussis in a elderly male patient. Maybe we are not able to diagnose it. So what's your take?
Actually, not in COPD, a lot of patient of the comorbidity with young patient also coming with the varicella. A lot of patient with varicella, and that patient, if the patient is comorbidity, there is the chance of mortality is very high in the varicella, because we have recently sent the same patient of the diabetic, a young patient, with the varicella pneumonia is there. Pregnant patient come with the varicella pneumonia. So if there is the cost is that syringes most commonly the newly, though if the cost is not a factor, the we can assure the patient you can take it, because the if the adult patient, yeah, elderly patient.
I'm not talking about Abhishek. I'm not talking about seagulls vaccine.
No, TDP has also come in the.
I mean, for pertussis vaccine. Sir, Alok sir, what's your take? Are you routinely prescribing, TDAP for your COPD patient? Because I have personally never seen a case of pertussis.
Yeah, but they isn't good.
In Gold Guardian, they have put, but all the studies are from, out of India. US and yeah, Western data is there. Vaccination program is different in India.
And that way, in Indian subcontinent, there are not many so we do recommendations now.
Okay.
The paradigm shift of management of acute conservation goes from management to prevention of health. I think we spoke in the slide also. So the prevention of conservation starts from the step approach, from starting to use the gamma for prevention of exacerbation, use of antibiotics, appropriate antibiotics in the exacerbation. Then vaccination with flu and flu vaccination as well as pneumococcal vaccination. That should be a norm to use all moderate to severe COPD. And even after that, and smoking cessation and control of other risk factors, even after that, if somebody does not have reduction in exacerbation, then macrolide therapy can be used.
Okay.
What about the echo finding was there? It was showing pH, na?
pH, yeah.
Actually,
So this is going to be the last questions. We all know that in COPD patient, we may have group 3 pH, but do we need to put them on anti-pH medication?
No. That is thing. The best thing in this will be LTOT only.
Okay. Yeah.
Yeah. Oxygen
Right.
should be there, and there is no role of any
anti-pH medication.
Yeah.
So just to summarize everything, in patient with severe exacerbation, systemic corticosteroid can improve lung function. Antibiotics, when needed, can shorten recovery time. Methylxanthines are not recommended due to increased side effect profile, and an IV should be the first mode of ventilation in all those patients who are having respiratory acidosis. So thank you everyone. These are a few of the picks which I took during my stay in SGPGI. Thank you very much.
Thank you, sir, and respected chairs for that engaging discussion. May I request Dr. Rajiv Garg, sir, to please come on the dais and present a memento to Dr. Nishit Kumar. May I request Dr. Rajiv Garg, sir, to present a memento to Zia, sir, as well. And I request Dr. Rajiv Garg, sir, to once again present a memento to Dr. Kumar Abhishek as well. Right. So for our next session on tuberculosis-associated obstructive pulmonary disease, a case-based discussion, I request the panelists to take the position on the dais. I request Professor R.S. Kushwaha, sir, Professor, Department of Respiratory Medicine at KGMU, Lucknow, Dr. Jagdish Lohia, sir, Consultant Pulmonologist, Narayana Health, Jamshedpur, Dr. Gyanin Shukla, Consultant Pulmonologist, Midland Healthcare and Research Center, Lucknow, and Dr. Vipin Yadav, Consultant Pulmonologist, Schwartz Chest and Medicine Hospital, Rewari. I request the panelists to introduce the speaker as well, Dr. Rahul Srivastav, sir.
Good afternoon, everybody. So first of all, I would like to congratulate and thank Department of Pulmonary Medicine, SGPGI, Lucknow, especially Professor Alok Kumar, Professor Ajmal, Professor Jia, and Dr. Mansi. So 2A, Alok and Ajmal, and 1Z, Jia, Dr. Mansi. Okay. So this is very important session, and there is its evidence also in the literature that tuberculosis associated COPD is a significant relation. So for speaker today for this topic is Professor Rahul Srivastav, who is our alumni from KGMU, Respiratory Medicine. Dr. Rahul is currently working as Professor and Head Respiratory Medicine, IMR Lucknow. So, Dr. Rahul, please start.
Thank you, sir. Respected Aloknath sir and all the faculty of SGPGI and seniors and colleagues. Thank you for inviting me to discuss tuberculosis-associated obstructive airway disease. This topic is of paramount importance as it intersects two significant respiratory conditions, tuberculosis and obstructive airway disease. Presenting unique diagnostic and management challenges, by delving into the subject, we can explore the nuanced relationship between tuberculosis and obstructive airway disease, including the impact of tuberculosis treatment history, diagnostic strategies, treatment approaches, and long-term outcomes. Through collaborative discussion and knowledge sharing, we can enhance our understanding and ultimately improve patient care in the complex realm of respiratory medicine, ensuring comprehensive and tailored management strategies for individuals with tuberculosis-associated obstructive airway disease. I welcome esteemed panelists, Professor R.A.S. Kushwaha sir, Dr. Jagdish, Dr. Vipin Yadav, and Dr. Gyanin to our discussion on tuberculosis-associated obstructive airway disease. Your expertise will enrich our dialogue as we explore diagnostic, therapeutic, and preventive strategies to address this complex intersection of respiratory health. So coming to the topic, I have two cases today, and I will ask some questions in between. So present case is a male 50-year farmer with chief complaint of cough and expectoration for 2 years, which increased for past 10 days. He was having breathlessness for 1 year, which increased for past 7 days, and hemoptysis for 10 days. There was no history of smoking, alcohol, etc. History of tobacco chewing and gutka present. Past history, if we see, history of ATT present 15 years back. There was no history of allergy and asthma. In examination, blood pressure was 130/84, pulse rate was 110, saturation was 92 on room air. No pallor, icterus, cyanosis, clubbing, lymphadenopathy seen. Respiratory rate was 24 per minute, and accessory muscle use was not present. Other systemic examinations were normal. So my first question is to Kushwaha sir. Sir, what would be the reason behind this presentation, and what will be your further approach to the patient? And secondly, I would like to ask what initial investigation we should do.
So on the given scenario, first we have to consider what DD we are thinking for, and accordingly we should plan for investigation. So on the given scenario, since 2 years history with cough, expectoration, breathlessness, and recently presented with hemoptysis. So in the given scenario, we can keep as differential diagnosis COPD, then any reactivation of tuberculosis. Maybe because there is a history of tuberculosis, maybe there is a, depending upon the lung damage, other conditions like bronchiectasis, destroyed lung, or other conditions, maybe even we can think for some lung malignancy, maybe giving this picture because the patient is aged, and other chronic respiratory conditions we can think for as a differential diagnosis. So accordingly, we have to plan for. So we will be planning for investigation like basic, apart from the routine basic investigations. We should rule out tuberculosis by sputum processing like smear and other advanced tests for tuberculosis. And then for basic chest X-ray, as we go in most of the respiratory cases when we require it. Then if you find something or you may not find something, then go for CT chest also. And when as we have seen that there is a respiratory, going towards the respiratory problem, having breathlessness. So we should also be evaluating by ABG investigation. Then when hemoptysis properly stops, we should also assess the lung function to establish if there is any COPD element, like we have seen in the history up to years. Because there is a large number of studies now established this fact, population-based studies, even hospital-based studies, that COPD का जो हमारा जो पेशेंट है उसमें एक सबसेट होता है जिसमें ट्यूबरक्लोसिस की पास्ट हिस्ट्री मिलती है. Even in India, some Indian study also have said that 32.4% COPD patients had a history of tuberculosis treatment. So this is a fact, and we know that we are also having largest tuberculosis population here. So it is a dual problem presenting in a single patient may be like this. So we can plan investigations accordingly.
Very rightly said, sir. As we know, tuberculosis is major killer infective disease in our world today also. So we did routine investigations and we get the X-ray and CT scan of the patient. I would like to ask a question to Dr. Vipin Yadav. What is your opinion about above X-ray and CT, and what further investigation is required?
As we can see in X-ray, there is right upper zone non-homogeneous opacity with architecture distortion, ipsilateral shifting of the trachea on right side, and there is left side hyperinflation of the lung. And we can confirm it in CT scan. There is a thick walled cavity with something inside the cavity, maybe some fungal ball or maybe blood. And there is paraseptal emphysema on the left side with hyperinflation of the lung. So it's correlated with old history of tuberculosis because there is lung parenchyma damage.
So very rightly said, we are having this patient with all the detailed changes in X-ray and CT scan, as Dr. Vipin said. We further investigated the patient and we did the ABG of the patient, which came out like pH 7.29, partial pressure of carbon dioxide was 56, PaO2 57, and bicarbonate 26. My third question is to Dr. Gyanin. What will be your approach to treat this patient according to this ABG?
The patients actually 3 chief complaints presented with the cough, sputum, dyspnea, and hemoptysis, and all the symptoms worsened in past 2 weeks. So for we will cover each chief complaints in detail. For cough and sputum, we will see what is the color, what's the its purulent, what is the amount, and according to that we will send sputum culture, the fungal QH, and there is also right upper lobe involvement, localized disease. We will also for the ABP panel also. And we will ask for any previous admission in the past or previous exacerbation so that we have an idea of antibiotic he received or any organism growth previously when he was admitted, and we will plan antibiotics accordingly. Now the second chief complaint was dyspnea, which worsened past 10 days. For that, we have to categorize. Actually, the accessory muscles are not working, but your ABG was a sort of mixed acidosis. Then we will also get the 2D code done to check the cardiac function status. And he has additional ABG is a mixed acidosis. Then we will also check the serum creat, and we will sort the opinion from the nephrologist if required. And the last one is complaint was hemoptysis from past 10 days. Then we will look for the bleeder. We can go for the CT pulmonary angio, where it is actually we'll see the severity of the bleeding. If it is recurrent bleeding, then we will try to embolize how severe it is. Actually, I have not given that in detail in the history. And if it is recurrent bleeding, we can go embolization as a bridge to and also take the thoracic surgery opinion also, because it is localized disease only involving right upper lobe.
Yeah, very rightly said. So we treated this patient with broad spectrum antibiotics and culture were sent. Sputum EFB came out to be negative. Gene expert was negative for Mycobacterium tuberculosis. And along with that, we treated tuberculosis associated obstructive airway disease like COPD. We used the inhaled corticosteroids by nebulization and hydrocortisone and other medication. Along with that, he was having type 2 respiratory failure. We have given him non-invasive ventilation. In further follow-up, the patient came. We did his spirometry also. So spirometry came like this: mixed obstruction and restriction. So my next question is to Dr. Jagdish. What is supposed cause behind this kind of spirometry report, and what further we can do to treat his hemoptysis?
Okay. So this kind, the mixed obstructive and restrictive pattern. So the obstruction can be because of the endobronchial involvement by the tubercular bacilli, causing recurrent airway inflammation and peribronchial fibrosis, associated bronchiectasis, and the emphysematous changes, as we have already seen in the CT scan. And the restriction can be because of the parenchymal scarring or the loss of the lung parenchymal tissue that can lead to a mixed obstructive and restrictive pattern on the spirometry report. And to treat his hemoptysis, we should do a CT angio, which including both pulmonary and bronchial arteries. And then we can plan for, if there is bronchial artery hypertrophy or dilatation, we can plan for bronchial artery embolization. Then if the patient is having hemoptysis, and then we can also go for video bronchoscopy guided intervention like cold saline lavage or installation of topical vasoconstrictor like epinephrine, or endobronchial blockade using the Fogarty balloon catheter, or the sealage, endobronchial sealage by the Spigot or biocompatible glue. And further, if there is recurrence of hemoptysis, then we can seek thoracic surgery opinion and plan for resection of the affected segment. Thank you.
Yeah, definitely that is our approach. Is it 30 minutes? Okay. Okay. So fortunately, his hemoptysis was controlled and the patient was managed by inhalers and everything what we can give to the COPD patient. My next case is 48-year male farmer, chief complaints of cough with expectoration for 5 years, increased for past 20 days, breathlessness 4 years, increased for 15 days. Patient was drowsy, slightly altered behavior present, and he was using accessory muscles. History of smoking was present, 10 to 15 BD per day for at least past 20 to 25 years. History of tobacco chewing and gutka present. Past history of ATT was present in his childhood at the age about 12 to 15 years. There was no history of allergy or asthma. On examination, his BP was 140 by 86, pulse rate 130, saturation was 76% on room air. There was no pallor, icterus, sinuses, clubbing, and lymphadenopathy present. Respiratory rate was quite high, 40 per minute, and accessory muscles use was present. So this is his X-ray. I would like to ask Kushwaha sir about to explain this X-ray.
So in this X-ray, we are looking that there is a bilateral involvement overall. There is a hyperinflation in the left upper zone. Left upper zone and middle zone, we are looking that there is hyperlucent field. There may be some bulla or quite destruction by this COPD process itself. And at few places, we are also looking sticky changes like fibrosis kind of things. So it is a mixed type of presentation. We can see some shadows may be related to his previous TB history, and some of the presentation because of long-term smoking history as he has.
Definitely, sir. So we did his CT scan. I would like to ask Dr. Jagdish to explain this CT. Yeah. So quite restricted CT scan, we can see emphysema and so much bullard and scarring is there because he was having tuberculosis in his early ages and he smoked a lot. So he is having this kind of CT. Now his ABG was pH 7.12, PCO2 was 110, PaO2 48, and bicarb was 42. Patient was not able to perform spirometry. What is your take, Dr. Gyanen, about this ABG? This is a pH is 7.12, so it is a type 2 respiratory failure with respiratory acidosis. So I would like to ask few questions regarding this scenario, these two cases where one patient was having tuberculosis 15 years back and he was not a smoker, and another one was having tuberculosis in his childhood and he was a smoker a lot. So how does a history of tuberculosis, particularly 15 years or prolonged, influence the diagnosis and management of COPD related symptoms? I would like to ask this question to Kushwaha sir.
So now there is a literature-based evidence, sufficient evidence is there that tuberculosis and COPD has a definite relation. जैसे जो ट्यूबरक्लोसिस का मरीज होता है उसमें आप देखेंगे कि दोनों पहले तो इन्फ्लेमेटरी प्रोसेस है लंग्स के लिए, COPD itself and this tuberculosis and aggravated by smoking also. तो जैसे COPD और TB का रिलेशन है, दोनों इन्फ्लेमेटरी है, इम्यून सिस्टम जो बॉडी का है वो प्रोटीएज और एंटी प्रोटीएज बैलेंस जो होता है वो बिगड़ जाता है, डैमेज की तरफ लीड करेगा. So there will be parenchymal damage, there will be damages in the airways. And tuberculosis का ये देखा गया कि जैसे सपोज रेजिस्टेंट केस है, उससे ज़्यादा जो सेंसिटिव टीबी है उससे ज़्यादा रेजिस्टेंट टीबी के जो मरीज हैं वो COPD का उनमें प्रोपोर्शन ज़्यादा मिलेगा, और जिनमें लंबी हिस्ट्री है उसमें COPD का एलिमेंट ज़्यादा मिलेगा. और ये भी बात है कि जैसे किसी को रिकरेंट ट्यूबरक्लोसिस हुई उनमें भी COPD का सबसेट आपको ज़्यादा मिल सकता है. दूसरा TB में देखेंगे आप लिटिन इन्वॉल्वमेंट, मतलब मे बी सिंपल स्मॉल प्लेस इन द लंग इन्वॉल्व और होल लोब, होल लंग और बायलैटरल. So depending upon the extent there will be severity and depending upon the duration of tuberculosis and how much destruction it has caused to the lungs. So there is a definite relation. And smoking एक तीसरा inflammatory response आ गया. Smokers में देखते हैं कि smokers में this जो tuberculosis है 3 to 5 times ज़्यादा होता. So there is a regarding tuberculosis and this COPD, there is a bi-directional impact on each other.
Definitely, sir. Yes, sir. Definitely. So we see tuberculosis causes COPD, we know, and smoking is also a cause of tuberculosis. But prolonged history of smoking can exacerbate much more COPD in the patient who are previously tubercular. Now, another question is, what specific respiratory symptoms or changes in lung function might be indicative of tuberculosis-associated COPD? And Dr. Vipin Yadav.
In tuberculosis-associated COPD, chances of hemoptysis is more as compared to smoking-related COPD. Chances of exacerbation are more in TB-related obstructive lung disease. And rest symptoms like cough, dyspnea, shortness of breath, all are almost same. And in view of lung function, lung functions are less in TB related obstructive pulmonary disease as compared to, because FVC is low, FUN is also low because of lung parenchyma damage.
Definitely. So now coming to third question, considering the patient prolonged history of breathlessness, how do we differentiate between COPD exacerbations and potential tuberculosis reactivation or complications? Dr. Gyanin.
To look for any TB recurrence, we will compare the previous radiology as well as the symptoms of the patient. He has any active fever or loss of diet, loss of weight, that systemic symptoms, along with we will compare the radiology previously, so that any new lesion which is compatible with the tuberculosis lesion. And the jury is for complication. Actually, we have the pan-acinar emphysema bilaterally. So we will also check for soma deterioration. We'll send also alpha-1 antitrypsin level also in this patient. That's all,
Yes.
sir.
So patient prolonged history and tuberculosis, if we see, any patient who is having tuberculosis any time in his life, he is more prone to develop tuberculosis again or reactivation of the tuberculosis. So we have to be cautious in treating those patients who are in our follow-up for last 5 to 6 years or many years. And whenever they get any exacerbation, we have to rethink about that. He might be getting another source of tuberculosis. So we should do the X-ray and sputum in those patients. Now, another question, what are the optimal diagnostic tests or imaging modalities to confirm tuberculosis-associated COPD in patients with a remote history of tuberculosis and ongoing respiratory symptom? Dr. Jagdish.
So if the patient is still having ongoing respiratory symptoms, first of all, we should always rule out reactivation of tuberculosis, for which we need to get a sputum for cartridge-based nucleic acid amplification test, and along with the midget AFB culture. And apart from that, we can, since there are ongoing respiratory system and it's a chronic history of tuberculosis-associated COPD, then we should also rule out cardiac status of look for the right ventricular dysfunction in these sort of patients with ongoing respiratory symptoms. And lastly, after ruling out the infective etiology and all, we can get a spirometry with diffusion capacity to look for obstruction and reduce lung capacity. And last but not the least, CT thorax of the patient to look for the architectural distortion like emphysematous changes, traction bronchiectasis, central valvular nodules, mosaic attenuation, in other symptoms to confirm tuberculosis associated COPD. Thank you.
Definitely. So given the dual burden of tuberculosis and COPD, what tailored treatment strategies or interventions should be considered to address both conditions effectively while minimizing potential exacerbation or complications? Dr. Kushwaha, sir, please.
So regarding strategy, this COPD and TB. So for tuberculosis, जितना जल्दी उसका डायग्नोसिस हो, जितना जल्दी मरीज को इलाज पर रखा जाएगा, उसका लंग डैमेज उतना ही हम लंग को प्रोटेक्ट कर पाएंगे. तो बेसिक स्ट्रेटजी तो ये है कि इसको एज अर्ली एज शुड बी डायग्नोस्ड एंड पुट ऑन एडिक्वेट ट्रीटमेंट. दूसरी चीज है कि जैसे अभी जो ट्यूबरकुलोसिस रिलेटेड सीओपीडी होता है उसमें फ्रिक्वेंट एक्सेसरबेशन होता है. सीओपीडी की डायग्नोसिस समझ लिए जो नॉन ट्यूबरकुलोसिस हिस्ट्री वाले उनसे 5 साल पहले होती है, मतलब प्रेजेंटेशन उसका अर्ली होता है. दूसरा ये है कि इन मरीजों में एक्सेसरबेशन फ्रिक्वेंट होते हैं, हॉस्पिटलाइजेशन फ्रिक्वेंट होते हैं, तो इनका भी आपको ध्यान रखना. दूसरा ये है कि इसमें इन मरीजों को इस सबसेट को आपको एडिक्वेट ट्रीटमेंट देना है, इनकी सही टाइम पे डायग्नोसिस हो जाए. अगर ट्यूबरकुलोसिस का हमने मतलब सही से इलाज कर लिया, अर्ली इलाज किया, तो रेजिस्टेंस और उसमें लॉन्गर उस कोर्स में नहीं जाएगा, तो डैमेज बचेगा. दूसरा जो मैनेजमेंट पॉइंट ऑफ व्यू से आपको सीओपीडी इन जनरल और टीबी एसोसिएटेड सीओपीडी का मैनेजमेंट ऑलमोस्ट सेम है, बट यू हैव टू हैव फ्यू कंसिडरेशन. जैसे आप जो ड्रग पार्ट देखें, जैसे इनहेल्ड ड्रग्स में आपको एक्स्ट्रा केयरफुल रहना, जुडिशियस यूज ऑफ स्टेरॉइड्स होना चाहिए. इसके अलावा जैसे स्टेरॉइड्स में अगर फ्लूटिकासोन बेस्ड देखेंगे और ब्यूटासाइड बेस्ड एज कंपेयर, So budesonide based will be better because fluticasone stay in the tissues is longer. So may have a breakdown of tuberculosis. So one consideration is like this. So you have to give, I mean, adequately and timely manage the exacerbation. You have to provide the immunization, pulmonary rehabilitation, all these in the previous session. Just we have heard that इनका अपना रोल है, pulmonary rehabilitation का अपना रोल है. इसके अलावा आपको ये भी देखना है कि दोनों पे प्रॉपर कंट्रोल हो, अगर दोनों का प्रॉपर कंट्रोल करना है.
Thank you, sir. So now I would like to say, past history of tuberculosis is an important risk factor of COPD, and tuberculosis is also common in COPD patients. Development of chronic airflow obstruction may be related to common risk factor or tuberculosis-associated lung damages. Both COPD and tuberculosis are major health problems in developing countries. Several predictors of COPD severity among tuberculosis patients have been reported, including smear-positive disease, extensive pulmonary involvement before anti-tuberculosis treatment, reduced radiographic improvement post-treatment, and delay in initiating tuberculosis treatment. So my take-home message is differential diagnosis is crucial considering COPD exacerbations versus tuberculosis reactivation. Comprehensive diagnostic testing and imaging are necessary for accurate assessment. Treatment strategies should be tailored based on previous tuberculosis treatment history and potential drug-resistant strains. Lifestyle modifications and pulmonary rehabilitations are essential for improving respiratory function. Long-term monitoring is needed to detect complications and disease progression. Multidisciplinary collaboration among healthcare providers is vital for optimal management. Patient education on self-management and symptom recognition is important. Regular follow-up visits are necessary to monitor treatment response and adjust therapy as needed. Thank you very much.
Thank you, respected speaker and chairpersons. May I please request Professor Ved Prakash sir to please give the memento to our speaker. May I now request Professor Ved Prakash sir to please give the memento to Professor R.S. Kushwaha. So please give a memento to Dr. Gyanin Shukla sir. I invite Dr. Vipin Yadav sir to please receive a memento from Professor Ved Prakash. So please give a memento to Ved. Thank you so much, chairpersons and speakers once again. I request her to please give a moment. I'm really sorry for that. Please give a moment to Dr. Jagdish sir.
Thank you all. We'll be breaking for lunch now. I request all our faculty to proceed with to the lunch area. And delegates, the residents who want to participate in the quiz, please stay back. There are exciting cash prizes for the quiz. So please participate.
By the way, residents who participate, don't worry. Lunch will be there for you as well. It's not that it's either lunch or quiz. It's not that. Yeah, we'll finish off with the quiz early enough. Yeah. So I'll request the residents to please come up and occupy the seats in the first two rows. We have A4 size sheets. And all the residents from our department definitely have to participate. So no one can go and have lunch. Everyone has to participate. Barring me, that is obviously. Please occupy seats in the first two rows, please. And if you want, you can keep a gap of one seat. Last में चार तो बैठे हैं, different time to go for. अच्छा, they are not, they are not.
Residents, we request you once again to please occupy the front two rows. It's a very short quiz. It will just take 15 minutes.
So you'll be given A4 size sheets. Please mention your name and institute. Please, if you want, you can. There's just one participant per team. That is, I mean, it's an individual quiz. So please maintain a gap of one seat. That will be like very easy. I find 4 residents from our department. They're sitting back. No lunch if there's no quiz.
Ajit.
Where is Ajit?
Residents from KCH, please come forward.
Thank you. Thank you. Thank you. Acha, right. I'll hand out the papers. Please mention your name and your institute. I hope the net jammers are working fine. अच्छा अच्छा प्लीज 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 इसको थोड़ा एक बार ये कर दो. नहीं करना तो पड़ेगा. तो इसमें आंसर्स थोड़ी लिखे होंगे, इसमें ब्लैंक ही होगा. प्लीज प्लीज हैव दिस. नहीं मैं दे दे रहा हूँ, मैं दे दे रहा हूँ सबको. अच्छा आपको मिल गया? You have paper? Right. हाँ बिल्कुल बिल्कुल. 1 2 3 papers. अच्छा यहाँ पे कितने लगेंगे? 1 2 3 4 5. अच्छा there is a
who has got a pen or paper. So
actually और भी papers लगेंगे. अच्छा right. आप ले लीजिए. एक second. I'll get more papers, please. Please just wait a bit. A4 size papers है आपके पास? A4 size papers नहीं, ये ऑफिस थोड़ा खोलिए. A4 size papers लगेंगे. A4 size papers लगेंगे ना?
Password on the नहीं मिला.
Sure, we can break that into, we can tear that into half. ठीक है ठीक. No. No, you're not allowed to give up your papers. You're only allowed to tear it into half. We still have 3 residents from our department who are not participating. So you have the papers, please tear it into half. हाँ, करना ही है. पेज बंदोबस्त हो जाएगा, don't worry. हाँ बस चलो. Do you have papers in here, please? We need 2 more papers.
Are you split it
नहीं
into
Ajit and Krishanu don't have. नहीं उतना split नहीं करना है. There are papers. उनको एक दे दीजिए please.
Everybody has.
So everyone has a paper and a pen, I hope. ठीक है, thanks. Thank you. Please write your name and the institute name on the top. So we'll have 15 questions. Each question, certain questions have subparts. So a correct response to every part will fetch a +5. A negative, there will be a negative. If there is any incorrect response, it will be met with a penalty of -1. Right at the midpoint of the quiz, that is question number 8. That will be a star marked question. So the stakes go higher in this one question only. So every correct response to to any part of that question will fetch a +10. But since the stakes are higher, there will also be a penalty of -5 with any incorrect response. I think that will be a bit unfair. Achha, so sir wants to act as a cheerleader. Okay. Okay. So can we start? Everyone has a pen and a paper, right? Sumit, where is your pen and paper? Achha, you have it. Okay. So for our first question, a little bit of history.
I'll do that.
Okay. So this is Acha, right. Just one second. Who is keeping right? So at the end of the question, right? Every question will have 30 seconds to it. So you'll have 30 seconds to answer the question. Question number 8, right? Question number 8 will have 1 minute. So you'll have 1 full minute to answer that question. Right. So starting off with the quiz, this is the first question. So a little bit of history. So this is a photo of a German anatomist, and he is credited with the discovery of an ultrastructure in the airways. So there are 3 parts. What did he discover? What are they now known as? And why was there a change? What necessitated the change?
Your time starts now.
Your time starts now. So if you discuss amongst yourselves and if you get the prize, then you'll have to split that as well, right? So 30 seconds for this one. There are 1 minute for this one. There are 3 parts to this. So 1 minute for this and 1 minute for question number 8. So what did he discover? One worded answer will do. If you want a clue, what did he discover? It lies, the answer lies in his name basically. What are they now known as? And why was there a change? I can give a clue as well. So I mentioned something about his origin. So that has something to do with why was there a change in the name. So at the end of 1 minute, you can again buzzer. Okay, right. We'll repeat the questions if there is a necessity. Rather. So question number 2. So this comes straight from the Goal Guidelines 2023, which is the only once daily long-acting nebulized anticholinergic drug approved by the US FDA.
Time has already started.
So I'll end the question and then the time starts, right? Okay. So one is, I'll give you a clue. One is glycopyrronium. What is the next one? Glycopyrronium has a duration of action of 12 hours. Then came this drug, which has a duration of action of 24 hours. Glycopyrronium needs to be given twice daily. This needs to be given only once daily. So moving on to question number 3. So according to GINA guidelines 2023, daily diurnal PEF variability in adults should be more than how much to confirm variable expiratory airflow limitation? This was actually mentioned in one of Suryakant sir's slides. So 30 seconds for this as well. Okay, so moving on to question number 4. So we all know that HAM is one of the pathognomonic features of ABPA, radiological that is. So in ABPA, HAM is found to have a CT density value exceeding how much? Either HAM is found to be more dense than the paraspinal muscles, or HAM is found to have a CT density value exceeding how much? Exceeding what value? So moving on to question number 5. Lung clearance index is a parameter derived from which test? So body plethysmography, multiple breath washout test, single breath washout test, and impulse oscillometry. So if you have a hunch, go for it. At the end, we can only not win this. And time is up for this. So question number 6. So recently, triple therapy has been approved in the treatment of cystic fibrosis. The 2 drugs are ivacaftor, tezacaftor. What is the third drug? If you need a clue, it's a very shallow clue. We all use smartphones, and there is someone guiding us. If you you get a female voice telling you all sorts of information. So the name of that almost matches the name of this drug. Almost. I'm not saying that it does. If you need a clue, that is. So this is question number 7. We're almost at the halfway point. So Mehta's rule of 4 is used in which airway intervention? Mehta's rule of 4, and all the questions are basically based on airway since this is an airway conclave. So Mehta's rule of 4 is used in which airway intervention? We have 4 options: endobronchial laser, electrocautery, endobronchial argon plasma coagulation, and bronchial thermoplasty. So moving on to the star-marked question. And this is a slightly difficult question, I accept. So it will have 3 parts. You will get 1 full minute to answer this. It's a clinical scenario. So we have a 65-year-old non-smoker female who presented to us with nausea, vomiting, and abdominal pain for 2 weeks. She's also been having recurrent bouts of episodic cough, dyspnea, and wheeze over the last few years, almost like an asthma. A preceding PFT demonstrated an obstructive pattern, while a recent CT thorax exhibited multiple nodules with mosaic attenuation. Abdominal MRI, because she was having abdominal symptoms like nausea, vomiting, and abdominal pain, abdominal MRI showed multiple masses throughout the liver, and a USG guided biopsy was done from the liver lesion. So what is the diagnosis? A lot of the times, this is a bit of a rare diagnosis, I must say, but then it is one of the differentials of asthma which fails to respond to treatment. So what is the diagnosis? The name is too long. If you want, you can write down just a short form. There's a very accepted short form for that. So if you want, you can write that as well. What is the classical description of the pathological image? The USG guided biopsy was done. So what is the classical description? If you don't even know the description, you just need to decode what you're seeing below. And this is actually the name of the classical description of the pathological image. You want the history once more? Okay. So 65-year-old non-smoker female, symptoms suggestive of asthma. A preceding PFT demonstrated a picture like an asthma, that is an obstructive pattern. Recent CT thorax exhibited a mosaic attenuation. Because of the abdominal symptoms, an abdominal MRI was done. Liver lesions were found. USG guided biopsy was done from this lesion. Okay, I'll give a clue. There has to be a clue to this. So it has got something to do with carcinoid. It has got something to do with carcinoid, but not exactly a carcinoid. Obviously, I wouldn't be giving out the answer just like that. So what is the diagnosis? What is the classical description? Try and decode what you're seeing at the bottom of the image. And what explains the obstructive pattern or the mosaic attenuation on PFT? So +10 for any of the parts, or for +30 for all of the parts combined together, -5 if you get it wrong. Slightly difficult question, I accept, but then that's why it's a star marked one. So I think 1 minute is up. Yeah, it's more than 1 minute actually. So moving on to the latter half of the quiz. So which TKI, that is a tyrosine kinase inhibitor, has been found to reduce airway hyperresponsiveness as well as tryptase release from mast cells in severe asthma? So you have 4 options. This was based on an NEJM article about 5-6 years ago. So which TKI? So coming to EBUS now. So all of the following are features of malignant lymph nodes in EBUS, except presence of coagulation necrosis sign, indistinct margin, presence of centra hilar structure, and on EBUS elastography if there is a predominant blue color. During my MCQ days, one of my seniors used to tell me, if you have any confusion regarding 4 options, option C appears to be correct. I can assure you this is not the case in this one. So moving on to question number 11. So Chartis system is used to assess what? If you want a clue, so what is the clue which I can give? So, Acha, you want the name of the disease? That definitely is a clue. So it has got something to do with COPD, obviously, at the back end of the goal guidelines. We tend to read the first few pages and not the last ones. So moving on to question 12. So this is an image-based question. So McAdams criteria is used for which disease process? And we have 4 bombastic names: tracheobronchial amyloidosis, relapsing polychondritis, tracheobronchopathia osteochondroplastica, and tracheobronchomalacia. The answer lies in the image. So I'll give a clue. Look at the trachea. No, that's not a very helpful actually clue. All of the answers have something to do with the trachea. So moving on to question number 13. So this is a radial EBUS image. What does a black circle indicate? what does a black circle indicate? This is a radial burst image. So what does a black circle indicate? Okay, I'll give you three options. I haven't mentioned the options. So one is, it may be the peribronchial mass itself, it may be the probe itself, or it may be the normal lung tissue. So what is it? What does black indicate? What does a black circle indicate? So I give you three options. It could be the peribronchial mass itself, it could be the normal lung itself, or it could be the probe itself, the EBUS probe. So which one is this? What does a black circle indicate? So question number 14. Enough clues in this? Which procedure is being done here? If you want a clue, probably the name, there's a name mentioned somewhere in there. That is a clue in itself. And coming to the final question of the quiz, is it visible? Is it visible? If you want, you can look at the side monitors. It's probably a bit murky in here. So identify the sign. So I'll give you a clue. This is found in COPD. So what sign are we looking at? This is found in COPD itself. So what sign are we looking at? So in description, you want to write, this is a chest X-ray PA view. So we need a specific actually answer. Otherwise, it becomes very difficult. Everyone will give a very answer. I apologize for the slightly tough questions, but this is how it was. So do we discuss the answers now? Oh no, first of all, I need to take away the papers, right? हाँ लंच के लिए जा सकते पहले पेपर देके उसके बाद ठीक थैंक यू So first prize is 5,000 rupees. Second prize is 3,000. Third prize is 2,000. All in rupees, not in euros or dollars. And whoever gets it has to give a party to all the others. So basically nothing is going to be taken back from this. Please. Okay, now everyone please have lunch. Thanks. Thank you.
Ajmal Khan will be joining from our own department. He'll be joining us shortly. And as a third panelist, we have Dr. Arjun Kashyap. So he's also going to join us in a while. And I request the panelists to introduce the speaker, please, for the session.
Shall I start, sir? I'll try to finish it as soon as possible. So central airway obstruction. So we are going to discuss about the diagnosis and management. So first of all, we are going to start with the clinical features. In most of these patients, you will find ineffective cough because there won't be any flow. Breathlessness, which can be found in this central airway obstruction, but it will be fine whenever the lumen diameter has decreased to 8 mm, and at that time only patient will having breathlessness on exertion. At rest, if the diameter lumen is left only 5 mm. If patient is having less than 5 mm, it is called as critical airway stenosis. It means you need to intervene as soon as possible in these patients. If CO2 is increased, the patient will have anxiety and more breathlessness. These are anxiety is there, then chances are that patient may having CO2, and it also hints that patient can land up in respiratory failure and he needs intervention ASAP. The presentation of symptoms depends on the size of the disease, location, stridor, it can be inspiratory or expiratory, or it can be fixed also. Inspiratory if it is extrathoracic, expiratory if it is intrathoracic, and biphasic at the level of vocal cord, which is fixed airway obstruction. Plus duration of the disease. If it is acute, maybe because of some foreign body, then dyspnea will be more. If it is a chronic, slowly graduating, symptoms will be less because of the compensation of the lungs. And underlying pathology, if it is benign or malignant also, it depends. Patients will have symptoms variability. It is not like that patients having severe obstruction, they may have less symptoms. A patient is having less stenosis may have more symptoms because symptoms depend upon the pressure drop across the stenosis, and it works on the Reynolds phenomena. So if patient is having active lifestyle, then there is a chances there will be have increased work of breathing, their symptoms will be much more. So according to your clinical symptoms, you cannot judge whether a patient is having severe stenosis or mild stenosis. You will require radiologically and bronchoscopic image to assess those things. These are some causes of CAO. It can be malignant. Malignant can be primary tumors of the airway or can be metastatic tumors. Non-malignant may be because of most common is endotracheal, post-endotracheal stenosis or tracheostomy stenosis, other TB in our disease in our country. Other congenital causes more commonly seen in your pediatric populations. Spirometry can definitely help you in assessing whether is there obstruction, but you can't rely only on spirometry. The spirometry values will show decrease whenever lumen size has decreased up to 8 to 10 mm. If it is more than that, you may not find any changes in spirometry also. So, thing is, your symptoms, spirometry or X-ray may not show good correlation with your stenosis. You need to keep a high suspicion in all these patients. 3D, normal CT scan may or may not help. The thing is, you have to get a CT scan with 3D reconstruction, which helps you in finding whether the lesion is extrinsic or intrinsic, or it is a mixed. What is the airway distal to the lesion doing? What is the length and the diameter of the lesion? And what is the relationship of the lesion with other structure, mainly your vessels? Sometimes your congenital stenosis, which can be there, which is O-shaped configuration with no airway thickening, can be seen, in which ring will be extending, your tracheal ring will be extending to posterior wall. Others in CT can help you like relapsing polychondritis or TBU. There will be sparing of the posterior membranous wall. R-glass configuration can be seen in post-intubation stenosis. Calcification can be seen in polychondritis, TBU, amyloid, and tuberculosis. And other associated parenchymal abnormalities will also help you, whether patient is having underlying COPD, emphysema, that is also causing an issue. Bronchoscopy is key diagnostic tool. You should have a low threshold to perform bronchoscopy in these cases. As I told you earlier also, your clinical features, radiology, or your spirometry may not give you the proper idea. You require a CT scan or better is a flexible bronchoscopy. So you have to keep bronchoscopy is low threshold. Direct visualization through bronchoscopy helps you in identifying the lesion. Plus it gives the severity and extent of airway involvement. Plus it also helps you in detecting the extrinsic compression and how much is the pressure it may or may be generating on the airway wall. So whenever we talk about central airway obstruction, we always try to distribute in three types. First is intrinsic, in which you just require removing of the intrinsic tumor. Second one is extrinsic. In these, you don't require any coring or anything. You just need to put a stent and these things will work. And third one is a mixed, in which you require coring and removing of the tissue plus a stent placement. So these mainly you can define or you can differentiate in all these things. So common thing is benign tracheal stenosis, which most of the time we see. It is mostly after intubation. It can be because of tracheostomy also, because of endotracheal tube. Classical history patient will give like I have undergone any intubation, and he was fine for 2 weeks, and after 2 weeks suddenly breathlessness has started increasing, and from last one week or 2 weeks he's having stridor. Most of the time, these patients will be treated like an asthmatic. And whenever we do any CT scan or any bronchoscopy, you find. So tracheal stenosis, benign one, is differentiated into two types, benign and complex. Benign and complex differentiation is if it is one cartilage ring involved, less than 1 centimeter in length, and there is no associated chondritis or cartilage collapse. It is called simple. This classification is very much important because in simple stenosis, you can definitely go ahead and do an endoscopic procedure. In complex, your endoscopic procedures may or may not really give you good results. And in these surgeries, always surgery is a better option depending on the patient condition. If patient is not fit for surgical thing, then you can definitely do endoscopic procedures in all these patients also. These are some other classifications for BTS. In the lack of time, I'm not going to go through all of these things. And these are some new classifications which has been proposed. Frigg et al. And Motogul, they have been according to differentiate types of the stenosis, and they are trying to grade. These are a paper which I was in SGPGI. Ajmal sir has given me this opportunity. And in these patients with the optical tracheal dilator, you can always dilate these tracheal stenosis in one shot also. Other treatment options are endoscopic dilation, ablative therapies, cautery, APC, laser, stenting, mitomycin C, steroid. And last one is the surgery, which is not our thing. Differentiation between rigid bronchoscope and flexible bronchoscope. This is always an important, which instrument should I have, which is better, which is not better. For rigid bronchoscopy, availability is limited, but yes, with the time it is increasing. But with rigid, the positive point is you can have airway protection, channel is wide, suction capability is superior if you are suspecting any hemoptysis, control of bleeding is more effective, but there are some limitations also. Anesthesia requires general anesthesia. You can't reach to the distal bronchus. Plus, whenever these patients, most of these patients may or may not be good candidate for any surgery, any anesthesia. So many times your patient or your anesthetist may not be very much comfortable in giving anesthesia to these patients. So you may or you may not get that support from anesthesia team whenever you are starting these procedures. So in these cases, you may have to go for the flexible bronchoscope also. But you need to see whether this patient is good for a flexible or rigid, and accordingly you should decide. The rigid bronchoscopy has unique property that you can you can insert a silicone stent, which is not possible with a flexible one also. In acute conditions, our aim whenever patient is coming in the stridor, you need to secure the airway. It can be secured through endotracheal intubation, which can be difficult to insert in these cases. Rigid bronchoscopy directly you can insert, which can dilate, can act as a therapeutic also, and can relieve the patient also. Tracheostomy can be done only for proximal obstruction, not for the distal obstruction. And Heliox, which is not available in India in most of the places, it can definitely decrease the resistance and help in better work of breathing. Dilation, it can be done through flexible scope or rigid bronchoscope. Rigid bronchoscope definitely can help you much better. Then metal bougie dilator, in past they have been used. Then angioplasty dilator, Fogarty, does not help much also. But yes, continuous radial expansion or CRE balloons can be used. CRE and balloons are different from other balloons because they provide continuous radial expansion. It means they're providing an equal force at all the level of the stenosis. With other balloons, it is not like that. And you can use air or saline or contrast media to dilate these balloons. Only thing is, if you're using the C-arm, then with the contrast, you can get a better vision. With air or saline, the chances are less. But if you're using the contrast, you may not be able to reuse your balloon again and again. But with air or saline, you can use it again and again. PITS or PTTS, post-intubation tracheal stenosis or post-tracheostomy tracheal stenosis, incidence is 4.9 cases per million. There are multiple risk factors. The mean length of PITS is 2.6 centimeter. For PTTS is 1.2 centimeters. And tracheostomy has less risk for stenosis than endotracheal intubation. But how does it develop? How does post-stenosis develop? It is always controversial. People say maybe because of the people who has more active lifestyle or who are more resistant to intubation, more injury if it is occurring during the intubation, chances are that they may have more chances of PITS, but there is no clear indication. Another thing is your vaginous, which is more commonly seen in females, younger age. Systemic therapy, if stenosis is occurring, then systemic therapy does not help in stenosis in these cases. Bronchoscopic procedures can be done, and you can use intralesional corticosteroids if you are suspecting vaginous related stenosis also. After stenosis, definitely improved relief in symptoms and improved physical status is there. Recurrence is more common in bronchial than in tracheal. And one thing which is important with vaginous is you will find multiple stenosis. You may not find one stenosis or two stenosis. You will find multiple stenosis. We had one case in which one tracheal stenosis and at one right main bronchus and left main bronchus, two stenosis were also there in this case. Another is mitomycin, whether to use it or not. We have used it, we have tried it as an anti-neoplastic agent. It can be inserted there and put there at the level of the stenosis after dilation. But what the literature says whether it does not prevent any recurrence, but it delays the recurrence. This is what meta-analysis says. But some people are against it, some people are in favor of it, but I'm not much in favor of it because it does not help in any prevention also. Other ablative procedures you can do with the rigid bronchoscopy, which is called as beveled end of the rigid bronchoscope, can be used to shave off the lesion, which is called as coring or core out. It is suitable for intrinsic tumor, which is area in tracheal or main stem bronchi. It is low cost because with the rigid bronchoscope only you can do the coring and immediate relief can be seen. Major complication is bleeding, slough and mucus, which can be seen. But once if you're doing the coring out, the radial pressure of the bronchoscope can help in preventing any of the bleeding. And with the flexible bronchoscope, you can clear the distal secretions also. Another device which has come in the market is microdebrillator. It is an electric powered instrument with the rotating blade and suction capability. From the Medtronics, it is available in India. Electrocautery, it can be used to generate the heat. Multiple devices are there, knife, probe, snare, and cutting blade. It can be done with a flexible or rigid bronchoscope. Most of the people are doing it with the flexible. There are two modes in coagulation mode and cutting mode. Coagulation for stopping the bleeding, cutting for cutting the tissue can be used. You can change the settings as per your requirement. Is also called as the cheap laser, or because laser is very costly compared to this is cheaper. Disadvantage, bleeding, if it occurs, then your cautery is not going to help there because with the blood, everything current will be just pass. Airway perforation, fire, it can be there. And you require repeated cleaning of the probe while doing the procedures. And sometimes it can take 2 hours, 3 hours for doing some procedure with cautery. APC, it is also like electric hot therapy in which argon gas is passed through the channel. And at the end, the current is passed, which helps in burning the tissue. So it is a non-contact laser or non-contact electrocautery, some people say. It is good for hemostasis. It has come into our bronchus setup from the gastroenterology, in which they are use it rapidly for your ulcers and all those things. They are using it again and again. And it is also easily available in most of the hospitals because it is always available with a gastroenterologist people. You can ask for the pros from the bronchus and can use at your setup also in private setups. Depth of the penetration of APC is much, much lesser, 2 milligrams. So you may or may not be able to use it for your removing all tissue. And with the all hot therapies, risk of fire is always there. So whenever you're using any hot therapies, you have to keep your FiO2 less than 40%. It is must because once endobronchial fire will start, it is very difficult to stop it and it can burn your flexible bronchoscope also. These things are much, much important because these procedures takes too much time. Maybe after 1 hour, sometimes you will lose your concentration and you may not be able to decrease your oxygen. This is the thing which is have to be taken care again and again. Lasers, it is costly thing, but it gives a rapid response. It can cut, it can coagulate, or it can vaporize the biological tissues. It is good for central lesions, which are less than 4 mm. Preferred is rigid because it can also cause fire. The flexible chances are that the fire is much more. Contraindication, if it is continuous involvement of esophagus or bronchus with the tumor, or maybe tumor involving the pulmonary artery, because bleeding can happen very fast and patient may end up in death. The new laser NDF, which is cheaper, portable, and better coagulation properties, but they are too much costly. Cryotherapies, yes, we have used it. Many people are using it again and again. It has two types of role, mechanism of injuries, physical and vascular, which is later. It also has some role in immunity, which they say it activates the NK cells. It is suitable for high vascular tumors. One thing is you can just take out you can remove all the tissue at that time also, which is immediate relief, or you can just freeze all the tissue and later on it will just shed off itself. So these are things which can use with the cryotherapy. Now these days, most of our cryotherapy is being used for the biopsies, but yes, you can use it for your getting the lumen also. It can be used in carcinoma in situ, microinvasive cancers, in also post granulation tissue after airway stent you can use after dilating your stenosis also. And more these days, because of lung transplantation, most of the patients are having too much of granulation tissue. These are being used. These are low cost or no risk of fire. Another thing which is basically for the extrinsic compression is your airway stenting. These can be used temporarily or chronic according to the requirement of the patient. Two types of stents are available, silicone and metallic. I'll just go into three, and different configurations are available according to the patient need. It helps in maintaining the patency and improve symptoms. There are issues with this migration, granulation tissue, and mucus plugging, and other complications are also there. If you compare with the SEMS or silicone stenting, yes, silicone will require rigid, difficult deployment, but they are easy to remove. You can remove it after 1 year also, after 2 years also, because they can be easily removed. There are high chances of migration also. But an on-site customization is possible with silicone, but it is not possible with your metallic stents. You won't find any tumor in growth because it's totally covered. It has little tissue reactivity because it is silicone. And if there is an airway which is tortuous, stents are much better. With silicone, you will find better mucociliary clearance and also less chances that it will erode through the wall also. Does these therapeutic procedures helps? They definitely helps. I'm just quoting 2 articles which have shown there's an improvement in dyspnea and lower function status. Patients who having more dyspnea and lower function status are the patient which improves much better with these procedures. And you will require a diversity of approaches and interventions for these procedures. It is not like if I am an electrocautery, I'll do each and everything. You may require cryo also, you will require rigid also. You require multiple guns with you to do all these procedures. So there are some principles for management of CO. Early diagnosis is essential. Early medical therapy, TB and fungus, ATT, antifungus you require. For sarcoidosis, IBD, RP, you require steroids also. Early referral and multidisciplinary involvement is required. Third one is you need to secure the airway through ET tube, through LMA, supraglottic airway, maybe through tracheostomy or rigid bronchoscopy, bronchodilators or heliox. Fourth one is bronchoscopic must be prepared to manage the complication. It is not like that always and always it is going to be in honeymoon period. You will find definitely some complication. You require a team which can help you. Sometimes your brain suddenly stops and you don't know what to do. At the time, your colleagues, everybody can help you. Treat the patient, not the image. It is an important thing. Just don't see the CT scan and say this patient requires the procedure. What are the symptoms? What is the patient requirement? Patient is an 85-year-old just on the bed ridden. You don't need to treat all these patients. Medical therapies are highly effective in many diseases of central area. So you should do bronchoscopy whenever it is much required. Otherwise, don't do. Intervene only when intervention is essential. Otherwise, don't do. These are not cosmetic procedures. These are the procedures just to relieve the patient's symptoms. So don't just go behind the cosmetics. Eighth one is do not place metallic stent in non-malignant disorders. Surgery is beneficial in selected cases like complex PITS and complex PTTS. And regular follow-up is essential. You have to call this patient maybe weekly or once in a month to follow up with you and to clear their secretion, to clear their issues. It is not like once I have done the procedure, I am finished. At the last, I'm just going to discuss a case in very fast. It is a 72-year-old male. He was difficulty in eating. Endoscopy was done. They have diagnosed esophageal malignancy, squamous. Endoscope could not be passed through the stenosis level. And they have decided to go for the palliative treatment. They have done the MDM meeting between oncologist, gastro, and they have put a esophageal stenting. After this was a PET scan in which we can see there's an esophageal malignancy and which was compressing the trachea also. But nobody called me at that time. And gastroenterologist has put a esophageal stent. After that, post-stenting, he developed respiratory failure. Second day, left side collapse was seen. He was intubated and ventilator was initiated. At that time, they called me what to do. I went and I knew what has happened because it has happened before also. So we did a bronchoscopy. Sorry, this bronchoscopy image was not, video is not working. But left side total collapse was there. And which can be seen, esophageal stent with left main bronchus was totally collapsed. So when we did the bronchoscopy, we were not able to pass our bronchoscope through the left main bronchus. We used the C-arm First, we've inserted the guide wire. Over that, we have put a deployer. And after that, this metallic stent was inserted in this patient. I have taken the help of C-arm because just to help me out to see whether I'm not going into any other areas. This is how we put the stent. This is the carina, left main bronchus, right main bronchus, and this was the X-ray post-procedure. So these are two stents which are here. So this is the case of double stenting. So take-home messages: prevalence is increasing of CO, different etiologies, bronchoscopic measures, dilation, ablative stenting is required, multimodal therapy, and surgical measure definitive for benign, risk for major surgery and anesthesia. Just respect to this case, I just want to ask Dr. Arjun. Arjun, would you like to put a silicone stent here or like over the metallic, or Ajmal sir will say yes to what?
Actually, in these kind of patient, either you can put a silicone stent or a metallic stent. Because both of them have a almost more or less same kind of efficacy. We have a published paper of 29 patients where we have put a dual stenting in a esophageal CA, and we have placed all the silicone stents only. But the difference was that we placed all the stents before the gastroenterologist has put the metallic stent. First, we placed the stent in the airway. Then the gastroenterologist put the stent in the esophagus. So it is the choice of the operator who is doing the procedure to choose between the stent. There is nothing specific that the metallic will help more or silicone will help more in these patients, because of the very few limited of kind of a life expectancy there with these kind of malignancies.
Dr. Rangnath, if you want to say.
Regarding one point where non-management disorder, you've seen them increasingly use a non-management disorder. That's because of the ease of putting in the stent as compared to silicone stent and not having the requirement for a rigid bronchoscopy for the stent. Secondly, the earlier the problems that we had were associated with removal of the stent. Nowadays, we see that with the silicone covered stent, the tumor inflow is very less and the stents can be removed. So that way, I feel we are moving towards more on the silicone covered or metallic stent. Yeah.
Only thing is that with silicone totally covered is most of the time the which is available is partially covered. So their ends are not covered in metallic motion stent which are available, and they cause a lot of granulation tissue.
But I will definitely say that if you have a benign condition and if you want to put a covered metallic stent, I would say.
So many times we have seen like patients who has come after malignancy. Now the time will come in future also that many of these patients will also improve. Like I think Ajmal sir has also told me about one case of adenoid cystic carcinoma, which he has gone to Bombay also regarding the treatment and everything. And he came back and we have inserted the silicone. And he came back and please remove my stent. If it was a metallic stent, it is always difficult. So we may see in future also that these cancers are also being treated. So another thing which I want to add, and what we have put in also metallic also, after 1 year also, sometimes their membrane also comes out in metallic. There are some cases also. From the covered, they totally becomes uncovered metallic. And you have to sometimes insert another stent on these patient, overlapping stent to cover it. So these membranes are not very like silicone thing, which are permanently will stay there. Break it also.
Basically,
there is no doubt we have
Sir, actually thing is when
basically work in two centers. It was in another center where rigid was not there. So at that time, the thing is, I have to, because he was on the ventilator, I cannot shift him. So that's why I put a flexible, and he was old age, the palliative care was there. So I knew anyways he's going to. Rigid. Flexible.
Actually, overall in a central airway obstruction, the major point is ki you should be knowing ki what procedure we are going to do in this patient and whether it is indicated or not indicated. Recently, recently there was some incidents. Patient with the tracheobronchomalacia went to some center and he had a functional central airway obstruction. They have placed a stent and what they did is they have converted this into a fixed airway obstruction from the functional airway obstruction. So the most important part of the central airway obstruction is to know when to intervene. Number one. Number two, like this silicon and metallic, it is a gray area. It is a choice preference also of the operator. Because what Loveleen was talking about adenoid cystic carcinoma, we have removed the stent after 2 years. And still there is one patient who is under our follow-up. We have placed a silicone stent 5 years back. He is living with that stent for 5 years. So all these kind of a outcome is not possible with a metallic stent, because metallic stent has a half-life, that life of after 3 months, if you want to remove it, it has to come out in a piecemeal. It will never come out as a single stent. So the removal is a very difficult part if in case it is required to be removed.
Dr. Rangnath, your experience?
Yeah, I agree with Ajmal sir completely. Even we had cases where patient was inserted a SEMS and stent was stuck and he was again having a recurrent area of obstruction. We had to remove it in piecemeal. And basically it's the preference of the operator who wants to insert the stent. And it should be always be done in setups where you have ideal for both converting and flexible bronchoscopy into a rigid bronchoscopy. I would like to add one more thing. In our setup, we are getting patients, I mean, children who are developing tuberculosis are having, they're developing static bronchi. So these are the patients whom we need to screen by a repeated bronchoscopy to look for presence of tracheal ulcerations and bronchial ulceration, which can lead on to tracheal and bronchial stenosis, and they ultimately go into something called as a cut-off lung. So they automatically lose their lungs, and these are the patients where we need to screen, and we can prevent the tracheal stenosis by repeated balloon dilatation or use of oral steroids.
I think Karan is working on it from New Delhi, and recently in last 2 to 3 years, there are a lot of papers from the Chinese population where they have screened the patient of a pulmonary tuberculosis with a CT scan and a bronchoscopy to look for any endobronchial lesions. If they have an endobronchial lesion, they have followed up this patient and they have intervened before any kind of a obstruction has developed into this patient. They have shown a very excellent results. However, in our scenario, most of the patient, we have also screened few of the tuberculosis patient, and what we have found it, when the patient comes, they have a very advanced stage of endobronchial involvement when they come at presentation. So it is very difficult to do any kind of an intervention because the mucosa is very fragile. And if you do an intervention at that moment without giving anti-tubercular treatment, there might be a perforation of the airway. So these kind of the patient are a little bit controversial as of now, because if the patient is having an active tuberculosis, whether you want to do a bronchoscopy or not, all those are issues.
There is a lot of ethical concern because there is a lot of aerosol that is being generated, and the atmosphere can become infective. But once the patient is already on treatment for more than 2 months, and if he's having some airway symptoms like static bronchi or getting dyspneic on minimal exertion, so these are the patients who should be screened for bronchoscopy to look for tracheal bronchial stenosis.
In these kind of a patient, if there is a strong suspicion, they should be screened with a CT scan. And if there is any airway involvement, one should go ahead with the bronchoscopic intervention.
Thank you, sir. Thank you, speakers and chairperson. It was indeed a very informative and eye-opening session. I would now like to request Professor Ajmal Khan, sir, to give a memento to one of his favorite students, Professor Loveleen Mangla, sir. May I now request Professor K.B. Gupta, sir, to please come on the stage to please give a memento to Professor Ajmal Khan, sir. I would also like to request sir to please give the memento to Arjun Kashyap, sir. May I now request sir to please give the memento to T.G. Ranganath, sir. Once again, a very big thanks to the chairpersons and the speaker. We move on to our next session, which will be on the management of bronchiectasis in adults, which will be a comprehensive case-based approach. The session will be taken by Dr. Subodh Kumar, sir, and will be chaired by Professor Ajay Kumar Verma, sir, who is a professor, Department of Respiratory Medicine, KGMU, Lucknow. Dr. Hemant Kumar, sir, Associate Professor, Department of Pulmonary Medicine, RML, Lucknow. Dr. Amit Srivastava, sir, Associate Professor, Pulmonary Medicine, ERA Medical College, Lucknow, and Dr. Arif Siddiqui, sir, Associate Professor, Prasad Medical College, Lucknow. May I please request the chairpersons to occupy their seat of procession on the dais, and please introduce the speaker for the session.
At the outset, I would like to congratulate Professor Alok Nath, sir, and his team for organizing such a wonderful CME. And it is my proud privilege to welcome my batchmate, Dr. Subodh Kumar, who is now Professor and Head, Department of Pulmonary Medicine at AIIMS, Gorakhpur. Over to Dr. Subodh.
थैंक यू डियर डॉक्टर अजय। ये मेरे लिए बहुत ही भावुक पल है कि मैं यहाँ 2010 में जनवरी 2010 आई ज्वाइंड हियर as a resident, and when I entered in the department and institute, I asked where the interview venue for the SRs. People told just go and join, interview taken later on. And I started my journey, and whatever I am here today, it's because of this institute, my mentor, Dr. Alok Nath sir, Ajmal sir, and G. Hasim sir. And definitely without wasting time, I will start my case-based discussion. Preferably, I try to make it just like ward side round, it's a bedside round, and then case-based discussion. I try to accommodate 2 cases here, and if possible. My first case is a case of, before going to actual case discussion, the causes of bronchiectasis, actually there are, according to Indian registry and data, as Dr. Rajadhar enumerated, in our country, the most of the time we get the bronchiectasis case as a post-tubercular, post-bacterial infection, idiopathic or allergic bronchopulmonary aspergillosis. And in Western literature, definitely there are different data like cystic fibrosis and others. My first case is in fact 36-year-old female which presents with the history of dyspnea, and that is progressive since long history. It's actually 10 years old history. And she is also having history of productive cough with mucopurulent sputum. The amount of color, volume, and frequency of sputum has changed from time to time. The patient progressed, and there is exacerbation of symptoms since 1 month, and she landed in the hospital in the MMRC grade 4 of dyspnea. She had past history of hemoptysis. She was admitted some other hospitals twice in the last 1 year, and the history of ATT for 1 year, 2 years back. On examination, patient had tachycardia, tachypnea, hypoxia, respiratory 87% of SpO2. The clubbing was present, and on auscultation, there was rhonchi and crepitation of bilateral lung fields. The chest X-ray, there is bilateral cystic lesions and the air fluid levels both sides. My question is, Dr. Ajay Verma, what are the bundle of investigation required in this case to go ahead, and what is the next best investigation in this case?
Usually diagnosis of bronchiectasis is made clinically, and HRCT is needed to confirm the diagnosis. So investigations are usually aimed at confirmation of diagnosis, identifying the treatable cause, and optimizing management to prevent further exacerbations. So as far as bundle of biochemical investigations are concerned, we should do total and differential cell count, immunoglobulins, immunoglobulin G, A, and M, and screening for ABPA is very utmost importance. That is total IG, specific IG, and IgG to aspergillus and eosinophil count. And for next best investigation, as I told, is HRCT thorax. And based on the clinical history, radiological features, and severity of disease, HRCT is advised to establish the diagnosis of bronchiectasis.
Well said, Dr. Ajay. That's guidelines also say that each and every patient who is under consideration for bronchiectasis should undergo for this complete blood count, immunoglobulin level, and rule out the allergy bronchopulmonary aspergillosis test. And additional tests like rule out for the cystic fibrosis, CTD related disorders leading to bronchiectasis, they to be dealt as a case-to-case basis. In our patient, this was the investigation, the leukocytosis, neutrophilia 92%, hemoglobin 11.1, platelet counts normal, CRPS was normal, a little bit raised, total IG and a specific IG for specific was normal. Now, this is the HRCT scan. As you told, the next best investigation. There is a cystic changes in the right side and middle lobe and lower lobe, and as well as lingula of the left side. HRCT, this is the radiologist report needed to discuss. My question is, Dr. Hemant, how will choose antibiotics in the management of bronchiectasis in this case? And what all of antibiotic you will use, and how long you will give the antibiotic in this case?
So this is classical case of acute exacerbation of bronchiectasis, and we know that this is vicious cycle. Colonization, inflammation, then infection, again colonization. So we have to prevent this bacterial load and prevention of secondary airway inflammation. So choice of antibiotics depends on severity of underlying disease, comorbidity, and the previous culture reports. So not for this patient. Otherwise, the means we have to see what were the colonization. In our area, means our this Indian population, Pseudomonas is common organism, while in Western H. influenza staph aureus is common. So what guidelines suggest we should give levofloxacin or ciprofloxacin, but in Indian setup, we are endemic for tuberculosis, so we would prefer anti-pseudomonal cephalosporin or carbapenems. Regarding this case, as you told, this patient has already three times hospitalization. In such type of patient where patient is having 3 times or more than 3 times exacerbation in a 1 year, we should give long-term antibiotic course to prevent further exacerbations. So it will depend on what microorganism we are going to find. If it is Pseudomonas, we would like to give inhaled antibiotics. And if it is non-pseudomonal, then we can give long-term macrolides. Lot of studies are there like Embrace study or many studies are there. So regarding how long should we give treatment? If it is first exacerbation, we have to give antibiotic for 10 to 14 days. But in this case, since patient is having 3 times exacerbation, we need to give at least 3 months. So 3 months antibiotics required in this case. What antibiotics depends on what culture patient is going to grow.
Well, this is if you get the bug in the sputum culture report, you will choose antibiotics according to culture and sensitivity. Many times we get the Pseudomonas, and most of the time we may not get the Pseudomonas, and if it is welcome report, if Pseudomonas is not there in the reports. If there are reports of Streptococcus, H. influenzae, and Moraxella, MRSA or MSSA, you have to choose the antibiotic according to culture and sensitivity reports. What are the, as Dr. Hemant told and the guideline says, if there is a more frequent exacerbation, like 3 or more than 3 times, you have to give the long-term antibiotics in the form of inhaled therapy, or if there is a patient tolerate in the form of oral therapy. If the patient is Pseudomonas, you have to choose different way. If not Pseudomonal, you have to choose the different antibiotics. ERS guidelines say that we should give antibiotics for 14 to 21 days. But in some cases, you can choose antibiotic duration less than 3 weeks. In the case of mild bronchiectasis, or patient is there is no comorbidity. If the patient is Pseudomonas airway colonized with the Pseudomonas infection, the choice of antibiotics in the form of inhaled are colistin, inhaled gentamicin, and if the patient is not tolerating the inhaled medications, you should give the oral antibiotics, as sometimes there is a need of combination of inhaled plus oral antibiotics required. When the patient is not controlled only on the inhaled antibiotics, you have to add on the oral antibiotics for Pseudomonas case. There are 3 landmark trials given that have supported the use of inhaled antibiotics in the treatment of chronic airway colonization, like the Pseudomonas. These are the Embrace trial, Bless trial, as well as BAT trial. They all says that with the use of inhaled antibiotics, there is a decrease in the exacerbation reported. The fall in the FEV1 was less in the inhaled antibiotic limb than the placebo, and the patient quality of life was better. Now the patient is in the ward, and Dr. Hemant, you have received there is a report, patient shows that the tuberculosis is negative and there is a Pseudomonas in the sputum. How you go for this patient, as discussed in the history?
So this patient is growing Pseudomonas. So Pseudomonas is one of common organism which is used to colonize in this airway. And Pseudomonas is something that it increases repeated exacerbation, and it increases 3 times mortality and 7 times hospitalization. So anyhow, it's going to reduce quality of life by repeated exacerbation. So once you find Pseudomonas at first time, you have to eradicate this Pseudomonas. So ERS guideline 2017, it strongly recommend the antibiotic for eradication of Pseudomonas. But no Pseudomonas, there's no recommendation by ERS. But some other guideline like that Spanish guideline, ETS guideline, they have weak recommendation for non-Pseudomonal. Now, what's the regimen? So we have 3 protocol. We have 3 basket in our hand to eradicate Pseudomonas. First is ciprofloxacin. Another one is dual anti-Pseudomonal antibiotic. One is cephalosporin plus aminoglycosides. And third one is inhaled anti-Pseudomonal antibiotics like colistin, inhaled tobramycin, like that. So what we can use depends on sensitivity pattern. If we don't have sensitivity pattern, we can go for protocol 1, that is oral ciprofloxacin, and we have to repeat culture after 2 weeks. If it is negative, then we can go ahead with same antibiotic for 3 months. If it is showing positive reports, then we have to change to dual antibiotics like anti-Pseudomonal cephalosporin like ceftazidime, cefaporazone plus aminoglycosides like gentamicin or tobramycin. If again sputum is showing positive, we can go for third protocol, that is inhaled antibiotics. So inhaled antibiotics along with either oral ciprofloxacin or IV anti-Pseudomonal antibiotics. But keep remember that we should give for at least 3 months. Then only we can reduce colonization.
Thank you, Dr. And as he discussed, that eradication is indicated in this patient, and guidelines also support his views that actually eradication is required in this case. And eradication in the form of either oral or inhaled, and at least not less than 3 months. And once 3-month therapy is completed, it's not actually easy task to continue antibiotic with the 3-month patient. Usually don't take. In fact, many times most of us are practicing the bronchiectasis treatment. I don't think many patients are going to take this regimen. And if once the therapy of 3 months is completed, you have to do the culture repeatedly for up to 6 months to show if there is no growth till 6 months, then complete eradication is achieved. This is the regimen as he described in details. Dr. Amit is our next panelist. I would like to ask whether our use of antibiotics as well as oxygen is going to suffice or something else is required. As written, what is the role of respiratory physiotherapy and what are the mechanical airway clearance devices indicated advised in this case?
So it's mainly pharmacological treatment. The first thing that comes in our mind when we talk about the physiotherapy, that some external treatment is going to be done. And in this disease, as the main culprit is pooled secretion, and to get rid of that secretion, we need physiotherapists. And they did by different, initially by positioning, in which gravity assisted drainage is done with the help of chest percussion with or without forced expiration. Secondly, by force expiratory flow modification, they do by blowing games or force expiration, and then autogenic drainage. Autogenic drainage actually is a very simple, it's a control type of breathing in which they uses different depth of expired air uh, uh, so that the mucus passes to the upper airways so that it can be expelled out in a very simplified form. And the third one is they did by instrument in which they use force oscillatory PEP, that is positive expiratory pressure with or without nebulizer. And second one is force oscillatory PEP with or without force expiration. And the third one is high oscillation chest wall movement. That is also known as the West therapy.
Well, he described different mechanical devices used for the removing the in fact sputum or secretions in the airway, because the persistent airway secretion, many times we do the bronchoscopy, we see copious amount of sputum or purulent secretions coming. Definitely that is required to be drained out in the form of postural therapy or some whatever they described in the form of mechanical devices. As he told about, there is a active and as well as mechanical devices to remove the secretions are adequate in the literatures. And most of the time we use, this is very commonly applicable, commonly used in our practice. And one literature was published, actually Murray and Liddell did a research work, a randomized trial on this device. And he told that this device is very useful in removing the secretions as well as patient quality of life. Now, this is the X-ray after 2 weeks of antibiotic treatment. This is the first X-ray in the left-hand side, and right-hand side after 2 weeks of antibiotic treatment. And we see there is a significant reduction in their fluid level as well as improvement. Now, patient is fit for discharge. My question is that Hemant, what is the role of anti-inflammatory in this case? Is inhaled steroid indicated in the bronchiectasis? And how is choose the bronchodilators in the treatment of bronchiectasis?
So regarding anti-inflammatory drugs, so we are having that azithromycin, macrolide. So this is not only antibiotic, but immunomodulator also. So in long term, it reduces inflammation, then colonization. So as patients are having more than 3 times hospitalization, so we should give anti-inflammatory in this patient. So what guidelines says that for non-pseudomonal, this is first line, azithromycin. For pseudomonal, we should give inhaled antibiotic. If it is not responding to that, then we should give azithromycin. There are new drugs like brensocatib, which is dipeptidyl peptidase 1 inhibitor. It reduces neutrophilic inflammation in airway. And this is in phase 3 study. So in future, we may get this anti-inflammatory drug for bronchiectasis. Regarding inhaled steroid, so routinely left and right, we should not use inhaled steroid. If patient is underlying bronchial asthma or eosinophilic asthma, then we can use inhaled steroid. Bronchodilators, there are 2 indications. If patient is having underlying obstructive lung disease like asthma, COPD, and already taking bronchodilator, then we can continue this bronchodilator. Another one is when we are prescribing inhaled antibiotic for bronchiectasis. First, we are giving challenge of this antibiotic to a patient. If there is significant reduction in FEV1 or FVC, then we are using bronchodilator and we are checking PFT again. If it is good range, means if even the reduction is less than 15%, then we are going ahead with antibiotics. So in that case, if patient is having positive bronchial challenge with antibiotic, we have to give short-term bronchodilators. So there are two indications: either patient is having underlying obstructive pulmonary disease or patient is having hypersensitivity to inhaled antibiotics. So in these
Well,
two conditions, we use bronchodilators.
It's well said that there is no contraindication to use the ICS in case of asthma bronchiectasis. And if there is a patient of obstructive airway disease, you have to use the bronchodilators. But most of the time, we are driven with the thoughts that if there is a bronchiectasis, you should give the either LABA, LAMA, or SABA, because these are used to increase the mucociliary clearance. And many times, all are each and the patient of bronchiectasis are taking the LABA, LAMA, or SABA without any in fact, proven diagnostic proof. Now, he has well covered this in his comment, and we are moving to second case. This is actually not the first time patient I have seen. This patient has shown many places because the childhood history. This is a 21-year-old female presented in the outpatient department with the complaints of recurrent cough, cold, and dyspnea since childhood. She has progressive symptoms, multiple episodes of pneumonia since childhood, as the parents told. There is a history of inhaled medications the last 10 years and frequent exacerbation. He has a history of pneumonia and there is use of anti-tubercular medications and ear and nasal discharge. On examination, there is a history tachypnea, tachycardia, partial hypoxia, and chest X-ray. This is the chest X-ray of the patient that is described. This X-ray shows that there is a, sometimes people told that our PG told that there is wrong marking in this case, but actually it is not wrong marking. There is a dextro position. There is a complete dextro position in this case. The heart is on the right side, gas spindle gas on the right side, nickel on the right side. It is a complete dextrocardia, right side gas on the diaphragm, bilateral bronchiectasis, and the complete case of situs inversus, and fulfilling the case of Cartagena syndrome. This is the CT scan of this patient showing the bronchiectasis in the lingula as well as lower lobe. That's described in the radiology. Dr. Ajay Verma, would you like to the focus whether the distribution of bronchiectasis have some role in the diagnostic workup? What is the distribution of bronchiectasis in the PCD I discussed in this case? And what are the investigation to check to, in fact, prove the diagnosis of PCD in this case?
Usually, lobar distribution of bronchiectasis indicates type of disease. In our country, tuberculosis usually often unilateral or asymmetrical usually leads to bronchiectasis, post-tubercular cases. ABPA also leads to bilateral asymmetrical central bronchiectasis. In Western world, cystic fibrosis, usually central and peripheral, is responsible for upper lobe involvement. As far as non-tubercular mycobacteria and primary ciliary dyskinesia is concerned, they involve middle lobe and lingular lobe. Lower lobe involvement is more common in viral infection, chronic aspiration, primary ciliary dyskinesia, and immunodeficiency. So distribution of bronchiectasis in primary ciliary dyskinesia is usually in middle lobe, lingula, and lower lobe with a central or diffuse distribution. For primary ciliary dyskinesia, investigations required advocated are nasal nitric oxide, high-speed video analysis examination of nasal epithelial cells, static cilia, and saccharine test.
Okay, well, many times we are left with a few investigation of radiological basis, like if there is a complete cytosynthesis and history goes in compatible way, we go by the diagnosis of primary ciliary dyskinesia, because diagnosis is not very easy to establish, complete diagnosis. As he told, there is some lobar distribution, and primary ciliary dyskinesia usually affect the middle and lower lobe, as described in this case. And HRCT findings, as he told, in fact. Now, what is the, would you like to rule out cystic fibrosis? This history is compatible because patient is suffering from very young age.
Yes.
And He told, yes, please.
Although cystic fibrosis is quite common in Western world, but if presentation is below less than 50 years, we should always think for the cystic fibrosis because it is a lethal, life-threatening disease. So we should also consider to rule out cystic fibrosis.
Well, but there is some history also seen in the patient of cystic fibrosis, like the abdominal symptoms, failure to thrive. These are all many times malaviation syndrome, pancreatitis are seen in this case and patient of cystic fibrosis. Now, Dr. Amit, this is the case of primary ciliary dyskinesia, where there is a ciliary concern is importance. There is a role of, what is the role of airway clearance? What is the use, how you optimize the use of mucolytic in this case, and whether the airway clearance therapy is a matter of prime concern in this case, then other case of bronchiectasis?
Sir, actually, in this, there is a loss of ciliary function. So, pharmacological and non-pharmacological both play an important role in this. Non-pharmacological, I have discussed earlier case. And in case of pharmacological, mucolytic therapy is the best therapy. And in that, we use humidification, saline, 0.9%, 3%, 7%, and inhaled mannitol, and oral bromoxine, and N-acetylcysteine. And the role of all the mucolytic agents are to just clear off the secretion that are pulled up.
Okay. The last question is there is a definitely the airway clearance therapy has a much concern in this case because the ciliary motility that is a very much important in the removing the secretion in the bronchial airway. This is not, they are poor functioning or not functioning. So the very much emphasis is to give the airway clearance therapy in this case, airway clearance mechanism that to be well treated, well told to the patient by the respiratory physiotherapist. And as he discussed, and as well as guidelines says, there are a lot of mucolytic agents like saline, humidification, mannitols, salines. If you combine the mucolytics as well as physiotherapy, they have better result than this individual one. And as mannitols are used in case of cystic fibrosis, DNAs are not required. ERS 2017 suggests there is no role of rDNAs in other than cystic fibrosis patient. And significantly, there is a much literature available related to N-acetylcysteine that showed improvement in the sputum volume as well as time to prolong exacerbation. Non-pharmacological management, as he told, that autogenic drainage in the previous case, there are 3 steps required. One step is creating the volume of sputum. Next step is the carrying that volume of sputum in the airway. And third step will be removing the airway volume of expectorant from the airway. That is the large volume tidal breathing. And this is the autogenic drainage step. Patient takes first step is small breath, then medium breath, and that is the third is the large volume breath to remove the sputum or secretions from the airway. This is the most commonly practiced air mechanical device, mechanical therapy by the bronchiectasis patient as discussed in literature. Now, this patient is a case of ciliary motility disorder. Definitely, we have to counsel to go for her gynecological department for the reproductive counseling as well. Now, at the end of the case, I would like to say that bronchiectasis is definitely the multi-causative disorders in our country. Post-infectious, post-tubercular is very much concerned. We many times forget the workup of allergic bronchopulmonary aspergillosis. Treatment definitely starts from the mucolytics, from the physiotherapy, from bronchodilation, and definitely long-term use of antibiotics. And we should not hold our hand to write down the long-term treatment antibiotic to eradicate the pseudomonas because that is lethal bug inside these patients. Thank you very much.
Thank you, respected chairs and speaker. I would now like to request Professor Ajay Kumar Verma, sir, to please give a memento to our speaker. May I now request Professor S.N. Gupta, sir, in the hall to please come on the stage to give the memento to our chairpersons. So please give a memento to our next chairperson, Dr. Hemant Kumar, sir. A memento for Dr. Amit Srivastav, sir. I once again thank the speakers and the chairpersons, and we move on to our next session, which will be on overlap of asthma and obstructive sleep apnea, which will be a case-based discussion, will be taken by Dr. Khushbu Saxena and will be chaired by Dr. Arshad Ijazi, who is a consultant pulmonologist in IGIMS Patna, Dr. Jyoti Bajpayee, who is Assistant Professor, Department of Respiratory Medicine, KGMU, Lucknow, and Dr. Rishabh, Assistant Professor, Pulmonary Medicine, Era Medical College, Lucknow. I request the chairpersons to please occupy their seats, and I request them to please introduce the speaker for the session.
Good evening, all. First of all, my huge gratitude to all my senior consultants who have availed me this opportunity to be on this side of dais and being able to speak a few words about this interesting topic of asthma and asthma and OSA overlap syndrome. So unlike detailed discussions which have happened already, we do not have much studies, evidences, guidelines. So what I will be discussing today is more of our experience as well as the panelists' experience over here. I welcome all the panelists over here, Dr. Arshad, I think Abhishek Verma sir is not there, Dr. Jyoti, Dr. Rishabh, and I'm Dr. Khushbu Saxena. So I would want to discuss the case history first of all. In my OPD, I encountered a 58-year-old female who was a school teacher, and she was resident of Shadol, MP. She denies addictions. She did not have any drug allergies. She presented to OPD with the complaints of increased difficulty in breathing for past 7 days, which was associated with wheezing. She also had cough with mucoid expectoration for past 7 days and 2-3 spikes of high-grade fever, which subsided over 2 days. And for 4 days, she was afebrile. As per the patient, she was apparently all right 7 days back when she developed throat pain, rhinorrhea, headache, and fever. She describes her dyspneas as follows. Earlier, she would be breathless on climbing 1 flight of stairs, but for past 7 days, she is unable to do her household activities or to go to school. I'm really sorry, I'm also having some dyspnea, probably because of my asthma. Kindly excuse me for that. So she complains of similar complaints in past with seasonal variation for which she requires hospitalization for 1 to 2 times every year. She is already a known case of systemic hypertension for past 5 years, for which she is on triple antihypertensives. Recently diagnosed with diabetes mellitus, bronchial asthma since childhood, and is on pressure MDI, salbutamol on SOS basis only. I checked the technique, which was not correct. Also, she was taking tablet Derifylin 150 mg. She would also take over the counter steroids, that is Texa tablets, whenever she experienced increased difficulty in breathing. Past surgical history includes total hip replacement 4 years back, due to avascular necrosis of left hip. She also has a positive history of COVID-19 related severe acute respiratory illness in 2021, which required ICU admission. There is no past history of TB or ATT intake. On probing on the environmental history, she says that there is some dampness in her house, and she also pets a cat in the house for past 4 years and feed pigeons grains on the terrace. Basically, she had all the components for an uncontrolled asthma, along with the phenotype of obesity. So on examination, she was quite conscious, well-oriented to time, place, and person. Saturation was 92% with ambient air. Pulse rate was 94 per minute. She was hemodynamically stable with BP of 128 by 80 millimeters of mercury, and her respiratory rate was 20 breaths per minute. There was no pedal edema on examination. On upper airway examination, she was having Mallampatti grade 4. That is, only hard palate was visible on upper airway examination. On auscultation, bilateral extensive polyphonic rhonchi were heard all over her chest. On doing anthropometric indices, height was 160 centimeter and weight was 93.4 kgs. BMI was 36 kg per meter square. Neck circumference of 36 centimeter. However, her abdominal circumference was 112 centimeters. Positive lab investigations revealed eosinophilia of 8% with absolute eosinophil count of 720. Her total serum Ig was 612, but ABPA panel was negative. That is, Aspergillus fumigatus specific IgE as well as IgG were negative. She also underwent a 2D echo, which showed grade 2 diastolic dysfunction, mild pulmonary hypertension with RVSP of 45 millimeters of mercury, no RA or RV dysfunction, normal left ventricular function with ejection fraction of 60%. So at the time of presentation, we could not perform a spirometry, but on this patient was basically admitted and she was treated with a short course of steroids and supportive management as per the line of acute severe asthma. On the follow-up visit, we performed a spirometry, which showed a FEV1 of FVC post-dilator was 74.2, whereas FEV1 and FVC were preserved, that is 82 and 86% respectively. If we see FEV1 25 to 75, then we would be able to appreciate that there was significant small airway obstruction, that is 46% pre-bronchodilator and 41% post-bronchodilator. There was no significant bronchodilator response. On the basis of her anthropometric indices and on probing on her sleep history, she revealed that she would snore very loud. Her snoring can be heard in the other room as well. And she would feel sleepy whenever she would sit idle in the house in the daytime. We performed a whole night diagnostic level 1 sleep study, and the manual scoring was done as per ASM 2.6, which revealed AHI of 67 events per hour, which did not have any positional or REM predominance. Events were predominantly hypopneas with arousals and desaturations. Her ETCO2 was also connected, which did not reveal any nocturnal sleep-related hypoventilation. So this was the case wherein there were multiple factors which led to uncontrolled bronchial asthma, along with the phenotype of obesity. So may I now ask Dr. Arshad Ejazi, what is the prevalence of asthma or OSA overlap syndrome in overall globally, as well as what is your experience in your practice? How frequently do you encounter this kind of phenotype in your practice?
That's a good question because both asthma as well as OSA share the common risk factors like obesity, rhinosinusitis, and GERD. Yeah, these three things are common in both the disease. So the literature that says that in Wisconian studies there is a 4 times increase, and there is a meta-analysis done way back 4 or 5 years back. In that they have seen that approximately 2.5 times higher risk of OSA in patients of asthma, as well as the risk of OSA increases with the severity of airway obstruction in the patients of asthma. That means if the asthma is more severe, the risk of OSA is also more in those patients.
Very rightly said.
So I would like to add one thing, Dr. Khushbu here. Dr. Jyoti.
Yeah.
So I just like to say here that is a case of bronchial asthma with multiple risk factors. So whenever any asthma, we see the case of bronchial asthma with difficult to treat or severe asthma, we have to look out all the risk factor. Like in this case, so there is a atopy history, there is a sensitization to house dust mite, and there is a obesity. This patient is obese, and she is a known case of bronchial asthma since childhood. So we have to look at all the comorbidities, all the risk factors, and as we know that the Ashif said regarding the prevalence of OSA in bronchial asthma. So every second, meta-analysis said that every second case of bronchial asthma suffering from OSA. So prevalence is about 3 to 50%. So this prevalence is coming from the longitudinal studies, cross-sectional studies, and some of the observational studies. So at least 50%. So every second patient is a bronchial asthma who is difficult to treat asthma or severe asthma is suffering from OSA. So we have to look out obstructive sleep apnea in every bronchial asthma patient who are difficult to treat or uncontrolled or severe asthma. As doctors said, 4 times there is a higher risk of OSA in bronchial asthma patient as per the some of the studies. So this is very important to look for bronchial OSA in bronchial asthma patients.
That's very rightly said, ma'am. Actually, whatsoever data that we have is not level A evidence, and the cutoff that we had been using, the ASM definitions, which had been, changing over the period of time for hypoapneas and apneas and all. So there is a variable in the content as well. I mean, the severity of OSA, as well as there is no standard questionnaire which has been developed to screen patients for OSA in asthma, wherein we can, directly suspect and subject patient for sleep studies. Also, cost is a factor in our country wherein patients usually do not get, they do not give consent to go ahead with the sleep study. So since Abhishek sir is not there, what kind of relationship these comorbidities do they share? What are the common risk factors for both? May I ask Dr. Rishabh or Dr. Jyoti?
So as I already said, and Dr. Arshad already said, there are 3 common, the asthma and OSA, both are the bidirectional process. So both share some common risk factors like obesity, GERD. These are the common comorbidities, and and rhinosinusitis. So rhinitis is a very common factor, like, and GERD also very common, and obesity. So both share the 3 most common comorbidities shared by the both the diseases. So we have to look for those patients of bronchial asthma having the rhinitis, like 80% of the population of bronchial asthma suffering from allergic rhinitis. So in these cases, there are higher chances of, because the inflammation is the process which leads to, there is a pharyngeal upper airway relaxations. So these patients are higher chances of developing OSA. So whenever the patient who had allergic rhinitis or GERD, we have to look for obstructive sleep apnea in those patients.
Dr. Rishabh, if you could just tell us about when would you suspect a patient to have OSA while having uncontrolled bronchial asthma as well?
Okay, so when we're dealing with a patient of bronchial asthma and we want to suspect obstructive sleep apnea in these patients, first of all, as the panelists have already told, that they should have shared features of rhinitis, GERD, and obesity. After that, if the patient is also complaining of excessive daytime sleepiness, as the patient was, this case was seen, and the patient was complaining of excessive daytime sleepiness, and the patient had a lot of snoring, witnessed apneas, and then we can definitely suspect. Also, when we have actually ruled out that the patient is actually compliant with the inhalers, as this patient was actually not compliant with the inhalers, so it made it a case of difficult to treat asthma rather than uncontrolled. And if the patient is taking inhalers regularly and after that the patient is still having a lot of frequent exacerbations and reduced quality of life, that may occur in these cases when there's coexisting obstructive sleep apnea, because all these patients, they usually have a neutrophilic inflammation rather than the eosinophilic inflammation. And this neutrophilic inflammation, they do not actually respond very well to inhaled corticosteroids as they do with the patients who are dealing with IG mediated eosinophilic asthma. So all these questionnaires, and after correcting the inhaler technique and after looking out for the modifiable risk factors, if still the patient is not be able to control on regular inhalers, and then I think we should definitely suspect overlap of obstructive sleep apnea in such patients.
Thank you so much, Dr. Rishabh. And if Jyoti ma'am could just briefly enlighten us about the basic pathophysiology of OSAS.
So as I said, asthma is there are two kind of bronchial asthma, TH2 inflammation and low TH2 inflammation. As we know, there is allergic bronchial asthma and non-allergic bronchial asthma. So in allergic asthma, there is a eosinophilic inflammation or allergic kind of inflammation. So as we know that bronchial asthma is a inflammatory disease. So this lung inflammation can lead to disbalance or imbalance in between the peripheral or central chemoreceptors and central breathing system. This stabilizes the central breathing system. This leads to there is a upper airway relaxation or upper airway opening. So that's why this inflammation is a most important mechanism for the development of OSA. Then second, another mechanism in bronchial asthma for development of OSA is non-anatomical causes like use of inhaled corticosteroid or oral corticosteroid. So these oral corticosteroid or inhaled corticosteroid leads to deposition of fat around the pharyngeal upper airway. So this anatomical cause also leads the for development of OSA. So these two anatomical and non-anatomical mechanisms are responsible for development of OSA in bronchial asthma patient. And another thing is in OSA patient, when patient developed a chronic intermittent hypoxia. So chronic intermittent hypoxia is a most important cause for switch over from TH2 inflammation to TH1 inflammation. So why the OSA with bronchial asthma patient are not responding to inhaled corticosteroid? That is a most important reason, because these patients are in, as we know that bronchial asthma, allergic bronchial asthma is TH2 inflammation. But in this, when the patient developed such mild kind of OSA, these switch over from TH2 to TH1. So that's why inhaled corticosteroid is not responsive to this patient, like in this our case. This patient is developed eosinophilic or allergic bronchial asthma. Eosinophil count was 700, IG was raised in this patient, but still development of bronchial asthma. This patient is not responding to inhaled corticosteroid. So these two mechanisms are very important, and chronic intermittent hypoxia in like OSA patient is most dangerous than persistent hypoxia. This leads to oxidative damage and oxidative stress. So this is a reasoning behind the development of OSA in bronchial asthma patients.
So as we have already discussed, the overlap of asthma and OSA is around 50% as per the variable. Basically, the prevalence is variable as per the studies available from the Western world. It varies from 5% to 50%, and the risk is documented is up to 2.6 times higher than the non-asthma patients. Also, as OSA prevalence is increased with asthma severity, and higher asthma severity is associated with worse sleep quality and daytime sleepiness. Coexistence of OSA and asthma is common, and it represents a bidirectional relationship between both due to coexistent rhinitis, GERD, and obesity, as rightly explained by Dr. Rishabh already. However, there is a growing body of evidence suggests patients with asthma treated with inhaled corticosteroids seem to have an increased risk of developing OSA mediated by an impact on upper airway collapsibility through direct muscle effects and fat redistribution to the neck. Pathophysiology is already covered in detail by ma'am, so I would just rather skip that. So to sum up, this entity should not be neglected, and we should rather subject the patient to sleep studies more frequently. Although there is no recommended guideline which level of sleep study is preferred, but in such patients, level 1 sleep study with a manual titration should be preferred, because sometimes when patient is having nocturnal hypoventilation, they tend to have worse desaturation and events during REM stage of sleep. So a titration study would be rather better. And if untreated, this overlap syndrome tends to have more complications, uncontrolled exacerbations, frequent exacerbations, uncontrolled asthma, as well as higher risk of developing pulmonary hypertension. So this is it. Thank you for today.
Thank you so much, Speaker and Chairpersons. May I please request our Chairperson, Dr. Jyoti Bajpayee, to give a memento to our Speaker, Dr. Khushbu Saxena now. May I please request Dr. Darshan Bajaj sir to come upon the stage to give mementos to. Would like to request sir to give the memento to Jyoti ma'am. जल्दी जाओ. Would like to request sir to give a memento to Dr. Arshad Ijazi sir. So please give a memento to Dr. Rishabh Kakar sir as well. Moving on to the last session for the evening. The next session will be on severe asthma with ABPA, which will be a case-based discussion as well. Will be taken up by Dr. Shubhkar Nadella sir and will be chaired by Dr. S.N. Gupta sir, Director, Senior Consultant Pulmonologist of Sanjeevani Hospital, Lucknow, Professor Alok Nath sir, Professor and Head Department of Pulmonary Medicine, SGPGI, Dr. Jugendra Singh sir, Senior Consultant Pulmonologist, Medanta Hospital, Lucknow, and Professor K.B. Gupta sir, Senior Consultant and Head, Pulmonary Medicine, Era Medical College, Lucknow, and Emeritus Professor, PGIMS, Rohtak. I request the chairpersons to please occupy their position on the dais, and I request them to please introduce the speaker for the session. I request the chairpersons to please introduce the speaker for the session.
So we begin with this last session for today's CME, severe asthma complicated with ABPA, a case-based discussion. So it will be taken by Dr. Subhakar Nadella. He's consultant pulmonologist at SGPGIMS, Hyderabad. So over to you, Dr. Subhakar.
Thank you, sir. First thing I would like to thank Alok Nath sir and everyone over here who molded me to the stage, and my seniors and all my friends who are gathered over here, and the expected dignitaries on the stage. I'll just start my topic directly. It's just a case-based scenarios. These are three real cases. For the first case, I'll give credit to the, Dr. Narendra sir. He's from NIMS. So the case goes like this. A 31-year-old male who came with complaints of shortness of breath from 10 days. He had cough since 1 week and streaky hemoptysis for 4 days. He had an history of asthma and allergic rhinitis for the past 10 years. Patient was using high-dose maintenance therapies of ICS and LABA, and he was also on leukotriene inhibitors. So he had previous histories of exacerbation and hospitalization 3 years back. There's no family history of asthma. On physical examination, he had polyphonic V's heard all over the lung fields, and saturation was 94% on room air. Patient's inhaler technique was proper, and he was compliant with the medicines. His asthma control, ACT score was around 10. So this was the X-ray which was seen in the OPD. So here, sir, can you just comment on the X-ray?
So this X-ray suggestive of left upper zone opacity, opacification, and mainly the extending the upper lobe, upper lobe bronchus. So this is mainly the opacification of the left upper zone in the X-ray.
Yes, sir, absolutely. There's an opacity in the left upper zone, which is homogeneous, as well as non-homogeneous opacity, which is seen in the right upper zone.
Yeah, there are some prominent markings could be seen in the right upper zone as well, which can actually represent bronchiectasis once you have given a background history of bronchial asthma and patient is a case of bronchial asthma with such kinds of opacity. If you see that X-ray very carefully, the upper lobes, the right upper lobe is also showing features suggestive of bronchiectasis, which needs to be confirmed on HRCT.
Yes, sir. Looking like tram tax.
The such opacity on chest X-ray should be assessed on the background history. The patient is having bronchial asthma and as per history and medications, uncontrolled asthma, and other patients, you can say, severe asthma.
Yes.
So such opacity may be because of the mucus infection in the major airways causing some distal pneumonitis, and also the mucus infection which has said out as the Dr. Lucknow has pointed out, that maybe some structure changes may have occurred, like the bronchus is also associated with that also. So mucus plugging, bronchiectasis, and you can say distal pneumonitis correspond to the obstruction. That's the second.
Yes, absolutely, sir. So, so this is CT, which we can see over here. So as all the panel members said, that we can see over here mucus plug-in seen over here as well as on the left side as well as on the right side. You see over there, I think the picture is not clear. Sir, to say it as ham, what features generally do we see, sir? So
you see, if you
yes, sir. That's the exact definition. So here we had a high attenuated mucus. So we did a laboratory test. So laboratory test shows aspergillus fumigated specific IgE around 47 kilo units per allergen per liter and total IgE of 3000 international units per ml. His absolute eosinophil count was 550 cells. Aspergillus specific IgG was 200 milligrams per allergen per liter. So with this, he was diagnosed as ABPA. And obviously, as the patient came in acute stage, this is acute stage with severe asthma. So what are the criteria to diagnose it as ABPA? So we all know that it's a Isham working group criteria. So we should have predisposing factors like cystic fibrosis or bronchial asthma with first two obligatory things, which are Aspergillus fumigated specific IgE should be more than 0.35 kilo units per allergen, and total IgE should be more than 500 international units per ml. Sir, here I would like to have your opinion, sir. Some place, in some guidelines it is written more than 1,000, and some the other place it is written more than 500 international units per ml. So what's it?
See, I would like to in the practice, what we are doing first, go and get the total IgE done. If it is more than 500, only then we advise the specific IgE and IgE against the that is very fast. But here, I think the guidelines also for suspecting the ABPA. You should go and get the IgE done for the SPS indicator. If it is more than that, then you go for the total IgE as parameter is from here more than 500 on the IgE. So I would like to have the comment of
the first investigation whenever you are evaluating a case of bronchial asthma and suspecting ABPA should be Aspergillus specific IgE. And that is the screening tool, that is the screening investigation of choice for screening of patients with bronchial asthma who are suspected to have ABPA. If they exceed the cutoff, 0.35 is the cutoff for positive and negative, then you should proceed with the total IgE. And if the total IgE is more than 500, the revised ISHM criteria was proposed in the previous paper. However, the new ISHM criteria is in the process of publication, and it has been accepted in European Respiratory Journal yesterday itself. And now we have finalized this with experts all over the world that the total IgE levels of more than 500 will be diagnostic of ABPA. Reason being that a large body of evidence and a very good quality evidence is there to support this proposal, that it increases the sensitivity and specificity for the diagnosis of ABPA to more than 90%. So this is the investigation of choice. And rest of the ancillary criterias, which I think Shubhakar will elaborate later on. But the main question of screening a patient of bronchial asthma for presence of Aspergillus hypersensitivity, specific IgE is the investigation of choice. 0.35. Yeah. Significance. Yes, if specific IgE is positive and total IgE is less than 500, then patient has got Aspergillus fumigatus sensitive asthma or ABPA serologic in absence of bronchiectasis. However, if there is bronchiectasis and ABP and total IgE is still less than 500, then this patient may be ABPA if other criteria are met, but he is not in acute phase.
Actually, the total IgE level is also necessary as a baseline investigation in view of the response, in view of the prognosis. When we are using the steroids or other drugs to control the asthma, so we monitor the response with the total IgE level. And it is within 8 weeks of the corticosteroid therapy, more than 25% drop in the total IgE level also, and with the complete response or remission, it is more than 50% of the reduction in the total IgE level.
Assess the activity and assess the activity of disease.
Yes. And when we see the reduction or because in the acceleration, then more than 50% of the baseline ID will come. And second, when we move on the biologicals, then ID sometimes will be more
IG would have very simple and step or parameter to assess the monitoring and follow patient apart from the guidance.
Absolutely, sir. Just to summarize what all the panelists have just said, as well as specific IgE levels, they are more like for diagnosis and just to in a smaller way. And total IgE levels, it will be more helpful for our monitoring the treatment as well as the prognosis. So just a few lines on pathogenesis. Not all the asthmatic patients develop ABPA, even though they dwell at the same space. It is mostly it is believed that there are two important factors which causes this ABPA. One is persistence of fungi in the airways, which should be there, which we generally see in asthma patients because of impaired mucociliary clearance. The other thing is skewed hyperimmune Th2 response. So generally, whenever the fungus lodges in our airways, we see Th1 response, it eliminates the fungus. Whereas in case of ABPA patients, there will be a skewed Th2 response, which leads to, it does not eliminate the fungus, whereas in other way, it generates intense inflammatory reactions, characterized by mast cells, degranulations, and influx of large number of eosinophils, neutrophils, the release of IL-4, IL-5, IL-13, IL-19, etc. These markers are important because these are the markers of importance for the future studies, and we may get some biologicals maybe in future. So this is a summary of the about before 2 slides. We see over here degradation of mast cells and which causes airway inflammation as well as bronchiectasis. So the patient was started on oral glucocorticoids, 0.75 milligrams per kg per day for 6 weeks, and then tapered to 0.5 milligrams per kg per day in the next 6 weeks. During the whole course, he was maintained on high doses of ICS and LABA. After 12 weeks, the patient improved clinically with radiological persistent opacities and decreased serum levels were seen. It was 1,570. Initially, it was 3,000. Now it was 1,570. Spirometry was not done in the first visit because of hemoptysis. In the second visit, it showed moderate airway obstruction with bronchodilators. With this serological and lung functions, these corticosteroids were tapered with 5 milligrams every 2 weeks and stopped over 3 months. Sir, any comment on this treatment protocol? Can we change anything or is this fine?
And second is the 0.5 for the 6 weeks. Now, advantage is just on both the so when you start with low dosing for this plant, the response rate, recurrence rate are more as when you start the high dose. High dose, the leads the monitoring of the adverse effect also. That is the thing. And the second part which we are that our aim of therapy, of course, we are monitoring by the IgP, but ideally this is not only goal of the treatment. The ideal result should be seen in view of the intersymptomatic
Yes.
Regarding the dose of corticosteroids in ABPA, as sir rightly said, that there are 2 protocols, either the high dose protocol and the low dose protocol. I'd just like to add in the information that when there was a head-to-head comparison of the high dose versus low dose, and there are a number of studies which have evaluated or kind of addressed this question, the rate of recurrence or the rate of relapse, the rate of remission, and the control of symptoms. Both were equal in both the groups. However, some increase in Cushingoid habitus and some adverse effect which were not dose limiting.
Yes.
Or drug modifying side effects were seen slightly higher in the higher dose group. So it's up to the patient, individual's perception about the acuity of symptoms or the severity of presentation, which a person can opt with a higher dose and can taper it early. It's not written in Bible or it's not written in Ramayana or Gita that you have to stick to a high dose protocol till 6 weeks. You can individually tailor-made your therapy and fit it to the patient's response. And just go back to the previous slide. Previous one. Yes, this the total IgE of 500. I just wanted to add upon that 500 is the current recommendation by ISHAM working group. However, in our part of country, it has got some limitations because the baseline IgE levels in general population is not known, and we see lot of patients who do not have any history of not even asthma also. They are being investigated for other reasons and they have Ig levels more than 500. So a person's baseline is more important as compared to this, and this classification, radiological classification, has also changed now. So it has come to ABPA B, ABPA S, ABPA mucus plugging, and ABPA chronic pulmonary fibrosis. So now we have 4 groups only.
No, sir, Alok sir, I want to add something. Whenever we are using the corticosteroids in the relapsed patient, the dose is not fixed actually. At that point of time, we need to consider the side effects of the steroid therapy, and at that point of time, we consider the fluconazole, the itraconazole therapy, mainly itraconazole therapy. At that point of time, the steroid dose is less because the itraconazole itself prevents the fungal colonization, as well as the it reduce the bronchodilators in the inhaled corticosteroids, as well as the oral or IV corticosteroid dose.
We have a case, sir, regarding the same thing. We'll just call it in the coming few slides. So this is the X-ray where we can, after 5 months, we can see the resolution of the lesion. Of course, it's not complete, but still significant. So this was the CT. The one on your left is the first one, and the one on your right is a CT after 5 months. We can see here clearing of the mucus plugging, with which the 60 lesions can be easily noted over here. So in the next visit, he came after 3 months. He was asymptomatic. His serum total Ig levels were 990, and along with radiological improvement. Spirometry was fairly improved than the previous visit, and so he was maintained on the high dose ICS LAMA, and he was advised to follow up. So the next episode came after 3 months, where he came with complaints of shortness of breath, rhonchi, and cough for 1 week. We could hear polyphonic V's in all his lung areas. His chest X-ray showed non-homogeneous opacity in the left upper zone, but it was, as we all know, we have seen the previous X-ray, it was better than the previous X-ray. And his serum total Ig levels were 1005 international units per ml. I just asked the panelists, so what next to be done? So this is the X-ray list.
So IG alone is not sufficient. Again, investigate the patient for the external also.
Clinically compatible manifestations, along with at least 50% rise in IgE levels, qualifies for an exacerbation of ABPA. So there was only a marginal rise of IgE in this case, and patient has worsened symptomatically. So this patient should be evaluated whether he has exacerbation of bronchial asthma, concurrent infection, or he is going into an exacerbation of ABPA, which may be evolving actually.
So, sir, infection was ruled out. His blood parameters was normal. So he was given a short course of oral steroids for the 7 days, with which he got improved absolutely. He was followed up for the next week also. He was symptomatically stable. So he was just sent again on ICS and LABA without adding any long-term steroids or azoles. So after 6 months, he came for regular follow-up. The patient was symptomatically stable, but at this point, his total Ig levels were 2,500. His previous levels were 1,000, 1,005. So a CT scan was advised. So these are CT scan. The one onto your right is a latest CT scan. This is the one. The one onto the left is the previous CT scan. So what's your take on this? So what next we can do?
This is an exacerbation. So now the IgE values have doubled. There is
He's symptomatically stable, sir. He is not having any respiratory symptoms.
okay, symptomatic. He has symptomatically stable. Okay.
And
But
the CT also, the left, I mean, the one on the left is the new one, sir. Right is the older one.
right.
So radiological resolution, yeah, these are old.
There is no new opacity. I thought that was
Yes, sir.
the new one. That one is the
No, actually, the only one cut, sir. So actually, these cuts are not. Just only these cuts are there.
okay. So I mean that upper lobe opacity was there in earlier scan?
Yes, sir.
It was there. So okay. So I mean, if
The first scan we had that upper lobe.
if only the IgE has raised and the patient is symptomatically stable, we have to follow up this patient closely. He might land up with an exacerbation later. But at present, if he's symptomatically stable, he only needs monitoring.
Yes. So he was again just sent on ICS and LABA and he was monitored closely. As sir said, absolutely. After 4 months, he came back with severe shortness of breath, dry cough, and bronchi for 3 weeks. By this time, he got enough knowledge that he started using oral steroids by himself. So he tried it for 1 week at his home with only partial relief, and he came to us. So at this time, his saturations were 88%, and his serum total Ig was 4,050. The previous one was 2,500. So we can label it as exacerbation after remission. So we call it as remission because his first symptoms were 13 months prior to this. So he had a symptom-free period for 6 months, more than 6 months. So just to summarize it up, as so,
just interrupt here, Shubhakar, that in your patient follow-up scan after 5 months,
yes,
the patient has, although patient has improved, his IgE levels had come down to 1,570, but the kind of lesion which was seen in the left lower lobe, this is not a usual way of resolution of a mucus plug. In this patient with such a ragged wall cavitating lesion forming while the patient is on corticosteroids, at this point of time only, this patient should be investigated for fungal colonization. If at this point of time he's bringing out sputum, it's fine. Otherwise, I would go ahead with the bronchial lavage in this patient at here itself. And if he grows fungus in this, then he's a case addition of azoles at this point of time itself to prevent further exacerbation, because this is not the usual way of resolution of a mucus plug in a patient with ABPA. And after 4 months of good amount of corticosteroid, everything vanishes. If it is a pure ABPA, it vanishes. He might be progressing to CPA actually, which we have actually missed, or maybe we have overlooked because of the symptomatic improvement of the patient.
Definitely, sir. No bronchoscopy, nothing was done at that time. As the sir was also sharing Isham classification, we have 0 to 6. So 0 is asymptomatic, 1 is acute, and 2 is response, 3 is exacerbation, 4 is remission, 5 is treatment ABPA, 5A, 5B, glucocorticoid dependent ABPA, and advanced ABPA. So this was the thing which sir was saying. Chronic, I mean, pleuroparenchymal fibrosis we see in stage 6. So just to summarize, when the patient comes in acute phase for the first time, we generally can give oral corticosteroids, as I said, either 4 months, or we can taper it based on the signs and symptoms of the patient. So in the follow-up visits, we have to look into X-rays, spirometry, total Ig levels. Basing on that, we'll be knowing it whether the patient is going into response phase or exacerbation phase. If the patient is asymptomatic for 6 months, then we call it as remission phase. So that is stage 4. So if the patient gets exacerbation, for the first exacerbation, we have to again try with glucocorticoids. For the second exacerbation, we have to go ahead with glucocorticoids as well as azoles. So for recurrent exacerbation, the strategy should be changed. There we have to use, sometimes we have to use pulse therapies or nebulized amphotericin based biologicals, etc., anti-TH2 therapies. So here for our case, we just started on 0.5 mg per kg per day for 4 weeks and then tapered it 0.25 mg, 0.125 mg. And at the same time, itraconazole was added, 20 milligrams BD. But unfortunately, after 3 weeks of starting itraconazole, the patient developed skin itching, blurred visions, mood changes. All these things can be seen in steroids also. But however, after consulting with the dermatologist and ophthalmologist, the team decided to stop the azoles because he was already given steroid treatment and he was asymptomatic in the previous episodes. So after stopping azoles, all these symptoms got reversed. So, and then to compensate it, he was started on omalizumab. So he was started with 375 milligrams subcutaneously for 2 weeks for 6 months. After 6 months, his serum Ig levels came back to 1050 and he was asymptomatic in the whole period. After 6 months, unfortunately, because of his financial constraints, he was lost to follow up for further omalizumab therapy. Sir, in this case, would you like to add anything or would you have done anything separately or change the regimens?
Skin itching and all kind of that. So it's better to avoid on that side. The next step of the idea can start. I think that.
So any role of mepolizumab and any other biologicals in this? Any experience?
The data about use of biological therapy in ABPA is sparse. Even for use of omalizumab, there is not a large body of evidence is available. The treatment is usually used on compassionate grounds. And regarding other biologicals, I mean, mepolizumab, etc., it is even less. So the data regarding use of biologics in ABPA is still evolving. However, there is role of biologics in patients who are unable to tolerate corticosteroids, do have major adverse effects with corticosteroids or with azoles, because now prednisolone, that is glucocorticoids, and azoles, both share the first line therapy status for the treatment of or management of ABPA. Either of them can be started as a first line therapy. If they are unresponsive to it, have major adverse effect to it, or they become refractory to the treatment, then only biologics have to be taken up.
Yes. So coming to the second case, actually, I'll just wind it up. What Sir said, just to summarize it, the patient had issue with the steroids. So here, the second line therapy directly started with the azoles. So, and it worked for the patient. Thank you. Yeah. I think all of you are summarized. So that's all.
नहीं summarize कर दो. अच्छा final diagnosis, differential diagnosis.
Yeah, short case was important.
ये वाला पता है.
ये वाला yes.
He had to tell him about everything. बता रहे हैं. हाँ, finish up.
Just the last one. This case is just to show the importance of not all cases are asthma. 24 years old female who came with complaints of shortness of breath, wheeze, expectoration for 2 years. She got treated with tuberculosis 2 years back with ADT. She was absolutely fine before that. After that, she started all these symptoms. So she was given oral steroids also 4 times in the past 2 years. So with this background, she was being labeled as asthma wherever she went. So for which the workup has been done. So where we can see the raised IG levels, as we just humidity, specific IG levels were raised, total IG levels was raised, and specific IgG levels were also raised. and eosinophil counts were 509. So the chest X-ray was done, which showed non-homogeneous opacity in the right lower zone. This was the spirometry which gave the clue. If you see the first loop, if you see the expiratory curve, so we see the flattening over here. So this was seen in 2 spirometries done with 2 different physicians, 2 different pulmonologists at 2 different places, and it was the same. So then a CT scan was done for the patient. This was the CT. So some nodule over here in the upper lobe. See the lower part of the trachea. It is narrowed and you see the opening of the right main bronchus. And again, from here, it is fine. And this was the thing you see over there. A lesion in the right lower lobe. Pleuroparenchymal fibrosis or whatever. What if it's a bronchial asthma case with these things? So we'll be labeling it as Isham stage 6. So pleuroparenchymal fibrosis, etc. So when we did a bronchoscopy for this patient, so this is the finding. The therapeutic scope could not be passed beyond this thing. Thin scope was passed beyond these things. So she was dilated twice. After dilating, we just put the stent. Her asthma was gone the next moment when she wake up from the anesthesia. So do we call it as an ABPA? Do you call it as a severe asthma? No. So I just put this video because this was my first case after me going from SGPGI, where I did sole, as a single person without Dr. Ajmal Khan sir's help, stenting and everything. So I just kept this case because whenever you get any patient with severe asthma, untreated asthma, don't just think that it is ABPA or asthma. Just look into the other differentials, whether is it a asthma at the first place or not. So reevaluate yourself, and then when everything fits into it, then you label it as severe asthma, ABPA, etc. Post endobronchial tuberculosis, sir, it was missed. Lower consolidation, it was in the previous CT, it was there. It was a pleuroparenchymal fibrosis. Which one, sir? Biopsy was not done. No. Because there's no, Yes, sir. Actually, that lesion was in the previous CT also, sir. But this part was not there. We never had bronchoscopy done in the during the course of while she was on ATT or in the 2 years. So endobronchial picture, it was not available. But the lesion in the right lower lobe, it was very large prior to that. In the first CT where she showed me, it was involving complete right lower lobe. So the size of it got decreased. Further in this thing, gene expert and everything came out to be negative, and fungal colonization was seen. There was narrowing, sir. There was no thickening. So at this place. Actually, subcarinal lesion EBUS was done prior to the patient which was sent to me. So it got to be reactive lymphadenitis. But still that was not, because she was not having active, she was not having fever or anything at the time of presentation. Hmm. Hmm. Yes, sir. Yes, sir. Hmm.
There was no tracheal infiltration.
Huh.
Tracheal morphology was almost
Normal.
preserved or
Hmm.
normal. It's interesting. I think we should further evaluate more.
We've had cases of fungal, since your fungal serology was positive, we've had cases of fibrosing mediastinitis also due to fungal infection. So you don't even know, maybe it could be part of all fungal sensitization. So I think biopsy from the cranial lymph node would be the first thing to do.
The differential diagnosis of this EDPA, tropical pulmonary eosinophil is normally not negative because the eosinophil level highest is less than 2000. And in tropical pulmonary eosinophil is diagnosed when it is more than 2000. Normally it is not. We exclude by taking the patient with eosinophil levels more than 2000. At that moment, we are actually excluding all these differential diagnoses. Of,
Subhakar, for a very nice presentation and a very interesting case in the end, actually.
Thank you, Speaker and Chairperson. It was actually a very intriguing session. And I would like Professor K.B. Gupta, sir, to please give the memento to our speaker. Amen. May I now request Aloknath, sir, to please give a memento to our chairpersons, Dr. S.N. Gupta, sir. So please give a memento to Dr. Jugendra Singh, sir. मैं बुलाऊंगा With this, we conclude our scientific sessions. We extend our gratitude to all delegates for their engagement and attentive listening. Before closing the program, we would like to announce the result of the PG quiz. I would like to invite our head, Dr. Aloknath, sir, our organizing secretary, Dr. Mansi, ma'am, and Ajmal Khan, sir, to please come on the stage to announce the winners for the quiz. I would also like to invite our quiz master, who was very enthusiastic while organizing the quiz, to please announce the result.
Just one thing before announcing the results. Someone mentioned his name as anonymous. So unfortunately or unfortunately, I recognize the handwriting. So, but I'll not divulge the name because there is something associated with anonymous. So let's see what it is.
So it's time for the result. So the first prize goes to Dr. Rixam, third year DM fellow SGPGI. He receives a cash prize of rupees 5,000, which he's not going home with today. A huge round of applause for him.
Right. None of the fellows knew any of the questions. Yeah.
The second prize for the quiz goes to Dr. Sumit, second year DM fellow from our institute as well.
And just to add our doctor anonymous.
Big round of applause for him as well.
For the third prize, it was actually a four-way tie. Even after taking into consideration how many negatives there were, we could not break the tie. So there are 4 people who have tied for the 3rd spot. So Dr. Ajit, second year DM fellow, SGPGIMS. Right. So Dr. Yash, Dr. Anushka Verma, and Dr. Rabia. Please come on the dais, please.
These two are from which college? So first and second prize, they have come back to SGPG. I'm interested to know the names and, where are you from? GSVM Kanpur. A big round of applause. And Dr. Rabia is from Era Medical College. And the quiz level was not for the MD students. So these are the two really deserving winners. They are doing their post graduation right now. So I think it's a huge round of applause for these two girls.
I would request Loknath sir and Ajmal sir to stay on the stage to please give a memento to our organizing secretary, who was the only one who was involved so actively in the. She was the driving force of the conference actually. So we need to give her a memento right now. A huge round of applause for her. And we would also. We would also like to, sir, to please give a memento to Atul sir for his efforts towards the conference.
I thank all of you to be present here till the end of the show, and you guys have made it really special for us today. Thank you all the senior people, my friends, my juniors. And I have forgotten to take the name of two very important people who were the masters of the ceremony today, Dr. Nandini Dikshit and Dr. Sumit Dey. A round of applause for them also. Thank you, and you can enjoy your evening with us. All of you are welcome for the gala dinner in the evening with your family, which is in the Hobby Center launch. Thank you. Oh, okay.